All right, we're going to go ahead and get started with the KanCare Oversight Committee, and the two topics that we're interested in covering today. We're not going through a full-blown like we normally do. KanCare Oversight will be the discussion of integrated care, which we'll talk about this morning. This came about during the mental health modernization committee that's been meeting. There was a lot of discussion of how that integrates, and so as the chair of that committee, I decided it was probably a good idea to start having some discussions with our MCOs, because they're one of our largest health insurance providers out there, next to probably Blue Cross and Blue Shield, and I think maybe Ascension would be the other one. So that we can start figuring out, okay, how does that work together? Because many times we separate the mental health from the physical health, and the two many times we really need to go hand in hand. So that's what we're going to start on our day this morning. This afternoon we will have discussions on our long-term care facilities and the concerns and issues that we're facing out there. So first up, on an overview of the all-inclusive care for the elderly, I'll welcome John Sullivan, President and Chief Executive Officer of Midland Care Connections. Welcome to committee, Sean. And if you feel comfortable taking off your mask, you're welcome to do so, but not mandatory.
Thank you. Good morning, Madam Chair, members of the committee. Thank you for the opportunity to talk this morning. So PACE stands for the Program for All-Inclusive Care of the Elderly. It is an integrated care model. We do a lot of the things that the chair mentioned that are concerns, and just thought it'd be a good opportunity to provide an overview of the program and some of the challenges and barriers that we face and a few recommendations. So it's a pleasure to be with you here this morning. This actually was the first comprehensive managed care system in the state of Kansas, and a precursor to the KanCare MCOs, and one that's a great model. So organization that I'm with is called Midland Care. We're based here in Topeka, and we do several different things. We have PACE centers and provide PACE services in Topeka, Lawrence, Emporia, and Kansas City areas, and then also provide hospice, home health, Meals on Wheels, and several other things to 21 counties in Northeast Kansas. So our model is to try to keep people at home as long as possible, and to provide holistic integrated care to do that and to achieve that, and that's what PACE is about. So why talk about PACE would be the first question that I'll try to answer. And I think that the healthcare system was already moving towards trying to keep people at home as long as possible, and to stay independent as long as possible, and healthy as long as possible, now the highest cost settings. That's certainly the way the reimbursement world has been moving for several years. But I think that the impact of COVID, to be honest, is only going to and only has accelerated this impact. So there's nationally, not talking about here in Kansas, but nationally, there's about 100,000 fewer people living in nursing homes now than there was in March before the pandemic started. And there is going to be a need, due to the impact that COVID's had on long-term care facilities, to think about and to ensure that we have a more robust set of community-based services and home-based services to keep people healthy at home and independent. Either because I think there will be more than there is now lack of access to nursing homes in some areas of state, and that goes along with what many people's choice would be to stay at home. And then secondly, why talk about PACE is this as a program is one that is growing across the country, and here in Kansas, it's one that has good outcomes on a number of fronts, and also one that saves money, Medicaid and Medicare money. So I know that that's something everybody always comes in and says, that, hey, our program, you invest in it, you'll save the state and federal government money, save society money. But for PACE, I can say that actually is true, and the model is set up to do that. So I provided in your packets, or hopefully what you all have as handouts, an infographic that came from our national association that says PACE by the numbers on the front and PACE value on the back of it. Glossy, nice infographic. For those that are online or watching it by virtually, we weren't able to actually provide that, but did provide a copy paper for you, or handout for you. So the people, first of all, people that are eligible for PACE, you have to be 55 or older, live in a PACE service area that the state and federal government recognize as being served by PACE, and certified to need a nursing home level type of care. So we are not taking care of PACE programs, do not take care of independent people that do not need nursing home care. You have to functionally be able to be certified to live in a nursing home, and that's an assessment process that's done by the state of Kansas and by all states. And then fourthly, you have to be able to live safely in the community with PACE support and the different things that PACE does when at the time of enrollment into PACE. So those are the four things: age 55 and older, live in the PACE area, that services are provided by PACE, certified to need nursing home level care services, and then be able to live safely in the community with PACE support when enrolled into the program. The model is set financially and programmatically to keep people at home. So in the places where our organization provides PACE, in Topeka, Lawrence, Emporia, and Kansas City, and those surrounding areas, we have PACE centers, what we call PACE centers. And what happens in those PACE centers is they're essentially adult day centers or adult day sites where we have staff and provide transportation for what we call our PACE participants to come into the adult day centers and receive their services that they need there on a daily basis. And then we also have medical clinics that we provide there that have physicians, ANRPs, other disciplines that see our participants as they need to, and to help them with their medical needs and help them stay healthy and try to provide preventative care and get out in front of whatever their needs may be to keep them, again, the concept to keep them healthy at home and independent. We are fully financially at risk for all in-person services. So this is a concept similar to what is there for the KanCare managed care organizations for our seniors in Kansas. So we are responsible for all a person's care that's in the program, whether that is to provide home care services at their home, whether it's to pay for or provide all their medications, to provide for their primary care, for their specialty care. If they have to go into a hospital for whatever reason, we pay for that. If they have to go into a nursing home, which only 5% of our clients do, we pay for that as well. So this is financially aligned for us and incentivizes us, and how we make it work financially for us is to keep that person at home healthy and independent and coming into our day centers and coming into our clinics and being treated holistically. We provide the adult day center, clinic services, medical care, home health, medications, social services, medical specialties, and then hospital and nursing facility care if we need it, if they need it. The history of PACE, as this goes back to the 1970s, there was a Chinese community in the San Francisco area that was looking for alternatives to nursing homes and how to keep their parents and seniors at home longer. And they established this PACE type model in their area to do that, and tested a new finance system with the federal government where the programs are paid per member per month or capitation rates, similar to what we all do now with managed care companies, to keep that person healthy and at home. And then years later, the late 90s, Congress established PACE as a permanent provider under the Medicaid and Medicare program. It's a program that's grown significantly. In the late 90s, there were only about 30 PACE programs in 19 states. And today there's 31 states, including Kansas, that have PACE, and about 130 or so organizations that provide it. The history of PACE in Kansas is that it started in 2002 through Via Christi, or what's now Ascension in Wichita. It started actually in that strip mall over on Pawnee on the east side of town, and then later moved over to the old Riverside Hospital, and started that almost 20 years ago now. Midland, who I'm with now, started PACE in 2007. And then the next kind of marker of the program was in 2012 or 13 when KanCare was being designed and developed and implemented. Those of us that were working at the time that were with the state were thinking about the PACE program and how it would work along or with KanCare and the Medicaid managed care program. And we couldn't figure out a way to make it work to where PACE or PACE clients would be in the Medicaid managed care or KanCare program. So we essentially carved it out and made it a separate enrollment option. So anyone that is in PACE is not enrolled into KanCare. Essentially because we provide the same set of services, we're paid the capitated rate and are fully financially at risk for all the personal services. Until that time, until KanCare was started in Kansas, there was a cap on enrollment for PACE, and it was a very, very small program, only about 100 or 120 or so people. Because of the way that the rates in the PACE program works, and because of the way that the rates were set for the 3 KanCare companies 8 years ago, and PACE essentially being a cheaper option, we took the the state took the enrollment cap off of PACE and allowed it to grow and not have that through that process. So that allowed greater growth through the program. And also KDADS at the time put an RFP out to grow the program in 2013 and then awarded several new market areas and what we call PACE service areas across the state. Midland Care was allowed to expand to contiguous areas and also given the Kansas City and Douglas County markets. Via Christie and Wichita was giving areas and market areas, counties around Wichita and Sedgwick County, and also were awarded Southeast Kansas with Pittsburgh and then up north to Johnson County. That fell through a year or two after that with the Via Christie sale to Ascension, and those markets are still unserved through PACE. And then there was a third provider that was awarded a contract through the state and CMS that's now called Blue Stem PACE, and that's a senior living organization in the Newton, Heston, McPherson area that established a new PACE program there in McPherson and then recently opened one in Hutch. And their aim is to go north of there to Salina and then over to through Abilene, Junction City, and Manhattan in the next year or two. And then recently, the last year or two, there's been a large push across the country to grow PACE, and there were a couple of foundations that funded what they call, or what we call, a PACE 2.0 initiative. And the aim of that is to take PACE nationally from about 55,000 people that is served by the program to about a couple 100,000 over the next 6 or 8 years, and to do that by a number of initiatives and reducing barriers to the program. So that's something that we are involved with, those foundations, and looking to grow our program significantly, especially in the Kansas City northeast corner of the state. On that infographic that's what's in your handout, it does provide a little bit more information as to what PACE is and what the model is, who's enrolled, who's eligible, who does this, as well as the outcomes. If you look at the back page of it, it does provide good information on what the outcomes are of the program, which I think is important, or we think is important. The first thing under the PACE value side of that handout is that PACE saves taxpayer dollars. States pay on average PACE programs 13% less than the cost of other Medicaid services. So how the financial or rates for this program is set is the state and federal government do an actuarial study to look at the cost of caring for a person that's not in PACE, whether that be through nursing homes or the HCBS program or other Medicaid managed care type services. And they set what's called upper payment limit, and then they provide a discount, a negotiated discount with PACE programs or with us that generally is 10 to 15% less than what it costs to take care of someone in other Medicaid services. So it is a program that is financially designed to save the state money anywhere from 10 to 15% less than what they'd be paying otherwise. And the way we again make that work, not to sound like broken records, we keep the person healthy at home, independent, providing preventative care, and are financially fully at risk for all the person's services. The outcomes that are achieved through the way this is designed are also on that handout. Our participants see less than 1 ER visit per year. We have 24% lower hospitalization rate than Medicare, Medicaid beneficiaries that are in alternative type services. We have a decreased rehospitalization rate, fewer nursing home admissions. Only about 5% of our clients live in a nursing home. Again, we pay for it if that person needs to be there to be safe, but we're incentivized to not have that happen. Even though all 100% of our clients, participants need a nursing home level of care. Only about 5% end up living in a nursing home from every day. And then you'll see other numbers and outcomes there. So to close this and then go through a few recommendations that are in my testimony, and these come from the 3 PACE programs in Kansas. Those recommendations, not just from Midland Care we're going with. There is a huge opportunity, I think a huge need to grow programs like PACE that provide services to high cost, high need individuals to help them stay at home. I think COVID has again accelerated the need to do that, to provide alternatives to facility or congregate level based care. And this is a program that we would like to see grow significantly. So we've listed, as we've thought through this, there are a couple of things that we see as creating barriers that either are internal things that we're working through with various people across the country and here in Kansas, and then a couple of public policy related items. So the first is this concept of the protected income limit. And I know if I were all in your shoes, I'd be thinking, didn't we address with this or deal with this a year or two ago and spend some money on this? And yes, we did, and we're very thankful for that. So the protected income limit used to be $717, is that right? I always get the number, $747 a month. So anyone on Medicaid that needed long-term care services or supports that had a monthly income amount through whatever that was above that amount would have to pay an obligation to their HCBS provider or PACE program above that protected income limit. And then the state would deduct that same amount from our rates. Raising it from $747 to $1177 a month about a little over a year ago made a significant impact in the quality of those persons' lives and reduce that barrier into PACE and HCBS, but we still do see it as a barrier even where it is now. So the current level at 1117 is at 150% of SSI. Most states put the protected income limit at 300%, which would be around 2,300 or so. And the reason this is a barrier for us as PACE programs, and just we looked at our numbers and our data, and even as a small program that only serves around 750 people through PACE, there were 120 people in the last year that did not enroll into PACE because of that income limit. So the reason that's important is there's a difference of about $22,000 a year for the cost that it takes to take care of a person in a nursing home, for what nursing homes get paid at $197 a day through Medicaid on average, and the cost that PACE programs get paid. There's about a $22,000 delta between the two. So of those 120 or so people that did not enroll into PACE over the last year because of that obligation they would have to pay, and that they needed to pay for utilities, rent, housing, the things that we don't provide as far as PACE, it only would have taken 25 of those to be into PACE or be enrolled into PACE for the state to cover that cost or that investment to raise the protected income limit for PACE because of that $22,000 difference. So collectively, the obligation that our clients across the state pay into PACE is about $580,000. So that's what the cost would be for PACE to increase that to about 300% of SSI. If also including HCBS into that program, for the 6 or 7 different HCBS waivers, it would go from 580 to about $4 million of cost to the state. But it is something that, again, we see as a barrier and wanted to highlight. The second thing are rates, and I know this is something everybody talks about, but I want to highlight from this, not necessarily from the rates that we get, but from the methodology of how rates are set in that perspective. So when KanCare was designed in 11, 12, and 13 and set and started in January of 13, the design, and still is this way, intent is for PACE to be a fourth option to the 3 KanCare MCOs for those that live in a PACE area, are 55 and older, and need a nursing home level of care. They can either enroll into PACE or be enrolled into one of the 3 KanCare MCOs. So we want to viably be seen as a fourth option, and that includes everything from how it's presented as an option to people that are eligible for it when they go through that process and are being presented what their choices are, for what their needs are and that assessment, how those assessments are done, to even how the rate process is done. So the MCOs have a rate study that's done by KHE twice a year. It's updated biannually twice a year. And the rates are negotiated and then loaded in through the consensus caseload process. That's done, updated twice a year by the state agencies based on what those utilizations of cost are for the 3 MCOs. The way it's done for PACE, there's a requirement federally by CMS that there has to be an actuarial study done every 3 years for the state's PACE program. So our state looks at every 3 years the cost to care for people outside the PACE program, and that rate study and those costs are determined and calculated, and then they negotiate and set with us essentially the rates or cost of state that's 10 to 15% less than that. So for us, it's done every 3 years. So then what happens is our rates go like this, they stay flat, and every 3 years they go up, where we like to see, again, a process more on par with how the KanCare MCOs are done, where at least, even if the rates aren't updated or increased, at least our rate study is updated annually, similar to how the KanCare MCOs are done. And then the third thing that you'll see on my testimony is, it gets pretty far into the weeds, but is related to the consensus caseload process. So most people hear about one that I'm all too familiar with, revenue tax collection, consider the caseloads that are done in April, November, and participated in them for many years. As you all know from your committee and those of you sit on appropriations or social services committees, there's also a human services caseloads process. KDADS, KDG, DCF, corrections all come twice a year into the smoke-filled room and then work with the budget office and KLRD to update the consensus caseloads for human services and then present those to the governor and then work through the process. PACE used to be all in the consensus caseloads prior to the cap being taken off in 2013. Right now, the only part of PACE expenditures that are in caseloads are our medical costs that we pay through hospitals or inpatient costs, ER visits, whatever those may be. The other things that we pay for, like nursing facility costs or other things that are part of caseloads through the KanCare companies, are not for PACE, part of the consensus caseload process. So, and we'd like to be put on par as an equivalent fourth option to the 3 KanCare companies, and like for the process that the state recognizes to be equivalent to how KanCare works. So that is something that could be done through just a proviso through the appropriations budget process. It's not something where legislation would be required, and not something that costs the state money. So those are the 3 things as we've talked about in this PACE programs are state policy, legislative type things that we would advocate for. And then there's a number of things that we're working on with our state agencies about how PACE is presented to people that may benefit from it, what written materials are there, are presented to people that would benefit from PACE. We're thinking about how individuals are enrolled into PACE, because right now that sometimes can take 45 to 60 days where they give us a call or they give the state a call and say, I'd like to learn about PACE. It can often take 45 to 60 days before they're enrolled into PACE because of the different assessment processes and all the things that go into that. Many other states allow for enrollment mid-month instead of just on the first of each month. So that's something that we'd like for our state agencies to consider and have discussions with us, and we will do that. And then also some what we feel are roadblocks that are there that we're trying to eliminate. So that's the first thing internally with agencies. It's not a legislative item. And also we'd like to see, which is big to us, additional markets served by PACE. So right now there's about 50% of people that are eligible in Kansas, 55 and older, nursing home eligible, that live in a PACE service area. There's about 15,000 people that we consider PACE eligible in Kansas. Only 50% of those live in a market that's served by PACE. and we would like to see that grow. So to Johnson County, Southeast Kansas, becomes more difficult because of the volume that PACE programs need to do it in more rural areas, but there are some ways that we can have discussions with the state and CMS to allow us to do that, and we'd like to do that as well eventually. So thank you for sticking with me and listening to me peddle the PACE program, but it is something that I think can be a valuable tool for the state and for your all's constituents around the state as a tool to keep people at home, healthy and independent. And I put my phone number and email address in the testimony if there's anything I can do to provide assistance and answer questions about the program. And then Tom Burgess also helps us out with government affairs, and he's going around on a daily basis here and can answer questions and provide assistance to them. So, Madam Chair, I can answer any questions that are.
Thank you, Sean. Are there questions for Sean Sullivan, Senator Hildebrand, or is that Representative Hildebrand? We're confused today.
Madam Chair, whatever you call me is fine.
Thank you, sir.
It's your
Just
show.
call you. Just make sure we call
Just
you.
call me. Sean, thank you for that testimony. A couple of questions for you. You gave PACE numbers nationally. You haven't had, since you're in Northeast Kansas, do you have the numbers at savings for Kansas in the Northeast part? Do you have historical data for that?
So it's essentially 10% savings from the Medicaid program. If PACE were not here, the state of Kansas would be paying 10% more for the people that we care for the 750 people in Kansas that are on PACE. And that's a byproduct of how rates are set between KHG, KDADS, and us, and those rate studies that I mentioned that are updated every couple of years. So I'd be happy to pencil out the actual dollars of what that looks like and send that to you all.
I was interested to see.
It's approximately 10%.
No, just to follow up on me, Madam Chair, is you had mentioned something about wanting to expand, but one of the obstacles was quantity. You need a lot of quantity. Can you expand on that, explain exactly what you're talking about?
Because the way that PACE is set up, there's a formula for the number of PACE eligible people you need in the market area for a PACE program to be viable. It takes about somewhere between 75 to 100 people in a PACE program in a market area to be able to break it even and make it work financially. So obviously that's much more challenging in Wallace County than it is in Sedgwick County or Shawnee County. So it's much easier to do in markets where there's a number of PACE eligibles that you need to be able to have a program and to create one and develop one and maintain one. But there are ways, I think, that we can work with the state and federal governments on making a more viable option for rural counties and rural areas of the state. And that's something that the state of Colorado has done over the years, is their PACE programs actually do serve a very rural population. It's something I think we should take a look at as well. But there's also an immediate opportunity. There's Johnson County that could be served. There's an opportunity for a bi-state situation with Pittsburgh and Joplin down in Southeast Kansas and counties around there to be served by PACE if the state was wanting to and open to, and to expanding PACE into those areas and doing RFP or whatever that would look like.
Thank you.
I have Representative Carpenter, and then we'll come to Representative Concanon on Zoom. Representative Carpenter.
Thank you, Madam Chair. Sean, thank you for being here. So on the surface, this sounds like a very good thing. So why are we having so much problem with this getting traction in our state?
For many years, it was because there was a cap on enrollment. So between 2002 and 2013, the PACE programs at the time, which were Midland and Via Christi, wanted to grow the program, but they couldn't because there was a cap on how many people they could serve. So it was for whatever reason, when KanCare started, that cap was taken off because whoever's not in PACE is served through one of the 3 MCOs, and those rates and costs are more for that person. So that made sense. Since then, the program's grown from about 100 and something, 120, 50, I'm not sure the exact numbers, to where it's now about 750, I believe. So it's grown, but it's still not a huge program by any means. One of the things One of the reasons, to answer your question, there are some internal changes that I think PACE programs have been looking at. A lot of people have perceptions that when you go into the PACE program, you're going to not be able to see your primary care physician or any of your physicians that you've seen over the years wherever you live. That is a misnomer. We certainly want to be able to have a tight network and be able to have control, not control is the wrong way, but be able to coordinate and integrate that person's care as much as we can. But many of the physicians and providers that a person sees, they're still able to see throughout the year as they need it, particularly their specialists. So we have to do a better job getting that word out to potential referrals and getting that word out to the people that present PACE as an option. That's been a huge barrier. And then the other one is just, it's not available in markets that where it could be beneficial or it could be of service.
Thank you.
All right, Representative KanCare.
Thank you, Madam Chair. Good morning, Sean, and thanks for your presentation. Hey, I think, I don't think you probably know the answer to this question, but I'm going to ask it anyway. Do you know the number of nursing home patients or residents that, do you know the trend of that number the last 20 years?
In Kansas, yes. I know what it was 10 years ago. It was about, for Medicaid, it was about 11,000. I think now it's around 10,400, 500. So there's been a slight decrease. That's just the Medicaid utilization or caseload. So there's been a kind of flat or a little bit decline in nursing home over the years as some of these other options have been out there and getting some traction.
Well, I think sorry, my dogs are barking. I think that it's important to track that if we could get the total number from KDADS to, if we're going to do some expanding, I'd like to know, how many we're preventing from going into nursing homes. Thank you, Madam Chair.
I think that would be good information. Is that something you can provide for us, or do we need to have?
KDADS would have to give you nursing home trends.
Okay. Senator Petty.
Thank you, Madam Chair. Sean, thank you for being here today. I think our needs and needs of the last couple of years have been kind of consumed at times by this whole thing with PACE, and that seemed like to be the protected income in the past is the one thing that I heard repeatedly as being an obstacle. You laid that out there about the protected income. With those 119 people that potentially could have gone into that, looked into PACE this year and didn't enter, was the protected income the #1 issue?
It was, yeah. For those, so that's certainly not the entire number throughout the state that called and asked about PACE and didn't enroll, but that is one of the top reasons that people did not. So 120 just in the last year. So that number has decreased as I've talked to our organization and the other two since the income limit went up from 747 to 1177, but we still do see that as a barrier. So if they're having to pay rent, pay for the utilities, transportation costs that we don't provide, even though we provide much of it, then that is an important consideration to them to be able to stay at home.
I do believe, and I might be wrong, I'm not sure, when we made that change in 18, we were the lowest at that time, I believe.
Yeah, I would think that we had to be one of the lowest, and to be honest, and I'll admit my own mistakes and fault here, is the protected limit and the need to increase it was not something that I recognized the need for over the years, as I had, whether it be Janet Williams or Rocky Nichols or other that would advocate for it when I was at KDADS in particular. And it really hasn't been until I came to Midland earlier this year and talked to our staff and described to me, and then talked to some of the HCBS people more about how they see it as a barrier to going on to HCBS. And both programs are designed to keep people out of nursing homes. That I had the light bulb kind of click off in my mind of how important it really is.
I'm sure, because I can understand that, because it seems that this protected income is an issue that takes a little bit of breaking down to be understood, the factor that it plays in providing for that person to be able to stay in their home, even though they are nursing home eligible. I'm not sure, and maybe I missed it in your presentation, when you talked about that we have 750 people in the state of Kansas that are on PACE right now in the service areas that we have. How do we compare with our border states? You mentioned Colorado slightly. But
Yeah, Colorado has a pretty robust program. I can pull the numbers and send them to you if you'd like on how many they have enrolled. It's significantly more than Kansas. Missouri does not have PACE programs. They had one in St. Louis that ran into issues and closed. They're in the process now of establishing one and working with SWOPE in the Kansas City, Missouri area to open a PACE program in KCMO. And they're working with a senior living provider in the St. Louis area to open one there. Nebraska has one in Omaha. There's an opportunity for whoever to open one in the Lincoln area and other areas of the state. So those are the three I know most about. Colorado's for years had a much more robust PACE program than what we have. Missouri and Nebraska are pretty similar to us.
Thank you, Madam.
Jim Ballard. Thank you, Madam Chair. Sean, thank you so much for your comments you just made a few minutes ago. I really can appreciate your honesty on that one. Two things I just want to talk about. I think increasing it, even though we're in a financial bind, would over time, the money saved of the state would probably balance itself out. And maybe you have to have money in order to do that, but that's how I see it. If it's going to save the state money, then we're going to spend it on one end or the other. The other question, just a little more explanation when you were saying enrollment dates moving from maybe the first of the month to the middle of the month. Would you explain how that would be effective, or if it saves money for us, or if it's just a more convenient, needed type of policy change for consumers?
I'll be honest, that's something that we have just started talking about internally and looking at how other states do it. So it's something that we need to have more discussions about and talk about it more with Via Christi and Blue Stem, the other two PACE providers, before we even go to KDADS, because I have not talked about it with KDADS. But many other states allow for a person to be enrolled into PACE and to have services started today in mid-month. Whereas the way Kansas currently has it, you can only start services on the first day of each month by that PACE program. So the barrier to that is if the person calls, or their spouse, or their child calls and, hey, I'd like to learn more about PACE, and start going through the process with us and go through the assessment process and say, yes, I want to do that. That makes sense. Beneficial to my mother, then sometimes you either lose momentum or their needs change and we're not able to get to them quickly enough. It would be a scenario of getting their assessments done and their medical needs done and seen and provided for, whatever that may be, to be able to keep them at home. Because if they are not able to be assessed to be living safely at home when they are enrolled, then they cannot be in PACE. So does that answer your question?
Yeah, it does. And thank you very much for that. Well, I would say we should really pursue that because it's a convenience factor, it's a safety factor, but it also would allow more people to enroll instead of they needed something right away and someone else grabbing them before that time. But no, I appreciate that. Thank you very much. Thank you, Madam Chair.
Committee, are there further questions? Anyone on Zoom? I got a few for you, if you were ready for that. No, you do better.
I was gonna try to get away.
No, that doesn't happen. Okay, on your first page, as you showed the,
Madam Chair.
yes,
Sean, have you seen the coronavirus spark a increased interest in PACE? Seems like many nursing homes, that is a huge issue as far as isolation from family, friends, and everything else, and causes deterioration of health. Seems like me that would be a great advantage of PACE, keeping that person home and close to relatives.
The short answer here, the answer is yes, we have, and I think that's mimicked by other PACE programs around the country as well. So there has been a huge uptick in the interest in PACE, Senator, for the reasons that you just mentioned.
Thank you.
anyone else on Zoom at this time? Okay. On the first page in your second paragraph, you provided that only about 5% of PACE participants nationally reside. Do we know what Kansas numbers are?
I know what ours are. I think we have 26 or 27 of ours out of 300 and what do we have today, 50 or so. So whatever that percentage is, it's similar here in Kansas, around 5%.
And then how many of the PACE participants are dual eligible with Medicaid and Medicare?
Nationally, it's 90% are Medicaid, Medicare, 9% are Medicaid only and not Medicare, and 1% are private pay. The private pay portion, the reason it's only 1% is related to the Medicare D benefit, and the amount of money a person has to pay to get that is a barrier at the federal level. I don't fully understand the ins and outs of that yet, but it's one of the main reasons why that's a small percentage. But it's to answer your question, 90%. And we also are seeing quite a bit more, a significant uptick in the number of PACE participants that are interested and that are enrolled in the program that have mental health needs. So we work quite a bit with the mental health centers in the areas that are served by PACE, and that is a growing need and one that we are taking a closer look at is how we can better do that.
Okay, so you talk national numbers. Do we know what those dual eligibles are in Kansas?
For my organization, we're different because we have more mental health people we serve, particularly in Kansas City. So it's 80% for us, and then 19% that are Medicaid only, and then 1% that's private pay. I believe the other two organizations are more closer to the national average than what we are, but I'd be happy to get that and send it to you.
I think that would be good information. The thing is that, every legislature, this is an education process on what each one of these do. So is that reduction in the dual eligibles, is that because they're below 65 and may not qualify for Medicare yet?
That is correct.
Unless there's a disability or something to that effect. Okay.
For my organization, because we have a higher number than national average that have mental health needs that are between 55 and 65, that skews our percentage.
Okay, seems how, this is kind of bad, it might be Representative Ballard and I are the only two that were here when PACE was created with actually Bob Bethell, Representative Bethell at the time. But I'm wanting to understand why it was the change in 2013. Okay, removing the cap, I get that piece, but then why removing them from the consensus caseloads? Do you have any recollection as to what the thought process was behind that?
I think it was because the cap was taken off. But I remember those conversations, but to be honest, it's been too long to know the reason, or exactly what the reasons were. My last year as budget director, I do remember I mentioned it to others, the agencies, and to KLRD to try to get it back in. KDAD's asked us to do that at the time, and the secretary at the time did. But I think it was KLRD that felt like there needed to be a proviso, or there needed to be something directed from the appropriations committees to bring it back in. And I don't remember the reasons as to, I actually don't remember it being discussed.
So would you have, just because of your former budget experience with the legislature, would you have an idea of what the fiscal impact would be moving that into consensus caseloads, or is it negligible?
It wouldn't be any.
Then what's the benefit?
It's the process. It's the process and being recognized and having a similar process with how everything goes and being on par with the managed care companies. I will say this, that the benefit really, the one benefit would be, besides being the two benefits. Number one is being very much on par with the MCOs as a fourth option with how everything is done. The second is a process I'm all too familiar with, again, of budget allotments. When allotments are done by the governor, often caseloads are exempted from that because they are institutional requirements that the federal government requires the state to continue to cover. So that would be one benefit.
Okay, and then on your third page, when you talked about about trying to get level on the rates and stuff, were you referring to something like the rebasing that we do in the nursing homes, or?
Yeah, so essentially that's done every year, and actually twice a year for the MCOs. It's done for us required by the feds every 3 years.
Okay. And are we currently not doing that?
There have been
to be more often.
There have been two rate studies or rebasing, essentially similar concept over the last 15 years. The first was in 2013 or 14, and the second was in 2018, I believe. So, but there was not a federal requirement to do it every 3 years until 2015. So that is a newer thing. And our argument would be treat us like the MCOs. The risk that we have financially needs to match what the rates are. We'd like to see, instead of flat and then spike, we'd like to see a little bit more gradual.
Are any of the PACE members utilizing the HCBS waivers?
They are not. So because they're in PACE, they're not in the KanCare program. They're not just utilizing HCBS providers. So we may contract with an HCBS, with a provider that provides HCBS services for the state or personal care services. We mostly do that in-house through our own staff, but we on occasion do contract with others. Sometimes we do that.
Committee, are there further questions? I think, this is a topic that can have a lot of discussion on it because it gets pretty complex into some things. I think, one of the misconceptions that so many people have is that Medicare pays for nursing homes, and it doesn't. It pays for what, up to 100-day, I think, of skilled care, and that's it.
Yep.
And then that's all Medicare pays, and then you go on to either a private pay policy or your private pay, or you go on to Medicaid. Medicare does not cover long. Any further questions or comments?
Representative Landwehr?
Yes, Representative Burnett.
Good morning. I just, knowing that I've been hearing about this for 4 years, and knowing that it just has no point of reference, unfortunately, for those of us who live in the bottom right-hand corner. I want to encourage folks that are continuing on in this conversation to recognize that this really doesn't have any context for folks that haven't had the opportunity to experience it. And so the assumption sometimes I have seen when I'm in the legislature and I'm listening to committees, that for those of you who live in the bigger communities who have had this opportunity, I just encourage you not to forget that most of the time the folks outside of the metro areas have no idea what you're talking about here, right? And this may not be the best choice for rural areas if indeed the driver of it is volume. And so I just need to throw that in, not saying anything bad about PACE at all. I think it's worked great for the communities that have had the lovely opportunity to have it. But if we're looking to scale up, or if we're looking for this as an alternative, volume doesn't oftentimes help those of us who live in super small communities and have 6 or 8 people. This might help. And I just wanted to throw that out there and say that for the record. Thanks for the opportunity, Madam Chair.
Well, thank you, Representative Murnian, because that kind of brings us back, and I can assure you that those of us that have done this a lot of years and our current budget folks, don't forget that, we've got different isolated programs around the state. And when we come back to the discussion, and we'll have a major discussion this afternoon on our nursing homes, but Sean, you've had a lot of experience in this. What are we seeing? Because a concern that I have is the potential for having fewer beds available, because we may see more homes go into receivership with the potential lawsuits that are sitting out there. I'm personally aware of 3 lawsuits that are being prepared at this time because they've been made aware that they're going to be sued. And I believe, I don't think that Deputy Secretary DeBoer gave us a number, but she did mention at our meeting last week that we will drop from 2 receiverships to maybe just 1 by the end of December. But when I took it a little bit deeper, it's like, okay, so who's in trouble out there? And she had a few homes with the agencies out there trying to figure out how to. So what are you seeing? What are your folks seeing? What are concerns that you're seeing with our availability for nursing home beds? Because we may not have anywhere to put mom or grandma.
That is a very legitimate concern. So that the company that I worked for before coming to Midland Care a few months ago was a national nursing home company out of Tampa, Florida, that I led for them, a division of their company that helped states and CMS with operating receiverships and helping facilities until they were closed, sold, or improved in some cases. And I can say firsthand that the number of calls that we got and I got going into late summer increased 5 to 10-fold. So nursing homes are hard to operate financially in the first place. But secondly, when occupancy decreases by 10 to 15 to 20%, as what's happened across the country because of COVID, that makes it significantly more difficult. They've been propped up by federal CARES Act money from the Provider Relief Fund that came from one of the federal stimuluses. And when that runs out next year, there is going to be a significant number of operators and facilities that are at significant risk for closing, going bankrupt, and losing access to them. So it's not a matter of if it's going to happen. In my opinion, I think what you'll hear from the people this afternoon on your agenda, it's a matter of how many.
Do you have any idea, just because of your past experiences, and this may not be current up-to-date numbers here, but the percentage of Medicaid pay in nursing homes?
So it's a number that's increased significantly over the years. It's probably used to be 40 to 50%. Now I think it's probably 60%. It's something that KDOS could provide, but it's somewhere in that percentage or number.
Then how do the Medicaid rates compare then to private pay or private insurance pay?
So the average daily Medicaid rate in Kansas right now is about $197 a day. KDOS or Scott Bruner in particular or Janice could provide the numbers, just the gap, but there is a gap between that and what a private paid person would make. So generally facilities they try to operate to make it work financially through Medicare and the program that you referenced earlier, the rehab to home type model, and through private pay residents, and they use that to prop up and compensate for the money they lose every day on Medicaid residents.
Committee, are there further questions? Is there anything, Sean, that during this conversation that, maybe there was a question that we should have asked, I'm gonna put you on the spot, that you feel would be pertinent for us to be aware of as we're proceeding forward. Because we are in uncharted waters right now.
Yeah, and you all asked, I think, the right questions, and you'll hear more about the uncertainty and anxiety this afternoon. So I'm never be the person, because of my background, to say that nursing homes and long-term care facilities, assisted living shouldn't be supported, because they should. And there's a lot of things that are being done and can be done. But I do think that there need to be community-based options because of where we're heading, because of where the concerns about access. And I think PACE is a viable option. Maybe not in every place in the state, but it is a viable option to help do that. So,
All right,
appreciate it.
John, thank
all.
you very much for being here today. We appreciate it, and I'm sure you'll be hearing from us at some point. All right, committee, next on our agenda, we're going to start the discussion on integrated care. As I mentioned earlier, this came about in all three work groups in the Mental Health Modernization Committee, and we felt like we would bring this discussion back to our MCOs. So I'm going to start off with Carrie Breffett with Kansas Health Institute. Kansas Health Institute provided facilitation on the Modernization Committee because we had X number of legislators on that committee, as well as I think right around 30 private sector members that were participating in it. And we broke up into groups, so they helped us facilitate how each one of those working groups operated, and then the information that they brought back to provide the report that we approved last week. So Carrie, are you out there?
I am. Can you hear me?
I can hear you and we can see you. Welcome to committee, Carrie.
Thank you. Thanks, Madam Chair, and thank you to the committee for inviting us to introduce the discussion of integrated primary and medical and behavioral health care. It's a natural follow-up to the conversation you just had about the PACE program. I am Carrie Breffett. I'm the Vice President for Policy at the Kansas Health Institute. Many of you know KHI is a nonprofit, nonpartisan educational organization, been around since 1995. As the chair said, we had the honor to facilitate working groups for the Special Committee on Mental Health Modernization and Reform. And specifically my colleagues, Carly Houchin and Hina Shah, and Hina is on this call today as well. And as the chair said, integrated care as a concept came up more than once. And in fact, it's a concept that flowed through the working groups, the three working groups that were established by the Special Committee. That committee, as many of you know, was tasked with analyzing the state's behavioral health system and developing the strategic effort to modernize the system. And so the three working groups that the chair just referred to that were established by the committee were finance and sustainability, policy and treatment, and system capacity and transformation. In my testimony on the flip side, there's the roster of two of those working groups, two recommendations that I'll be referring to briefly this morning. My role mainly, though, is to introduce a great slate of folks who are going to talk about integrated care from both the federal perspective, what's going on in another state, and what's going on in Kansas, including from the managed care organizations. The Special Committee on Mental Health Modernization and Reform, and this committee will be hearing much more from that committee as time progresses, but that work was based upon previous work of the Child Welfare System Task Force, the Governor's Substance Use Disorders Task Force, a couple different editions of the Mental Health Task Force, the Governor's Behavioral Health Services Planning Council, Crossover Youth Working Group, etc. So the recommendations from all of those groups that have been putting in great work over the last few years were taken by these working groups and the Special Committee, and then grouped into specific themes and move forward into prioritized recommendations. And there are a couple different kind of recommendations. Immediate action recommendations were the ones that they think that the state, whether policymakers or their partners, could take action within the next couple of years, and then some longer term strategic initiatives. Now they're all strategic, but that might take a little bit more than 2 years. These working groups had great membership, really a cross section of folks, including legislators, state agency leadership and staff. We really know the information and the content, provider associations, individual providers, payers, et cetera. So as in an introduction to the recommendations related to system transformation, the working group that was tasked with that, in the testimony, it has the whole language there, but I just wanted to call your attention to one of their focuses was an important strategy for system transformation will be addressing the continuum of care to ensure an integrated and coordinated approach to care delivery. And I think it was during one of the special committee meetings, and if not, it was offline, but it's something that we've heard a lot of people say, what do we mean by integrated care? It can mean a lot of different things. You just heard a little bit about integrating services, community services for older adults in the PACE program. Integrated care can mean a comprehensive integrated managed care program, like the KanCare program, or it can mean integrating substance use disorder treatment and addictions treatment with mental health treatment and care. And it could also mean the integration of primary medical care and behavioral health services. And so I think when the working groups were thinking about it, they were sort of embracing all of those things. They sort of naturally all lead to each other. And in fact, you'll be hearing from folks from Washington State this morning that will talk about sort of that progression as well. The recommendation for integration is in the testimony. I'll read it real quickly. It's recommendation 9.3, so you get an idea of how many recommendations the special committee saw from the working groups. It was to increase integration, linkage, collaboration, and identify care transition best practices among mental health, substance abuse, primary care, and emergency departments across the state. Adopt coding practices that allow for the integration of services across the continuum of care domains, including but not limited to primary care, substance use disorder, and mental health, to provide more integrated services to clients with co-occurring conditions. And I copied the rationale, but really is the idea that integrated, the rationale for this recommendation included the definition from the Federal Substance Abuse and Mental Health Services Administration, who you'll be hearing from the Region 7 administrator after me, but that description of integration from SAMHSA is the care that results from a practice team of primary care and behavioral health clinicians and other staff working with patients and families using a systematic and cost-effective approach to provide patient-centered care for a defined population. Integrated care can lead to better outcomes. I think it was Representative Ballard who asked the question about PACE. It's just like you may spend money now, but the idea is trying to reduce costs in the long term by getting better outcomes. That's the idea behind the integrated care approach as well. Another working group, the Finance and Sustainability Working Group, the membership is also on the testimony for that, included a recommendation also for action in the next 2 years. So both of these are those immediate action recommendations related to a model that you'll hear about today, and you've probably heard about before as well, certified community behavioral health clinics. I'm going to defer to other conferees, and particularly the next conferee to describe the model, but the recommendation prepared by the working group was to support expansion of the Federal Excellence in Mental Health Act, which established this model, and then pursue participation as a state. But if participation in that Excellence in Mental Health Act is not possible, to pursue a state plan amendment, a Medicaid state plan amendment, or an amendment to the Section 1115 demonstration to allow interested providers to gain access to the CCBHC model. And you'll be hearing from some folks who have experience with that. It basically, the short version is it provides for cost-based reimbursement for a set of core services that you'll get to hear about in more detail here in a minute. You'll also hear from, I mentioned the team from the Washington State Healthcare Authority, and thanks to them, because it's 2 hours earlier there than it is here for joining us this morning. They'll describe Washington's journey from sort of their integrated care model, including sort of the evolution to the collaborative care model, something that was actually established in state statute based on a model established by, I think, the University of Washington Ames Center. And then you'll also hear from a Kansas provider who's implementing integrated care in a clinical setting, and then from the KanCare managed care organizations. But thank you for the opportunity to introduce these groups. They have the expertise. I'd be happy to stand for questions, but also think it would be great to be able to roll it over and turn it over to Kim Nelson, who is the SAMHSA regional administrator. She'll be a familiar face to some folks, probably in her SAMHSA role, but she also has experience working for the state of Kansas in SRS and then KDADS in the Substance Use Authority, as well as Director of Behavioral Health Services during the implementation of KanCare. So she's very familiar with the Kansas program, and she's the regional administrator, and that is, I believe, Kansas, Missouri, Nebraska, Iowa.
Terry, Representative Lambert here, and I have a question for you, because we have one individual that was slated until 10:30 to appear at 10:30. Is it possible to move her up because she has to be off at 11 and we got a little bit of a late start this morning? Or
We
does
were
that-
able that. Thank you. That's very kind. We were able to coordinate with her, and Leah, I think you were able to move your 11 o'clock. She's giving us a thumbs up. So I think we're good to go with the flow.
All right, I just wanted to make sure we didn't miss anyone because it's been pretty important to,
Oh, that's very, thanks for thinking of that.
to bring all these people together. So Kim Nelson, we will welcome you to the committee. And as you heard, the acronym SAMHSA, which is Substance Abuse and Mental Health Services Administration. And even some folks that have been here around here a while are not as familiar with SAMHSA because we don't always hear about it. So welcome to committee, Kim.
Thank you. Good morning, everyone. Can you hear me okay?
You can.
Great. I'm very pleased to be with you this morning. Thank you for having me, committee. So I am, as was said, your SAMHSA Regional Administrator, part of the United States Department for Health and Human Services. SAMHSA is the area of our federal government that focuses on substance use and mental health services. I do serve, as Carrie said, Kansas, Iowa, Nebraska, Missouri. But more importantly, I am a citizen of this state in Kansas, and I care about people with substance use and mental health, living good lives. And I'm grateful that you are entertaining this topic on integrated care because I think it makes a huge difference. Okay, I am going to try to share my screen and get my PowerPoint up, and you will, if you would please let me know if that actually happens correctly. Oh, I see a thumbs up. And let's try and get it into presentation mode. Still good? Okay, great. I have about 30 minutes of slides that I am going to try and do in 15 minutes or less, so that I leave the majority of the time that we have together for you to hear from the state of Washington and other folks who are actually doing this work. So I'm going to give a very high level kind of orientation or overview of integrated care, a little bit about the evolution and kind of where we are now. I am happy for you to have these slides, happy to do a deeper dive at any time that's helpful to you all. But I'm going to, try and yield most of my time to the state of Washington, as Carrie said, who have graciously agreed to be here very early in the morning and tell us about what they're doing. I think you'll get the most value out of that. All right, so just quickly, why are we talking about this? Because, 1 in 5 folks continue to be, and this is an ever increasing number, continue to have a mental illness in our country. These are the latest national data. So, folks 18 and above, over 20% of folks in our country have a mental illness, and almost 8% have a substance use disorder. That number, like I said, is increasing. And in fact, from last year, that number increased by almost 6%. And that increase was entirely made up of folks with mental illness. Important for us to understand. These are pre-pandemic numbers, just, one other important thing. So since the pandemic, which, that data will show up next year, we know that there are an increasing number of people who are experiencing mental illness, especially, and substance use disorders. So this need for integration, why integrate? Well, people with mental health and substance use disorders died decades earlier than the general population. And most of that is from untreated and preventable chronic illness, co-occurring chronic illnesses like hypertension, diabetes, obesity, etc., coupled with some poor health habits like not enough physical activity, poor nutrition, etc. I'm sure many of us can relate to this. However, these folks have an added barrier of kind of a challenge in navigating very complex systems that are often varied and operating, separately. We have kind of a primary care system that operates over here and a behavioral health care system that operates over here. It's causes great difficulty in someone that has combined chronic conditions to actually access care. Additionally, we have primary care settings that are now kind of the gateway to behavioral health care as well as these chronic care physical conditions. And those folks often need support to do that well. So the solution really lies in integrated care, which what I'm talking about when I say that is the systematic coordination of medical primary, general health care with behavioral health care, which includes mental health care and substance use disorder care. So integrating those either 2 or 3, however you want to look at that, areas into a location where someone can get care for all of their conditions, kind of a whole health location for care. Just a little bit more, the numbers tell us 68% of adults with a mental illness also have one of these physical chronic conditions. So this chart below here, the red bar are people with mental illness, the blue bar, people with no mental illness. So that first line with high blood pressure, you can see a difference of 18.5% or so of folks without mental illness compared to almost 22% of folks with mental illness that have high blood pressure. And then go down the line there. Smoking is dramatic. 21% of the population without mental illness smoking, 36%, almost double the percent of folks with mental illness are smokers. In Kansas, I'm sure you know this, but NAMI, Rick Kagan, has an ongoing work group that is really tackling this very specific issue of smoking among people with mental illness and substance use. And so there are some really good work happening in Kansas in that area, but we then also have diabetes and heart disease and obesity and asthma, these other conditions that people with behavioral health conditions, suffer in greater numbers. This is kind of an early representation of what integration, really what we started looking at many years ago. And, in that bottom quadrant 1, if you will, we have, folks with a low physical health and a low behavioral health need might be best served, by a physician with maybe an on-site behavioral health staff member. As on the left bar, as your, behavioral health needs increase, being served in a specialty behavioral health environment would be important. On the bottom axis, as your primary care needs increase, being served in the primary care system with just maybe a connection to behavioral health care is adequate. But it's that fourth quadrant, people that have high behavioral health needs and high primary care health needs that we're looking at, that we target for integrated care. And we started to do that through what was called the PBHCI, or Primary Behavioral Health Care Initiative through SAMHSA. It was a type of funding, a type of grants that we started utilizing. That has really rolled into what was alluded to, the Excellence in Mental Health Act in 2014 that was signed into law. Section 223 of that required Department of Health and Human Services to establish a process for certifying certified community behavioral health clinics. You're going to hear that referred to as CCBHC. And so that really is what is kind of, where we are right now in terms of integrated care, the best models of integrated care. That act that Congress passed and was signed into law created a demonstration project called the CCBHC Demonstration Project that was managed, combined by SAMHSA, CMS, and the Department of Health and Human Services Assistant Secretary.
Hey, Kim.
Yes.
I'm sorry to interrupt. Would you be able to remove the chat from your screen? It's kind of cutting off a little bit of our presentation.
Remove the chat from my screen.
If you would just click on the chat button at the bottom.
Okay, I can't see that just because I've got the presentation up large, so I'm so sorry. I will figure out how to do that though, just a second. Let's see. Remove the chat from the screen. All right, I think the only way I'm going to be able to do that, oh, there we go. Here we go. I see it, okay. So now, how do I remove it?
If you just click on that chat, it should just,
Right. Oh, I need to actually open that chat. Here we go. Can you take the chat off the screen? It's cutting off. Did I do something that made that actually work? So sorry, don't have great Zoom skills. Did it work?
I hate to do this, but I've got word that one of our conferees following behind you has to leave at 10:30. If I could interrupt you and let her present quickly to us and then come back to you, would that be all right?
Absolutely, whatever works.
Okay, I certainly appreciate that. Thank you very much. So committee, we're going to jump gears. You do not see all of these names on here because we did not have the names until early this morning. So we're going to have Melanie Azolt, is that correct? Foundational Community Supports. Are you there, Melanie?
I am. Thank you, Madam Chair, and my sincere apologies for interrupting the flow of the presentation this morning, and certainly appreciate the opportunity to present information. You're going to hear from my colleagues Alice Lind and Mary Fliss about the efforts in Washington State to implement integrate behavioral health and primary care. And as we started focusing on the implementation of behavioral health and primary care, we also moved towards whole person care and really thinking about the whole person. And that included the social determinants of health around housing and employment. And so I'm not sure if you're able to view my slides that are in kind of a combined PowerPoint presentation, but they certainly are available to you to review. Oh, there it is. Great. Thank you so much. Next slide. So the social determinants of health are really quite an array of thinking about how housing, how income, transportation, nutrition affect that person's health. Having a person go to an emergency room or a behavioral health treatment facility, state hospital, any inpatient treatment that you can think of, and then having that person released to homelessness, not having daily activities that provide purpose and income, transportation, and being poor around nutrition. And so the Healthcare Authority is really has quite a broad array of activities that we're doing to try and address the social determinants of health. Next slide. So including in 2015, Washington State applied for an 1115 Medicaid waiver. And that waiver, so we have a number of initiatives under that waiver to look at a regional level, how can we address integration as well as address social determinants of health and really move towards that whole person care philosophy. In that waiver, it also allowed us to have 2 targeted benefits focusing on employment and housing. And so why focus on employment? Well, because we actually know that long-term unemployment is bad for your health, and that there is really quite a bit of information, epidemiological studies that correlate being unemployed for long periods of time with bad health. And so next slide. So when you think about unemployment and laid off workers compared to those folks continuously employed, that 54% of laid off workers have poorer health than their counterparts. Next slide. We also know that when you're laid off, you're more likely to develop actually physical health symptoms like cardiovascular disease. Your diabetes is more likely to be out of control. Next slide. You're also more likely to experience depression. You're more likely to use substances. And so really, as a healthcare system, we really need to think about being unemployed for long periods of time as a health issue. And so the 1115 waiver allowed us to create a targeted benefit using an evidence-based practice model called individual placement and support, IPS, to try and intervene with targeted populations to provide supports to help people obtain and maintain employment. Next slide. We also focused on housing because we know that there's a lot of research out there that says, you know, if you're going into the hospital, whether you have a chronic health condition or a behavioral health condition, releasing to homelessness is also going to not help you recover from your health or behavioral health conditions. And so there's a lot of research that is out there around the impacts that homelessness has on health. And so helping people focus on the services to obtain and maintain housing are also part of what this demonstration allows us to do. Next slide. So these two benefits, supportive housing and supported employment, are available. Again, they are, we can't pay for housing, we can't pay for wages. These are services using Medicaid funds to be able to support people. And it's really kind of almost a specialist. We're creating sort of specialists within the behavioral health, healthcare, and long-term care fields to really focus on these two issues. And so this is kind of a description of what those benefits entail. Next slide. So again, these are services. We cannot use these Medicaid resources to pay for room and board or to pay for wages. Next slide. So there is a medical necessity that has to be established, and these are really an enhancement to our healthcare and behavioral health services. So we have to create that or identify that medical necessity. Individuals, of course, have to be on Medicaid. For supportive housing, they have to be 18 and up, and for supported employment, they have to be 16 and up. And partly what we're trying to do is divert people from a life of poverty. You know, we think that SSI, SSDI is great, but it's still poverty. And in Washington State, where a single room apartment goes for about $1,500 a month, an SSI cash check of $780 isn't going to pay that rent. And so helping people obtain employment and divert them from a lifelong poverty is really what we're trying to do. And so the target populations that we've identified, next slide, for these interventions that are intensive supportive services. So we really identified specific target populations in supportive housing. So individuals that are chronically homeless, people coming out of institutional settings, jails, prisons, state hospitals, substance use treatment programs. We also identified individuals in our long-term care population. And then the PRISM is our predictive risk intelligence system that identifies individuals that are likely to cost the Medicaid system more than the average person on Medicaid. And so that's our PRISM risk system. And then for supported employment, again, these are folks that are on the path towards disability benefits, or individuals with a behavioral health condition, mental health, or substance use. So we can work with a straight SUD population. And then youth with behavioral health conditions. Next slide. So we were awarded the waiver in 2017. Our program launched January of 2018. These are some very preliminary findings on the first 9 months of our service delivery system for foundational community supports. Next slide. So these, our partner agency, Research and Data Analysis, has an amazing integrated client data system that allows them to cross-reference individuals in over 60 different administrative data sets. And they are able to do a very thorough evaluation using a pre-post as well as a statistically matched comparison group. And for anyone that's rural researchers, that want to know more, the full research report is available online. I'll make sure that those links are available. But I just grabbed 2 slides that kind of highlight the impact of these interventions. Next slide. And this is sort of that summary. I'll go to the next slide. So the gray bars are the statistically matched comparison group, and the blue bars are our healthcare authority. So these are individuals with behavioral health or chronic health conditions. And you can see that how the intervention increased employment outcomes, earnings, and average hours worked. And then the next slide is our impacts on supportive housing. And so again, the gray bars are the statistically matched comparison group, and the blue bars are our intervention group. And so supportive housing, we're seeing decreases in emergency room visits, as well as decreases in inpatient hospitalizations. I do apologize, I'm late for a meeting with our legislature, and so I'm going to turn it over to Matt Gower to answer any questions that you might have. So thank you very much for the opportunity.
Melanie, thank you very much for being with us, and we appreciate you giving us your time. So thank you.
Bye-bye.
Questions? We'll go ahead and on this particular situation, go ahead. Are there any questions on the stuff that Melody presented from Matt? Anyone in the committee? Anyone in Zoom? All right, seeing none, Matt, thank you for stepping in for Melody. We appreciate it. And we'll proceed on to our next conferee. So we appreciate your time. Next, I have Alice Lynn on integration.
Good morning. Hi, this is Alice Lynn, Washington State. I also have a quick set of slides to walk you through. Thank you so much for the invitation to join you this morning. I think the materials that Kim presented are a good introduction to the work that we have done so far in Washington on integrating behavioral health into physical managed care programs. So we'll go on to the next slide. Today, I'm just going to quickly talk about a few topics, basically to give you the design of our integrated managed care program and the different roles of the managed care organizations versus the behavioral health administrative service organizations. So those 2 roles will become clear as we go ahead, and then some initial outcomes from the early years of integrating. Next slide, please. Our legislature passed the law that created integrated managed care in 2014. They gave us a deadline of integrating behavioral health services into the Medicaid managed care program by 2020. And in so doing, also gave us a pathway for any region of the state that chose to do this in an early phase, and some incentive dollars to do so in April of 2016. So we'll move on to the next slide that shows why we did this, but I'll describe in a little bit who chose to go earlier and later. I think Kim covered this already very well. The silos under which we had been administering Medicaid services created problems of not having a single entity with accountability for the whole person. We had consumers who had co-occurring disorders, mental health and medical condition, or substance use disorder and a medical condition, who could not navigate the system easily and were shuttled from place to place. Care coordination and care management was duplicated across the system. We had something called access to care standards that set an artificial barrier for folks who needed higher level mental health services and shuttled them to specialty mental health when they could have been perhaps served in the managed care plans set of benefits and providers. And those bifurcated funding streams made it very challenging to support integrated care models. So while we did have some really high functioning, high performing clinical integration. It was often only supported by SAMHSA grant dollars, and for limited time periods, that made it hard for a sustainable model to be in place. So the integrated system allows one managed care plan to be accountable for the whole person, to have one point of contact for individual clients, one care coordinator, and to be able to provide the entire continuum of care for clients under the Medicaid program that allows providers and managed care plans to work together over time to establish new integrated clinical models. So next slide, please. This is the map of how we have regionally established integrated managed care. So we started off in the southwest corner of the state, the little green corner there, which is Vancouver, Washington, right across the river from Portland. That corner of the state chose to be our early adopter in 2016. Then North Central, a big geographic, but another rural, kind of low population center. North Central went next in 2018. In 2019, we had most of the state move to integration. So that was the Spokane region, Greater Columbia, North Sound, King, Pierce. All of those regions went live in January or June of 2019. And then out on the Olympic Peninsula and just where we are in Olympia, Washington, and south of us, all just went live in January of 2020. So we did it as a phased procurement and a phased implementation. The health plans do not necessarily cover every part of the state, and that was purposeful. The behavioral health providers asked for fewer numbers of managed care plans to simplify and reduce the burden for them of the administrative challenges of going from contracting with one behavioral health organization to multiple managed care plans. So that's where we stand in 2021. We did accomplish, or 2020, we accomplished the goal by January 2020 of statewide integration. Next slide. The Medicaid benefits remain the same. They continue to be defined by the state plan. The managed care plans do provide all the Medicaid benefits on the physical, mental health, and substance use disorder side. They also receive general fund state dollars for some medically necessary services that are not covered by Medicaid. So, for example, when clients reside in residential settings or freestanding evaluation and treatment centers, there's a room and board component that is a state-funded part of the service that flows through to the managed care plans under a separate contract, but it keeps the service as an integrated service. Next slide, please. We also contract through behavioral health administrative service organizations, one per region, and the responsibility of the behavioral health ASOs is to manage the crisis services regardless of insurance, regardless of income level. So that is a service we thought was best administered by a single entity. Next slide. The way the contracting works is that we, in each region, contract with multiple managed care plans. They, in turn, pass the Medicaid dollars to the behavioral health ASO in order to administer the Medicaid part of crisis. And that offers a continuum of integrated clinical services to the individual Medicaid client. Next slide. We had, as you can see from the legislation passing in 2014 to our first implementation in 2016, it took time to ensure successful transitions in each region. We had targeted readiness with each managed care plan to make sure that they were ready to do the integrated services. We established local leadership structures in each region to help provide guidance. We did rapid response calls. In the first couple of regions, we would start January 1st, New Year's Day, to have a check-in call just to make sure that nothing had fallen apart when we flipped the switch to integration. Followed many metrics through these groups established in each region called the early warning system groups, and then monitored and shared that information through monthly webinars. Obviously, the normal Medicaid compliance monitoring continues, and we track data and outcomes. Next slide. So just as Melody was describing, our partnership with research and data analysis and our Department of Social and Health Services, they also track metrics for us on the implementation of integrated managed care. In the first year of implementation through calendar year 2017, we had 11 indicators showing favorable change in a statistically significant way. Here are some of the ones that are most pertinent in terms of integrated managed care. Again, as Melody said, these reports are available online, and we can certainly share the details with you. But just to show that we are tracking closely our successes in each region. Next slide. The clinical integration parts that Kim was describing are still really in the building block kind of stage. Each managed care plan was creating its own pathway to clinical integration. So while we work on such things as ensuring that new programs and services are built into the managed care plan and assisting providers through the transition, of course, we've had 9 months where we had to focus on the impacts of COVID and changing our working system to telework, et cetera. We know that clinical integration is still our ultimate goal, and so we're working very closely with folks out in the regions called the Accountable Communities of Health on how to assess providers' progress in clinical integration, because that's the ultimate goal of this program. Next slide. I offered a few places to look for resources about our programs, including Medicaid transformation there at the bottom. And on the next slide, my contact information, if there's anything we can help you with in the future, we're certainly open to inquiries and can get on a call with any of you who are interested at any point. So thanks very much for the opportunity.
Thank you, Alice. Are there questions or comments for Alice? Representative Carpenter.
Thank you, Madam Chair. And maybe these might be questions for all of the folks talking about integrated care and answer it. A couple of questions I had right off the bat. Budget neutrality, how does that affect that? How have we been able to prove that when in their 1115 waiver? Another one is because of the difference in billing, how difficult has that been for the MCOs to orchestrate the difference in billing? And finally, have your numbers after 2017 still held up to the numbers that you have here?
Representative Carpenter, I think what we'll do on that, if staff did you get Representative Carpenter's questions? Okay, because we're under some time constraints with the folks in Washington. So staff will get those questions to them and come back with the answers for us, if that's all right with you, Alice?
Yes, I heard the questions. We do have some follow-up information we can provide on those things. Thanks.
All right, that's wonderful. You'll hear from our staff. So next up, I have Mary Fleece, Collaborative Care Codes, and this is her testimony.
Good morning, Madam Chair, members of the committee. It's a pleasure to be here today. It's also always humbling for me to go after Melody and Alice in these sorts of presentations. The portion that I'm going to review is the Collaborative Care Code model. Excuse me, the Collaborative Care Code model. And I'm hoping slides will come up. Great. Okay, the magic of technology. Next slide. All right, so a little bit of background. In June of 2017, CMS announced final rules for the Medicare payments for services provided to patients participating in a collaborative care program or receiving other integrated behavioral health services. And then in July of 2017, our legislature appropriated about $4 million to our program, our Medicaid program, for us to implement the collaborative care management model. And this model was based on Medicare rates. Typically, we don't use Medicare rates, but in this instance, we were. And we were able to implement then in January of 2018. Next slide. So the payment for providing care in the collaborative care model requires a group to have a team trained to deliver care following the model design. And that model, as Carrie referenced, was part of the AIMS design. It includes a psychiatric consultant, a primary care provider champion, additional staff with training in the aspects of behavioral health, and a registry for tracking progress and interactions with patients. The reimbursement for the COCM codes is limited to practices, groups, and facilities that meet those requirements and provide the required certification. So we did create a certification system in order to bring these codes up. Next slide. And when we were needing to do this implementation, we were looking both at New York that it had piloted this effort, as well as CMS. And CMS didn't have a standard certification process to use at the time. And New York had developed and used an application for signing up groups that provide this care. They had 2 dedicated FTEs for this program, including the sign up and education. The AIMS Center has a checklist that online that broadly outlines the requirements for the model's implementation, and a process to ensure practice fidelity to the model reduces the risk potential for future audits of the services. And that was really key to us as we were messaging to the provider community why we were asking them to go through this additional step of certification. And then aligning the certification and credentialing process with AIMS CMS requirements will also reduce those administrative burdens moving forward. Next slide. So as of May of 2019, which was over a year after implementation, we had about 86 provider groups that had submitted the attestation forms to the Healthcare Authority for participation. And it was also clarified that board certification in addiction medicine professional or addiction psychiatrist may be the consultant when the diagnosis is related to SUD. So initially we just started out with the mental health side of behavioral health, and we were able to evolve the model to include the substance use disorder portion as well. So very quickly, that was my presentation. We'd be happy to answer any questions you have.
All right, committee, are there questions? All right, seeing none, thank you very much for being with us.
Thank you. Bye-bye.
As we progress forward, you'll hear back from our staff as we have questions come up as our session gets started in January. So thank you.
Sounds good. You're welcome.
All right, next committee we have, and I'm going to butcher this, Leah Gagnon, CHCFEK provider.
Yes, hello everybody. Yeah, and you were really close. It's a tough one. It's Gagnon, but I responded to far worse. So you did great. So thanks, Madam Chair. Thank you, committee, so much for having me today and allowing me a little bit of time to kind of follow up on some of the things we've learned about integrated care today, and an example of what that actually looks like in Southeast Kansas. I did, though, want to follow up. I didn't know if we wanted to circle back to Kim Nelson before I hop on here. I just wanted to make sure she had the time, because I was able to push my other stuff back today.
Kim, are you okay on time if we go with Leah first?
I am fine with whatever works best for the committee.
All right, thank you very much. And committee, you might know, because Leah, we didn't have anything written from you to present to the committee, is that correct?
That is correct. I wish I had had a little more time to prepare something. So you're just gonna have to see my giant floating head wherever you're at. And I'm happy to maybe send any follow-up information as well. I know we've got some friends in the room from United and Representative Mernan. So I would welcome anyone to pitch in as I kind of go through this. So
yeah, I think what would be good is at some point is maybe you could hit some of the high spots that you're going to cover and get that to our staff so that we do have something written as we go forward into our next legislative session, please.
absolutely. No, I'd be
Madam
happy.
Chair, sorry to interrupt. Leah, Madam Chair, this is Sandra Berg with United.
Yes, Sandra.
There is a written case study that was done on the central or on the Community Health Center of Southeast Kansas, and it is in your packet. And it kind of goes through their model of integrated care and is available.
And then the first page is 6 boxes, starting with 27% of Americans. Is that the one you're talking about?
It should be a separate document that, excuse me, that says NADADC, I think, I have to look back at the acronym, but it's the National Association of Community Health Centers. CHC SEK was recognized for their integrated care model, and they wrote up a synopsis, yeah, of their program. So it should be a separate document.
I see the NAC, yes, okay, we see that. So that's something that we can kind of follow going through with Leah's presentation. Is that what you're saying, Sandra?
It should be, and then there is also a slide in our slide presentation that kind of outlines a few things, but Leah was going to talk more what's happening currently.
Okay, that's fine. All right.
Is that okay? All right, thank you.
Yes, and
having what we don't have. So Leah, you may continue.
okay, thank you. Yeah, and I will follow up with some of the highlights that I covered today. And I will also preface this with I started here in March, and it's been a bit of a marathon since. And a lot of the things I'm going to cover today are, direct benefits that the program I help coordinate here is reaping from the hard work a lot of our leadership has invested over the years and a lot of our community members. So I highly encourage you to reference that case study about how our integrated care model started. And I think that was dated August 2016. So it was kind of fun reviewing that and getting to share with you what it looks more like today. Because I think in there it references how, we hired a director of integrated care. Well, now we have a director of population health and working on hiring a director of patient engagement. We've got a vice president of health advancement that all really work to support what an integrated care model looks like. So a little bit about myself. I help coordinate the KanCare Kansas program, which I think most of you probably know a little bit about. It is our care coordination program for some of our Medicaid folks that are living with schizophrenia, severe bipolar disorder, and asthma. And I will say, a lot of the folks that we're working with that have asthma also have some sort of co-occurring mental health condition as well and are receiving behavioral health services. I also help coordinate our chronic care management program, which is kind of a parallel to the KanCare Kansas program for our Medicare population. And they primarily work with a nurse, and I kind of share responsibilities in overseeing those programs, but I also do help provide direct services, especially when it relates to community and social supports alongside our kind of team approach. And that is really the heart of integrated care, the 101. It is all about approaching patient-centered care as a team. And so when it comes to this model, I have the wonderful privilege to know what that approach looks like in practice here at the Community Health Center of Southeast Kansas, and what it can really mean for someone's health. And I think what I've learned ultimately, their outlook on life. So a lot of the service, and I will kind of be speaking through, again, my experience with coordinating the KanCare Kansas program, and again, how a lot of those services the program is designed for, the CHC has been doing for years. And I think, the little snippet we got from Washington, even in just a couple of years of starting to provide some of these services, they just absolutely explode because there is such a high need. So we really love the KanCare Kansas program because we're able to now kind of bill for providing some of these services we weren't able to bill for before to a small percentage of our community members. So just a little precursor on the CHC, we're a federally qualified health center, nonprofit. We cover 7 counties in the Southeast Kansas region and are growing our services in Northeast Oklahoma as well. Most of the services I'm going to review exist at our Pittsburgh clinic, which is kind of our poster child for those of you that know us, and where we're really modeling all of our other 13 plus communities, the clinics in those communities after. So when we think about integrated care here, it's really striving toward that everything under one roof, right? Really making it as accessible as possible to have all of the medical, behavioral health services. And I'll get into even some of the community health services available in one location. So on the medical side of things, we have primary care providers. That includes family practice, where we have 2 pediatricians. And we have grown. I mean, even thinking through COVID, it has been such folks need us now more than ever. I think when I started here, we had like 500 or so staff across our service areas. And I think the last update I heard is like we're approaching like 650. So, even through this time, we have grown because, again, there is just, COVID has just exacerbated so many of the needs for all care across the board. Again, I couldn't even tell you how many primary care providers we have, but it's quite a few. And then we've got internal medicine, and all of those providers that regularly have a panel of patients also have to have same day appointments available on their schedule, so that if one of their patients has something or needs a hospital follow-up, or went to the ER the other day and they really just need to get in to see the care team that knows them and knows their situation, we have those slots available for them same day. We also have dental, which right now is in a clinic downtown, but they're getting ready to transition and move into the same building. We have imaging, radiology. We also have a pharmacy here on site, and most of our other clinics, if they don't already have a pharmacy, are working on the space for one. And then we also have walk-in care, which is a really great opportunity to talk to a lot of our folks, especially our Medicaid folks, about, hey, before you think of calling EMS, you do know that we've got walk-in care 7 a.m. to 7 days a week available for you to see somebody. And again, we have imaging and things. Some of the things that folks are worried about is, well, if I come to walk-in care, I'm then just going to have to, go to the hospital, which sometimes that is the case. But again, really trying to provide everything that they could possibly need in that one visit here. And so down the hall from all of those services in the same building is our behavioral health, where we have a panel of psychologists. We have 4 providers that provide psychiatry services. And then we're also a certified addiction treatment service provider, which includes 2 counselors, a nurse that works with our folks, a social worker, and then our peer support specialist, who is amazing. And we rely on her a lot, especially with the KanCare Kansas program. Anybody that is looking to go through a tobacco cessation program is referred to her with lived experience in addiction treatment and in recovery. And another neat part about that tobacco cessation program is that we do have our own in-house that partners with one of our providers, and then our pharmacy techs who have been trained in, talking folks through those NRTs and working through on their treatment plans. And then again, because they're all in the same system, we all share an EHR, they can communicate with their whole team on progress and needs. And then also in our behavioral health services, we have a behavioral health contact or consult. Right now we have one primary behavioral health consult, and then our other psychologists kind of block their schedules to be available for someone that comes in to walk in, or someone that is just here for regular follow-up with their primary care provider. And while they're talking to them, they may identify some needs for mental health services, or even just someone to talk to at that moment. During like regular follow-ups or chronic health management visits, our providers are asked to do a PHQ-2, which is a 2-question depression screening on everybody that they see. Now, if they have a depression diagnosis in their chart, they are required to do a PHQ-9, which is the 9 questionnaire for depression risk, and directly asks about self-harm or harming others. If we need to have that BHC contact respond to any sort of crisis, that they are there. Having that shared EHR and having everyone in that same system, we've actually been able to use integrated and linked care plans. So it's really neat, and we're hoping to implement this for some of our care coordination and care management efforts down the road. Is that these care plans that maybe a psychologist is working on with a member can also be used right alongside maybe some health goals, and so then when they're seeing their primary care physician, they can pull up that linked plan right there in the progress note and say, hey, I see that you've been working with our OneCare nurse on trying to walk 10 minutes a day. How's that going? And really just, again, kind of just make a cohesive effort on everything, that whole person, patient-centered care. And so we've covered medical, we've covered behavioral health, and kind of what that looks like with our EHR, and some of the mechanisms we use to track our efforts. We have been growing our initiatives in community health outreach and support with our team of community health workers and what is referred to as our community health action team, or CHAT. Because we recognize that most of what impacts someone's health happens outside of the clinic. So you talk about boots on the ground. These are the folks that are doing home visits and doing blood pressure checks, and folks right there in people's home or on their front porch, following up on any ER visits, delivering medications, because if you think about, and even just checking on any social determinants needs as well, you think about someone that's maybe being treated for anxiety and depression. Well, if they've got an $8,000 delinquent utility bill hanging over their head, that might be something that's triggering their anxiety and depression. And so maybe when we can address those needs and talk with the utility companies about working with the community member on on an affordable payment plan, things like that we've done. And as our Washington friends mentioned, the greatest needs that we're seeing among our community health worker team are transportation, food, safe housing, right? And we're working to have specific staff members really specialize in addressing those needs and working with community members. And then the fourth one I would point out is health literacy. So something we really try to work with our OneCare members on, it's always the low-hanging fruit, is what does it mean to have asthma? What does it mean to have schizophrenia? What do my treatment plans mean? What are the medications that are addressing those diagnoses? And how do I talk to my providers about this? And so when it specifically comes to our Medicaid folks, there is so much opportunity alongside that of just understanding their benefits, and helping them kind of coach through learning. Like, I mean, I can't tell you how many, probably 4 or 5 times a week I talk to somebody that has no idea that they are eligible for rides, unlimited rides to all of their appointments, just because they have Medicaid, with one of our MCO friends. Yes.
Is it possible for you to, kind of summarize? We're hitting up against a time crunch here, and
yes,
get back to Kim, please.
Absolutely. So yeah, so thinking about all of that, when we're working with these folks, it's important to keep in mind that, they didn't get into these situations overnight, and it's going to take a lot more than one visit to get them out. So, I always think of, we've come a long way, but there's always more work to do. So the main thing that's missing are care management opportunities. And that's really why we love KanCare. But we know that we're missing a lot of our community members, and especially a lot of our Medicaid members, that could really benefit from some more of that continuity of care. Even if we just zero in on the behavioral health services, it's really rare to offer psychiatry without care management, without someone following up on your medications and your treatment plans, and addressing some of those social determinants of health. So I'm a huge believer in care management and what the KanCare program has done for a lot of our folks. And then the fact that we have, all of these services under one roof is, it just all makes this really beautiful glue that kind of holds the integrated care model together. So that was pretty much all that I had, but the main struggle we run into is that because we are an FQHC, or even just because we're not a CMHC, we can't bill for services like targeted care management. So that is something I would love to encourage the committee to explore more opportunities for us, because there's a lot of work to do, and we really love this work and are so happy to be here in these communities. And thank you very much for your time. If you guys have questions, I can put my email in the chat, and again, make sure that the committee has it for any follow-up items. And I will conclude there. Thank you.
Thank you, Leah. Now, when you're talking about not being able to bill for the coordinator, are you talking about the case management code?
Yes, TCM.
All right, I just wanted to verify. Sometimes, I'll have one group use one terminology, another one use it, and it's like, okay, wait a minute, exactly what we're talking about. So, all right, thank you. Committee, are there quick questions for Leah at this time?
Yes, Madam Chair.
Representing Murnane.
Can I just say, that's my community.
I would have been shocked had you not asked to speak, Representative. So
and what she said, multiply it times 1,000. If we could build that code, the work that we could do for people would be astounding. Pretty simple policy change. I think the group can do it.
All right, thank you. All right, now, Kim, you have been waiting patiently out there, and we very much appreciate that. So we're going to come back to your presentation, and were we on page 7 or 6? I think I'm at the right page, but I am not sure.
Thank you, Madam Chair, and I will be quick. I really planned on going through the rest of this presentation quickly. I think you've heard the most important things, which are what this looks like in the community. So I'm gonna share my screen again and hope to just go quickly through the rest of these slides. And then I'm right here. So I'm always available for, time, anyone that wants to talk with me about this topic.
Thank you.
All right. Sure. My pleasure. Okay. So let's see, there is my screen, but let's get this in the right format. Okay. You can see that? Okay, great. Thank you. All right. So I think, this is slide 7. And so this was just me kind of saying, Congress codified the Certified Community Behavioral Health Clinics in the PAMA Act, which is part of the Excellence in Mental Health Act 2014. And then I'm just going to skip this next slide. We've already talked about why CCBHCs. Well, mostly because we have got to figure out ways to treat people as the whole person, whether that's in our primary care system or our behavioral health care system, or maybe a combined system, which is really what CCBHC is about. This is just a quick timeline of the CCBHC process. It started in 2014, again, as a Medicaid demonstration. There were, it was released that any state could apply for this demonstration. There was a preparation phase, which we called a planning phase. 24 states down below in the second phase, 24 states were awarded planning grants and started doing planning work. And then the actual, up in number 3 there, the demonstration phase begun, and 8 of those 24 states were selected to be demonstration states. Important for us in our region, Missouri was one of those 8 states. And so then in phase 4, this is also important to understand, SAMHSA was awarded dollars through, the appropriations process in Congress gave SAMHSA dollars to then award grants, very different than the demonstration program. We have the Medicaid demonstration CCBHC program, and then SAMHSA grants, which begun in 2018, which happily, speaking of that bottom right-hand corner of the state, Southeast Kansas, the mental health center in that area was awarded one of these SAMHSA, what we call CCBHC expansion grants. Very exciting. So moving on just quickly, this really says kind of some of the key provisions of a CCBHC. So they provide services to everyone, regardless of ability to pay. Important. Okay, again, these are the Medicaid demonstration, requirements or provisions, a few of them. They are required to coordinate primary care and behavioral health care to include substance use. Be patient-centered, of course. A key component of this system is, as you heard from Washington, this prospective payment system. It is the way that services are paid for in the behavioral health world. So in the FQHC world, this has long been kind of a different payment model than the CMHCs. The CMHCs, community mental health centers, have long been in a fee-for-service payment model, which seriously hampers their ability to do integrated care and care in general, really. So this model moves them into this prospective payment, either daily or monthly rate based on their costs. So this is what the certification criteria at a very high level requires, these 6 program areas for CCBHCs to have, staffing that can meet the need in their local community. 24/7 availability and access to crisis response services, that's a pretty big deal. Care coordination, as has been mentioned, I'd say of the things on this list, the care coordination and the staffing are key linchpins really in the certified community behavioral health work. And because of the prospective payment system, CMHCs are more able to provide the kind of staff that they need because they're being paid based on their costs. They're more able to provide the staff that are needed to support people that have, these chronic conditions. Care coordination, again, instrumental in helping people stay out of hospitals and higher levels of care. The scope of services, I'll talk a little bit more about that. Quality metrics, we'll say a little bit more about that. So these are the quality metrics. There are some required through the demonstration project and then some required through the state. We won't go into a lot of detail about that. We could talk about that for a long time, but just know that there are quality metrics that are required. And these are metrics that are really intended to measure quality of life for people. So not just how many people were served through, how many people accessed care, but are you doing better in your life type quality metrics. Very important. This is just a visual of this process I just told you about. We had the planning grants that then were followed by the actual demonstration program and kind of the certification process, the development of the prospective payment system, et cetera. This is, again, just a visual of the services that are required. So there are required services that must be provided by the CCBHC themselves, the actual, the crisis services, treatment planning, screening, outpatient care. Then there are, in the lighter blue color, services that can be provided by what we call a designated collaborating organization. So someone that this CCBHC has a written agreement with to provide this care. It could be that they provide the care themselves. They could, for instance, a CMHC could have a designated collaborating organization agreement with an FQHC, for instance, just examples here of, to provide some of these other, but it has to be written agreements and there have to be kind of shared files in a different way. And then of course, lots of referrals still. I'd say just also important to point out again, in this CCBHC model, we're talking about providing mental health care and substance use disorder care. That's required. This is just kind of a quick schedule of the reports that are due to Congress for the demonstration project. So you see that one is due next month. That will be, important, and I'm sure you'll keep your eye out for that, as we all are, so we can kind of see what this looks like in terms of outcomes. Right now, we do have a report from 2018 that was out in September of last year, that has kind of the initial metrics and kind of where we are in that process. There are some really interesting, if you haven't looked at this, interesting things, especially about Missouri in here. Missouri really cites staffing as being, a huge advantage in this model. This is just a little more detail about the difference between the Medicaid demonstration and the SAMHSA grants. So I think the primary difference is, the Medicaid demonstration has the PPS, the prospective payment service, as part of its demonstration project. The SAMHSA grant is a 2-year grant that's awarded to a CMHC to do work for about $2 million for about 2 years to move toward becoming a CCBHC. But it's kind of a one-time funding, not something that is integrated into the Medicaid system for funding, for instance. All right, this is just, SAMHSA's CCBHC grant kind of release schedule. We started in 2018, did some off-the-shelf grant awards in 2019, and then in 2020, really, got some additional dollars from Congress and were able to fund a larger group of folks for 2 years, $2 million per year. This is where Southeast Kansas's Community Mental Health Center award was in that 2020 group. So this just shows you where the initial awards were in our region. It's in red, Iowa and Missouri. But we just heard from Washington State, and are they on this list? They were not awarded, and they were not part of the demonstration project in the first year. So second year, 2020. So we see, again, we don't see these are awards that went to specifically to providers. And so this is the cohort that had Kansas, Southeast Kansas Community Mental Health Center getting that award. So congratulations to Greg and his staff. This is just a little more detail about the Missouri's project because they're so close by. Missouri really went all in on this demonstration. So the demonstration required, 1 or 2 community mental health centers in a rural and an urban area, and different states did this differently, back to the 8 states that were awarded the demonstration. Missouri, uniquely among all the 8 states, went all in on this project, and they are really transforming, have transformed in a lot of ways, and continue to transform their entire behavioral health care system into a certified community behavioral health organization system, they call it. You can see here that most of the state is covered. So the gray areas are the ones that are not covered by a CCBH. They call them O for organization. So most of the state is covered. They're in the process of, the other parts of the states coming in. Missouri is a great example of transforming their system using this demonstration. Here are just some early outcomes from Missouri. This was year 2. We're going to see additional outcomes for year 3, like I said, coming up in January. But, they saw a 20% increase in access to care. That's a pretty big deal. 25% increase in veterans' access to care once they implemented all of the components of a CCBHC. Lots of communication with law enforcement has increased. Increasing school mental health, one center by 81%. They're seeing good rates of patient satisfaction. Importantly, at the bottom of this slide, they're seeing decreasing ER and hospital admission visits, which, as we know, really means people are living better lives if they're not having to use that kind of emergency care. So these are, resources. There's all kinds of resources. If you want more about that, just contact me. But SAMHSA still funds a Center of Excellence on Integrated Health, and that's at the National Council of Behavioral Health. The National Council on Behavioral Health also has a CCBHC Success Center that really tracks kind of what's happening throughout the country. And then there's my contact information if you want to chat with me anytime. Okay, hope that was helpful.
All right, thank you, Kim. Questions, Representative Ballard? Yes, Kim, thank you very much. That was very helpful. I do have a question with the grantees by state, and you mentioned that Kansas was accepted this time. And I'm looking at the next sheet that talks about improving outcomes and access to care. What did they specifically do that would increase the participation rate with veterans to 25%?
Outreach is, I don't know exactly, and thank you for the question, Representative Ballard, and I would defer to Missouri, specifically to speak to that. But a key component of certified community behavioral health is outreach, and specifically to target our veteran population. And so their outreach into the veteran population, their ability to have more staff, more qualified staff, and longer hours of operation, and same day appointments. Often all of these kind of pieces that come together with a CCBHC that allow for this service to be more robust, and combined with their outreach efforts, that crisis care, that 24/7 crisis care, all of those components come together, I think, to create better access in general and specifically for veterans.
Thank you, Madam Chairman. I especially asked for that because our Social Services Budget Committee really has veterans as one of our groups that we fund. And what we do know from the veterans is that we have been very short on field operations, which would be your outcome, getting out there. And so if this is increasing that outreach participation and enrolling more, making them aware of them, helping them through it, or even opening different like satellite locations, which we have been very short on doing. I'm hoping that's what this is doing, because 25% will help significantly to get the message out. I'm sure it will decrease the suicidal rate, or at least help along those lines. So thank you so much for just highlighting that. And boy, I am just really excited about that kind of service. Thank you so much.
Madam Chair.
Representative Murnay.
Thanks. Kim, I'm sorry. who in Southeast Kansas was awarded that?
4-county mental health.
4-county, not Southeast Kansas Mental Health in Iola, but 4-county in Indy.
So sorry that
No,
I
thank
was
you
not
so
there.
much. I appreciate you clarifying that for me. Thanks.
Senator Petty?
Thank you. And thanks for this presentation. I was looking at the outcome sheet that you've provided on Missouri, and I just had a couple of questions. I noticed, so some of these stats, are they program-wide, and some are just, it looks like I see on this, serving more patients in the community, it says a rural. So that just would be one of the sites. I mean, I know Missouri's a little bit different than any of the others in that they expand it statewide. So is that true with this improving outcomes and access to care? Is it some of them are statewide and some of them are just one site?
Thank you for the question, and you have interpreted it exactly correctly. So some of these outcomes, when they say overall increase in veterans care, in access to care, that is for everyone overall, the average. Others are a specific CM or CCBHC that, you know, had was highlighting an area of improvement in their community. This is very community specific in terms of a model. So while the statewide demonstration is important that it happens at a statewide level in terms of system transition, the cost-based funding for this, for instance, means that each of these CCBHCs are paid differently. It's not some statewide PPS. It is based on the community that the CCBHC is operating in because costs are different, right? So it allows for, and communities have different needs. So this really allows those needs in a specific community to be targeted. That's why I think you see, you know, the outcomes presented that way.
Thank you. And just one of the other outcomes, the one with the law enforcement collaboration, was that 38,277, was that an increase of referrals from over the 2-year period?
So I don't know the answer to that. If that is just a, you know, a total, I could certainly ask my Missouri colleagues and get a clarification about that. I think that is just the total over, you know, between 17 and 19, the number of referrals that came from, you know, into a CCBHC from a law enforcement source. But I could check.
Thank you.
Yeah, to tag along on that, would you also think you'd be able to provide an age breakdown of what that was on that number Senator Petty was referring to? On 38,277 with the law enforcement, you know, what is the age breakdown? I think those are important numbers for us to watch.
I will definitely ask my colleagues in Missouri that put this information together and get back with you all.
Thank you. Committee, are there other questions here in the room? Are there any questions or comments from Zoom? Kim, I had one on the page 12 on the quality measures. And my question is this tracked by person or is this just an aggregated amount? Aggregated measures, I should say.
Right. Again, you know, I believe it's patient level or person level data, but I hate to absolutely say that. I'd want to just check and be sure.
Okay. Well, the reason I bring that up is we've had a lot of discussion in our mental health modernization committee that's been working this interim, and, you know, trackable, measurable outcomes. And we got to where I think we pretty much, Representative Carter, removed the word data, because it was just, what is data? You know, we know that as a state, we collect a lot of data, but it doesn't mean it's in a usable form. And then some of that went back to the mental health K-12 pilot program that we've had in place for 3 years, that we track every single child individually so that I know, is Johnny got less disruptions in class, less absenteeism, less tardings, improving on his grades? I think we've got like 10 or 12 items that we track, but it's in a trackable database. So we just know how important that is. Every time we add a new program, we think we're tracking things and we find out, no, we're not. So we're wanting to get into more detail. So I think that if Missouri's done some of that, that would be very beneficial to us.
Excellent. I will check.
Comments. Committee, are there further questions or comments? All right, Kim, thank you very much for being with us here this morning. We definitely appreciate you assisting us here.
It's my pleasure. Always happy to help. Thanks for having me.
Okay. Would you like to get in now? Okay, because we still got a few more minutes. Okay, now, committee, I think we are back and Orion can correct me if I'm wrong, but I believe that I'm ready to go back to our regular purple, lavender, whatever we want to call it, agenda because of the additions that we had this morning. So the next person that we will have up will be Dr. Will Warrens, Medical Director of Behavioral Health for Sunflower Health Plan. Dr. Warrens, are you out there?
Yes, thanks, Madam Chair. The MCOs did collaborate last week, individuals from United and Aetna, and I would say that one of the leaders of this collaboration has been Sandra Berg from United, and she's put some slides together to present. Although I am here along with her to respond to questions that the committee might have.
Okay, did we have a written presentation from you or Sandra? Oh, it's this one right here. Sandra, did you want to go through some of these items here, or how would the two of you like to proceed?
Yes, Madam Chairman, thank you. And thank you, committee. I will go through the slide presentation. Dr. Warrens and others from our group that put this together are also on the Zoom call, so they may jump in as well. But I'll start through the slide presentation. My screen share up here. Okay, can you see my first slide on integration care models?
Yes.
Okay. So the three MCOs met and we pulled together some information, and I won't go through all this data. I think we've covered this pretty well in the previous presentations, but we really wanted to emphasize what is happening with folks with mental illness, substance use disorders, and how it impacts their health. And I think Kim did a good job, as others did too. It's a pretty serious situation for folks that have both mental health and physical health challenges. So on the next slide, we put together some benefits that we see for integrated care. And before I go further, I want to talk a little bit more about how we see integrated care. And it flows across a continuum. It's, we've talked about the siloed effect where different provider types are providing their services, but aren't crossing over or aren't checking into the other piece. So if a primary care physician, if I go in to see my PCP and she just checks my vital signs and what's going on with my physical health, but doesn't talk to me about behavioral health issues, that's the very far end of the spectrum. What we are trying to move towards is what Leah described as a fully integrated model where, all providers or most of the primary providers for behavioral health, primary care, substance use are housed in one system, sharing a shared record for everybody to be able to see what is happening, tracking outcomes and those kind of things. So when we talk about integrated care, we're talking across that continuum and that spectrum of integration. So when we have integrated care, we see higher treatment compliance, we see greater patient satisfaction and people living longer lives. we also see a significant decrease in healthcare costs. And integrated care can give more opportunities to treat the whole person, as Leah described earlier. We can resolve some of the data and system barriers that we've talked about in the Special Committee on Mental Health Modernization. You know, one of the challenges is how do we get information from one provider to another? But when they're integrated and they're sharing a system, they have access to that information. It also empowers our providers and the care teams to respond more broadly and adequately with issues. So thinking back to my days as a clinician, when I was doing therapy, I had a person come to me who was falling asleep when she was driving. And we knew that she was suffering from some depression. But what we also found out by digging a little bit further and referring her to her primary care physician was she had sleep apnea. Combining the focus with behavioral health and looking at any physical health symptoms helped her get to the point where she could drive again, not fall asleep, and gave her a better health outcome. An integrated care system can also change attitudes about behavioral health and helps reduce the stigma. Unfortunately, we still have providers across the system that don't want to treat behavioral health or are reluctant to because of either the stigma or their lack of confidence, whatever it is, but we need to move past that so we can get people to the point where they are being treated holistically. We also see the increase that individuals suffering from mental illness or substance use will get a timely and appropriate intervention. So if you're going to your primary care physician and he's treating you for an ailment that could be exacerbated by a behavioral health issue, having that ability to see that perspective will also impact the intervention that they're going to use. On the next slide, we have a case study about Hannah, who moved from hardship to helping others. Hannah is a compilation of several members that we put together, and these cases are real live cases that we do see daily here in the managed care organization world. A mother of 5 struggling with asthma, Crohn's disease, anxiety, depression, bipolar, PTSD, and substance use. Her spouse also had a substance use disorder. And because of their drug addiction and the struggle, they lost custody of their 5 children. Since she was new to the area, she wasn't really sure who to go to. She didn't have a relationship with a provider, and she didn't know about the community resources. So working with her managed care care coordinator, she was able to find a practice that was integrated. Her new primary care physician assessed her health and recognized the need for her physical, behavioral, and social supports. I think we've talked about that a lot today. Really appreciated the Washington folks talking about the SDOH and how important that is in assessing a person's needs. And because of the assessment that they used, they were able to share the information with both the physical and behavioral health providers and look at a shared care plan that everyone could be working on together that would help monitor her health, her progress through her treatment, and what other support she might need. She also got referrals to the community, such as transportation and local food banks. The outcomes for Hannah were she was able to continue to see her primary care physician, her counselor, and specialists to make sure that they were all working in conjunction with each other. She completed her outpatient substance use program without any relapses, and she performed so well, she was able to be employed at the recovery center as a peer specialist to help others with struggling, drug addictions. Hannah and her husband are both sober, living together, and they're in the process of getting their children returned to them. And she continues to share her story with others who are struggling with addiction and helps to mentor them about her process and what the hope is for them. One of the other things that we did as the 3 MCOs coming together is we looked at what are the system barriers we have in Kansas. And we put those into 3 different buckets. One is the communication and collaboration. One was around infrastructure and investments. And the other was around incentives and performance. So under the communication and collaboration, we have all talked about the silos, the limited availability of care coordination, how different parts of healthcare structures are in different organizational and political management, so that creates a barrier. Even suicide prevention is currently siloed, and we really don't have a good, strong system across the state to really address the suicide crisis that we have now. Again, we have disconnected systems that hinder our data collection and looking at outcomes. We have restrictions in place that limit patient sharing information, and some of those restrictions are federal, some of them are state level. We don't have a really strong infrastructure and resources available to implement integrated activities. Some of the incentives and performance barriers that we see are state and federal policies around reimbursement for care, and then payment models that don't always encourage coordinated efforts. On the next slide on provider barriers, we looked at the 3 same cohorts or buckets and looked at differences in how providers and practices establish their culture around integration, some of the lack of collaboration between facilities and providers in the community, and the resistance to change that exists within organizations and within even the external environment. Excuse me, we also looked at the inadequate adoption of standardized screenings. Leah mentioned a couple this morning around the PHQ-2 and the PHQ-9, which are depression screens. We also have the SBIRT, which is a early screening for substance use, which we see very little utilization with here in the state, but it helps early identify and set treatment for people with substance use disorders. We also see the separation, the physical separation of our mental health and physical health and allied health partners within the system. And of course, the electronic management or electronic medical record management doesn't always interface with systems or across systems. And then funding and reimbursement models don't always incentivize integrated care. And it's really difficult to measure the performance through incentives without a fully integrated model. So on the next slide, we as a team walked through the different recommendations that are going to be going through the special committee. And we also looked at what our barriers are and tried to tie those together. So I won't go through this whole slide, but I wanted to really point us out of what are some things that we can do as a state to help move us along that in the continuum of care towards integration. So some of these: prevention, early intervention, having multiple disciplinary team integration, person-centered focus, on down the list. And then we tie them to the specific committee recommendations. Now, this isn't all inclusive, but we wanted to show how the recommendations that we felt were important for the state tied to the committee recommendations and where they fell in the impact, either with the provider or with the system as a whole, and whether we felt like they were immediate or strategic, following the same rubric we did for the committee recommendations. And then on the last slide is a visual of the triple aim in what we are trying to accomplish when we look at integration. So we want to manage costs and utilization. We want to increase population health and improve the experience of care for those in our system. Following this slide, there are some appendixes, and those are just some examples of different integrated care models. We've already heard about several of them today, so I won't go into those. And I will ask Dr. Warrens if he has anything he would like to add, or anyone else from the committee.
Thanks, Sandra. I guess I've been with the MCO world for about a year, not quite a year and a half now. So I'm kind of new to working at Sunflower, and I'm sure United and Aetna would have an equal amount of ways in which they are trying to internally work on integration. I can only say at Sunflower, one example is, having to work on silos is just as pertinent internally as it is to the state of Kansas and it is to the providers. And, I'm very impressed with hearing some of the stories of how providers are extending outside of their comfort zone to try to work on integrated care. I had to kind of take what I had as my skill set, board certified in family practice as well as psychiatry. And at Sunflower, this is just an anecdote as an example of how integration, we are attempting to move in that direction. Our language at our administrative meetings is becoming much more integrated. We are trying to minimize any time that a conversation extends regarding a certain member and it drifts from physical health to mental health to substance abuse. We try to design our meetings now so that there are representatives from all aspects at every meeting, and the conversation can continue in an integrated manner. We round on our complicated members recently, or frequently, complex case reviews, complex case management rounds, inpatient rounds, PRTF rounds, and those rounds, we are now having behavioral health representatives sit in on physical health rounds and vice versa. That was step one, is that we can have these integrated rounds as all of our rounds, and the place we are trying to go to next is just fully integrating the rounds. So we don't have behavioral health rounds and physical health rounds. They are one round. So then our treatment plans that we're supporting are more comprehensive and collaborative as we're creating them. I'm not saying that Sunflower is superior in any way to United or Aetna, because I'm sure that they have anecdotes that are identical, maybe with different flavors to them on how they are working on integration. But the work is everywhere, and it's broad, and it's a big task. So I guess that's all I would add. But thanks, Sandra, for your presentation. I think it sums up a lot of what we're dealing with.
You're welcome. Does the committee have any questions? Any questions at this time?
Representative Ledward, or I think I heard Concannon. Are you?
No, actually, I recognize, this is Barbara Bell, and I recognize you, Representative Mardan.
Thank you. So if you hang around in this world long enough, everything comes down to codes, because codes mean reimbursement, and codes can oftentimes be incentivize those providers to break down those silos and those barriers. So people who are going to do the right thing because integrated care is the right thing to do are going to do it no matter what, and they're going to figure it out. But those who maybe need a little bigger shove can oftentimes be incentivized. So in Kansas, we have a set of codes that can only be used by mental health centers. Am I correct on that are specific to targeted case management? And right, Sandra?
Yes, that is correct. It's there are rehabilitative codes that are only allowed by the CMHCs to be used. So it's not just targeted case management, but some of the other rehabilitative services for mental health.
But we're talking about a handful of codes, right? I mean, like less than 10 or 15.
Yeah, I would say that's probably accurate.
And those codes don't pay massive amounts of money. So for example, T1017 is a code that in Kansas can be used by early intervention providers. What we know is Tiny K. And it's called Family Service Coordination. And it only pays about, $4 every 15 minutes. But that $4 is, when you have somebody on the phone trying to coordinate care for a family that's super high risk for an hour, you'll take 4 times 4 for $16, right?
Right, yes.
I'll take it. Thank you very much. And so that is essentially what you're talking about. And the codes then kind of do two things. One is they continue to push forward the people who have figured out how to do the work and know that the little bit of expenditure saves you a lot later on. And then two, it incentivizes those who are in your other buckets of communication and collaboration and silos. Would you agree with me, Sandra, or am I making this too simple?
I didn't catch that last part.
Would you agree with the allowing the codes to be spent could do both incentivizing and rewarding good behavior? Or am I simply making this too simple?
I wish it were that simple. Yeah, the codes do play a big part in how we move towards integration. And even though integration is the sharing, there are still specialists that need to focus on what they do best. So when we talk about those the psychosocial, the rehab codes that the CMHCs currently quote unquote own, they do those the best. Do we want to spread that out over other providers? I'm not going to make that determination, but I think when you start looking at integration, you don't want it to become a melting pot. You want it to become a salad bowl. Does that make sense?
Absolutely. It doesn't take away from any particular group. You have to have the lettuce and you have to have the tomatoes, and you don't want to have them pureed together into a soup.
No, I'm not too big on smoothies.
Yeah, thank you. Thank you, Representative Ballard.
And this is Will Warren's too to respond to is not all of the codes I think you're mentioning are low dollar codes. Some of them are high dollar codes. But I think one element of caution that I think Sandra is hinting at, not to put words in her mouth, but I certainly would hint at, is that I don't think we're disagreeing with what you're saying, the premise. It's just looking at what the overall effect would have on the system. I have red alerts of lots of caution. It's not that we shouldn't have that conversation. It's just that there.
What are your red alerts?
Well, Kansas has a very robust CMHC system. We certainly can point out the shortcomings in it, but if you've worked in other states, there's certainly a lot of states that it's superior to. You know, for instance, I've worked in Nebraska and Iowa, and they pale in comparison to the CMHC system we have. We have the strengths and the weaknesses of a CMHC system. So if we were to say, open the codes for the sake of collaboration, what would that do to our system? So again, it's not that we shouldn't have the conversation, it's that I think there would be downstream effects that we would have to plan for. If that makes sense. I mean, we could devastate our CMHC system if we're not careful.
How?
And I think Representative Murnan, and because we get into the code discussion, and that can take us really into the weeds. And you and I've had some of these discussions before, is in talking to my counterpart sitting here in the room, the chair of social services budget and his ranking. We've always proceeded with caution in anything that we've done in expanding our codes. And you have to look way out and see what these long-term ramifications are. What are you changing? Because we have people come in every day to the legislature on a regular, not every day, but on a regular basis and say, you'll just open this code. Well, if you just opened that code, well, if you just did this. So what do you do with it? And one of the worst things that we can have happen is that we dismantle some of the systems that we have out there, number one. Number two, there's that fiscal side of it, because there's a huge fiscal side, as Will pointed out, on some of those codes. And as much as we may want to open them, we can't pay them. And that's an even bigger issue going into this next year with our fiscal constraints. We would be in a lot worse shape right now in Kansas than what we are if it hadn't been for about $384 million in Medicaid enhancements by the feds. that was able to free up some of our SGF in the Medicaid system. So happy to have that conversation with you. I'm just not sure we have the time to do that because I'm already taking the running behind. But I appreciate Will's comments. I do appreciate your comments as well, Representative Meridian. I think unless you oppose, I think I'll move on to Senator Hildebrand at this time.
Thanks, Madam Chair. And you kind of touched on what my question was. What would be the fiscal note if you did open up the codes for the integration and collaboration where it was effective? Do we know what that is?
We'd have to work on those numbers.
Thank you.
Any further questions or comments in the world of Zoom?
Madam Chair, this is Sandra Berg at United.
Sandra.
I just want to say that outside of the conversation around code opening, I think there are maybe some creative ways that we can look at incentivizing providers to work together. Haven't quite figured that out yet. Still working on it with a few of our providers here at United. But I think that we can look at what barriers that we put in place for them to do that without going through the process of opening codes and doing that kind of thing. I think helping them get to that point where they are working together is part of what we can do as a managed care organization.
Well, Sandra, I think that, that's kind of an excellent point. I think there's been, for whatever reason, and I think part of it just has to do with the political environment that we operate up here, is a little bit of frustration between our FQHCs and our CMHC, and that frustrates me because there shouldn't be. Those two should be working hand in hand together. And as you say, they each have their own different codes. The FQHCs have the luxury of having a higher enhancement rate at cost versus what our CMHCs do. So it's a major deal for us to take and look at, but staff will try to gather some of those figures and make sure that the social services budget folks have those to work with. Any further comments or questions? All right, committee, we're going to move on. We have Maggie Myers. Maggie Myers.
Sorry, Madam Chairman. I think Maggie Myers is one of the representatives that's part of the MCO collaborative, along with myself and Sandra Berg, and she's. I think I'm representing her, and what Sandra presented, I think, wraps up what she would have said, as well.
Put the three of you together.
Correct. Yes, we all work together, and the others that you see on that list were part of that collaboration, unless you have questions specifically for the individual MCOs.
Are there any questions for the individual MCOs? Hearing that, sounds like that we're good. Now, Sandra, I also have you, because I have Michael Stevens up next, and then I have you behind him again. Is that correct?
Well, that was part of the collaboration. Instead of us doing individual, we just did it all into one slide presentation. So unless you want to hear me talk more, I don't have anything else to say.
I'll hear from you. There's not a problem with that. All right. Thank you very much.
You're welcome.
So we're out of do. So that's
those are the only two that are presented.
all right. I want to verify just so that I'm not skipping something, because I'm actually kind of excited. We might be on time. Is that we had Aetna had some folks on here. They had some folks from CVS. So with the presentation from Will and Sandra, that was all lumped together. This just gives us the information and the contact stuff for people that we can use for resources in the future. Would that be correct?
That is correct, Madam Chair. This is David.
Oh my, I tell you what, I love all you people out there. So I know that, we're kind of rushing through some of these things, but it gives us a good start going forward. And like I said earlier, this discussion on the integrated care really became a major point in all three of our working groups that the mental health modernization reform was working on. So I look forward to having continued discussions, and we'll probably be reaching out to your sources. So thank you very much for being here today. And those that are possibly online listening to this that joined us from the MCOs, we appreciate your time as well. Committee, what we're going to do now is we're going to recess for 15 minutes. Your lunch is outside the door, and we can thank Matt Hickam and with Sunflower for our lunches today. And if you'll be back here in 15 minutes, we're doing a working lunch once again, which just kind of keeps us moving forward. And at 12:15, we'll have COVID and long-term facilities and start off with Scott Bruner, Deputy Secretary of Hospitals and Facilities, and I believe he's with KDADS. Is that correct? Yes. All right, 15-minute recess.
Oh my God, I was like, how am I going to do? All right. I love that they work together because we don't have to have one MCO that another
Ready? All right, we're going to go ahead and proceed with our schedule. So we're going to talk about COVID-19 and long-term care facilities. It's an issue that many of our constituents have asked us about. There's different changes that have gone on. There's concerns out there. So first up, I have Scott Bruner, Deputy Secretary of Hospitals and Facilities. Are you with us, Scott? Oh, there you are. Oh,
I am. Good afternoon.
Welcome to committee, Scott.
Thank you for the invitation and the opportunity to do this by Zoom. Hopefully, if you have a problem hearing, you'll speak up and stop me. I have been watching some of the morning, but I'm not sure. Do you want me to share my screen to show the slides, or do you want to work off the paper copies you have, or how would you like to proceed, Madam Chair?
I kind of like it on the Zoom, if you don't mind that, because it's where other people can watch us at the same time. I think it's helpful for those that do not have the handouts. All of our committee members out there on Zoom should have your handout.
Okay. Let me try to see if I can get this to share and present it as well. I think I've got it up on the screen now. There's just a title slide that doesn't have my name on it, but my name's Scott Bruner. I'm the Deputy Secretary for Hospitals and Facilities with KDADS. Thanks for the opportunity to be here today, and I wanted to focus on the questions that you advanced to us to ask about. And so I put them here on the slide mostly for me to keep track of as I was responding to them, but it's helpful to use as overview. So first I want to talk about the testing machines and testing kits for nursing homes that have been provided by the federal government. Spend a little bit of time on that. And then the last three bullets are really about the testing strategy that the state's implemented using Spark funding and the awarding of contracts to labs that are serving the region. So when we get to that part of the presentation, I'm using some slides that the Department of Health and Environment prepared to describe that to several audiences, including the Spark Committee and Recovery Office. So I asked if I could just use those rather than getting something wrong. So they'll say KDHE, but I am authorized to use them without changing jobs. So and the content is, I think, right on point with the questions that you were asking. So if that's okay, where I wanted to start was the testing machines to nursing facilities. And again, I apologize, this is very similar, if not identical, to what I talked to you about last week when we met, but the context is just a little different. So hopefully it's what you're looking for. But so the Department of Health and Human Services at the federal level sent testing machines, testing devices to nursing facilities around the country. For a facility to get one of these machines, they had to have a CLIA waiver, certificate of waiver, which is a document that indicates the facility can do testing, other kinds of testing in their facility. So as long as they had that and they were CMS certified, they would get one of these two types of devices, either a BD Veritor or a Quidel Sophia 2. They were shipped out to facilities over three time periods, in three waves, one that started in July, one that started in August, and then one that started in November to get them out to all facilities across the country. In Kansas, the bolded point there, 319 nursing facilities received one of these devices as of November 19th, which was the last report that I could find indicating where these were being distributed. So facilities got these instruments and the test kits that are needed to run the tests through the machine. When they got the device, they were also informed about how to order additional testing kits to keep using the device for point of care testing in their facility. At the time in the summer, when the first rounds were delivered, there were some reports that there was a pretty significant backlog of resupply for those machines or those instruments. That's somewhat resolved, but there's still some delays in getting enough kits and supplies to facilities to run those tests. But that's all done at the at the federal level or between the facility and the device manufacturer at HHS's direction. These are antigen-based tests, so they do look for evidence of the virus, but it's not a definitive test. It's used more for screening. And CMS and HHS, when they provided these machines to facilities, said if you get a negative, that's you can go with that and assume that that person is negative for COVID-19. But if they come up positive on one of these point of care screening tests, you need to verify that with a more definitive PCR viral test to make sure it's a true positive result. So those are all instructions that nursing facilities have had since they started getting those machines. The bulk of the ones that came to Kansas came in that first and second round. There were a few facilities that weren't on those initial lists, and they had asked us at KDADS through their trade associations of ways to be reconsidered, and so those came at the latter part. So we went from about 280 or so to get to the 319, which we think is a pretty good number for coverage across the state. The other thing that happened, since there were backlogs in the availability of testing kits to go into these instruments that were being distributed, the White House and Health and Human Services announced that they were buying pretty much all of the manufactured supply of these cards that you can see the picture of. They're called Abbott Binax Now cards. They also do an antigen test through, it doesn't require a separate instrument. You don't have to plug anything in. It just uses the card and a nasal swab and some chemicals to generate the result. Those were also sent out to facilities. These, the Binax Now cards were sent to nursing facilities and assisted living facilities that are part of, that receive Medicare payment. So it was a little bit broader of a distribution. And that was designed again for nursing facilities to fill in the gaps in the supplies for their other instruments and to get something on the ground to assisted living facilities and home health agencies. That all happened in September, and they've been continued to be shipped every week to facilities on a pretty regular basis. We get a weekly report of those shipments by facility and how many of the cards that they have received. And so I put the results, I believe that's from not last week's report, but the prior, or it might have been last week's report when we were in the Bethell Oversight Committee was when it came out. But there were 113,000 test cards distributed to 106 assisted livings and 530,000 or so test cards distributed to 264 nursing facilities in Kansas through that time frame. The reports are that's going to continue at least through the end of the year and possibly into next year as well. These are also an antigen-based test, so if you get a positive on one of these Binax cards, the direction is that you need to get a PCR follow-up test to confirm the results. The KDHE lab also got a supply, is receiving a regular weekly supply of these that they can distribute to people who need them, either facilities or individual businesses or healthcare providers, or they're managing the distribution of that. I was asked to comment on some considerations about testing and what facilities should think about. So I did want to just, I guess, reiterate the point. If for KDHE's role, they are through the Health and Environment Lab, were the kind of lead agency for testing across the state prior to the testing strategy, and as facilities were getting these different instruments and tests. But the other role of KDHE is as the reporting source. So if a facility got a positive result in their testing using one of these point of care devices, they needed to report that to KDHE and then confirm it with a PCR test as needed and get all that data to KDHE for the epidemiology reporting and case tracking. And that, so this added a little bit of reporting to to nursing facilities and assisted livings, but for the most part, they'd been set up to do that testing and reporting prior to these devices becoming available. And then in terms of testing frequency, that was some question of how frequently to test. The federal government for nursing facilities requires testing twice a week. for the staff in that facility, in those facilities, and then to be prepared to test residents if there's an outbreak or there's positive cases. So when CMS made that announcement, they, number one, sent these testing instruments out to facilities to give them the capacity to do the testing. And then number two, they created a report that tried to measure the level of community spread, which they measured by looking at the positivity rate. So the percentage of COVID tests that were positive divided by the total number of COVID tests that were being performed in a county. And if that rate was higher than 10%, you test twice a week. If it's between 5 and 10%, you test once a week, and lower than 5%, you test once a month. There were some concerns early on that there was a number reported by KDHE that was similar, and there was the CMS number, and facilities weren't sure which one to use. We clarified with CMS and worked with KDHE to produce one report that has all of that data for Kansas, using the Kansas data that mimics what they were looking for to help guide positivity, those decisions. And this is what the map looks like, at least the map for the end of November, for that county positivity rate. We pointed people to the KDHE website. It shows up as one of the gating criteria on the KDHE data site. But so a facility could go to this map, find their county, and based on whether it's red, yellow, or green, know whether they're testing twice a week, once a week, or once a month. And then see some of the data below this map as well, that shows historically what the trends are and how things are moving. But that seemed to answer most of the questions about community spread and which data set to use. We've been pretty consistent since the beginning of this to use this KDHE report, and other than it's become more red over time, but that's less of a function of the report than just the level of community spread. But so that's how facilities can determine how frequently to test. If you're a nursing facility, you're using the CMS standards. And then last week, the governor announced her executive order that applied those same standards to what we call state licensed facilities. So assisted livings, home pluses, residential healthcare facilities, and others, to use the same set of standards to help inform how frequently those state licensed facilities ought to be testing their staff, the requirements on staff alone. So they're one set of standards, kind of different sets of testing, but one set of standards in terms of the frequency, which is the main question that we were receiving at KDADS and also at KDHE. In terms of the state testing strategy, so the Department of Health and Environment was leading the state's testing efforts through the pandemic, through the KDHE lab, providing resources to communities and local health departments and assisted living long-term care facilities as well. There was some interest over the summer of ramping up the capacity to do testing and to make that more available. So the strategy is reflective of how to get that capacity at the right level using Spark funding. So when the governor announced it, these were the principles of the testing strategy. So I apologize for the harsh transition. So the federally provided testing instruments and testing kits, that part I've talked about, and now I'm talking about the state testing strategy and the Kansas labs. So the state testing strategy, this was the governor's statement about broader routine testing to stop community spread and identify what's going on. There were these principles of the testing strategy for accessible, equitable, cost-effective, and timely testing, which is the main thing. The testing doesn't do much good if it's too expensive to encourage people to be tested. It doesn't really do much good if the results are so slow that you're still exposing people while you may be positive until you get your test result back. It needed to be equitable as well, that there was ready access across the state to testing. So that was the main elements of the strategy. On this slide, which is number 10, this is the proposal that Health and Environment and others provided to the Spark Committee to describe what the state was going to pursue to increase and enhance the level of testing in the state. So it lists several of the same elements about the goals and what was needed, who would administer it, and the application process. And all, so this was ultimately what was approved, or what the Spark committee used to approve the strategy. So in the round 2 of Spark funding, KDHE received $20.7 million to increase the state's capacity at the KDHE lab. And you can see there on the second bullet point, about 18.8 million of that's actually been distributed to the lab in buying equipment, testing materials, and the staff cost to increase the capacity at the lab to perform more than 5,000 tests a day. So the first part of the strategy was to ramp up the capacity at the lab to conduct more testing. The second part of the strategy was use the Spark round 3 money, which was about $52 million, to buy more testing capacity around the state through private reference labs, which I'll go into a little bit more detail about here in just a second. So with that round, so the first batch of money, the round 2 money, bought things for the KDHE lab. The round 3 money was designed into this competitive process to identify labs that could perform more testing and step up the capacity to target particular parts of the state and populations. So this slide is showing the process that was used in some of the timeframes to get from when the Spark committee authorized the funding to the contract award. So when the round 3 money was made available, the process had to be a competitive bidding process to make awards. And those proposals had to be reviewed by the Spark committee if they exceeded $10 million, which this one definitely did. So we have to spend all the money by December the 30th of this year, based on the Spark rules. And so KDHE developed a request for proposal to identify labs that could be awarded this money. They announced the RFP, or put the RFP out on the street on October the 7th. Proposals were due by the 21st of October. KDHE reviewed them that following week, or that week after the 21st of October, to look at the proposals, and then made an award. It was sometime in November, but this was a slide they used to present the process. So they announced the vendor sometime the first week in November. So for your question about the time frame from when the need was identified to Spark funding to contract award, this lays out that first part of that process. In that RFP, just a couple of points about what was in the RFP. There were 3 different response sections. Section 1 was about laboratory testing solutions, and so labs could respond to those questions. The second section was about how a lab would respond and serve high-risk populations. And then the third section was about innovative strategic solutions that labs could propose to meet some other needs. So in a little bit more detail about each of those, section 1, the labs was really the kind of nuts and bolts of performing testing. So it asked labs how they would collect samples, transport the samples from the facility or location to the lab, and get the reporting back. There were some requests in that process also for the costs. This slide, number 15, shows the, I think this was the actual table that they used in the RFP for labs to build their responses, showing what they'd be able to do and what it would cost per test. The section 2 was asking labs to respond to high risk populations and where they would, how they would respond to those needs for particular groups of Kansans that had higher needs or were at higher risk. And the labs are asked to respond also for costs related to this issue. So the high risk populations, and again, the form that they responded to looked kind of like this. It's on slide 17. The list of high risk populations that labs are asked to respond to included nursing homes and assisted living communities. The populations in those, both the staff and residents in long-term care settings, schools, correctional facilities, first responders and essential workers, some key industrial sectors, and then service providers as well. So the labs went through and responded how they would serve those populations with different lab services. They did need to talk about the population size, what type of test they would use, the protocol. So just a little bit more about the details that they were asked to respond to. In section 3 of the RFP, they could respond about innovative strategic solutions, which meant ways of like doing mail delivered, self-administered test kits, software that might track the results or track the responses, ways of centrally reporting instead of the results going from the individual to a lab back to the individual, that there'd be a way to cut some of those paths out of the reporting chain and then provide the costs related to those activities. So overall, there were 23 bidders that were qualified. 10 were from Kansas or Kansas-based companies. 15 of the proposals offered end-to-end solutions, which meant that they would provide all the services from collecting the sample at the point of care or at a testing site, to transporting the sample to the lab, getting the result and reporting the result back to KDHE for the epidemiological tracking. Most of the proposals included some information about high-risk populations, and there were 4 that were more detailed in that regard. And there were 11 proposals that included strategic solutions, like I talked about, that would support some other aspect of the unified testing strategy. So as a result of that, KDHE awarded 9 contracts to labs, and you can see the list here: 4M Wichita State Clinical Reference Lab, MAUD, which is a Johnson County-based lab, Well Health, Nick USA, Sinochips, Quest, and Kansas University. So from this point, the KDHE took the labs that were awarded contracts and then tried to match them to different populations, match their proposals to the different combinations of things they needed. Those that would do end-to-end testing, those that would serve the targeted populations and the high-risk populations, those that had some innovative solutions. And what resulted from that matching process, and that's skipping a couple of important steps, but there wasn't a lot of time between the award and when the regions were assigned. But what KDHE and their consultants did was take those vendor contracts, match them to population sizes based on county, and then rolled out that this lab is assigned to this group of counties and needs to provide all the services that are required. So the result of that process is a whole bunch of testing that's been happening, but roughly related to this map. So they divided the state into 7 regions based on county, assigned a lab to each region, and then directed the lab to provide all of the testing related or needed in that county, whether that was for a high-risk population, long-term care, end-to-end support the existing health departments, whatever it was. These labs were the ones that were tasked with doing that. So we've shared this table a lot, or this map a lot, with facilities, particularly from my perspective, working with nursing facilities and assisted livings and other long-term care settings. We've shared this as far and wide as we can get it distributed, so the facility can say, I work here in Rice County. I'm a nursing facility. I need help with supplementing my testing. So I would call the KU lab and start a relationship with them to figure out, how do I get test samples collected to the lab and get the results back, all of those different steps. So lots of individual conversations then between labs and facilities, or labs and providers to make those connections. Overlaying all of this also was another effort with Well Health to set up mobile testing sites around the state that are still rolling out, and we can provide some more information about that if you're interested. But so we did try to share this map and table with as many providers as possible, so they could see if there were gaps, how to contact their lab. There's also a contact sheet by lab with who to reach out to set up that relationship and have that first conversation about, how can this lab help my facility meet my testing needs going forward. So that's really the testing strategy. It went from when the Spark funding was identified through the RFP process to award in about a month. And then these labs have been up and running. I lose a little bit of track, but since the beginning of November, I think the first test was performed November the 13th, if I recall. And so they'll keep running through the end of the calendar year There's been additional requests for funding extending into the new year, but we're waiting to see about that as well. The other part is that these 7 labs that are around the state ramped up a significant amount of capacity to be able to perform the number of tests that are expected, and that capacity won't necessarily go away, but it will need to find a funding source so that it can keep serving the populations and facilities that they're serving. The last part of the questions that I was asked to respond to were about some of the impacts of this amount of testing. And the testing that's been happening. I think I came up with 3, and I didn't put them on a slide. I apologize. But one was, I think that amount of testing that's happening is helping to identify where there's spread that is because somebody's not showing symptoms of COVID-19. All facilities, at least for long-term care facilities, were directed through the infection control survey process and their own processes internally to develop screening procedures so that when people start at work, or during the day, have their temperature checked, asked if they're feeling sick, those kinds of screening questions that we're all familiar with. That identifies people that are sick or feeling bad and then tells them to not come to work or lets them not come in. COVID-19, we know a person can develop an infection but not show any symptoms. And so for those asymptomatic folks that then go to work, they pass through the screening process, they're could potentially be spreading the virus throughout their facility. Testing helps identify that because it'll pick up those people that are infected but not showing symptoms yet. So hopefully that's one thing that will abate some of the spread within buildings as we get more testing around or just having it available. I think the second impact is that we've now gotten to the point where we have a consistent standard for how frequently to test. Before the governor's executive order was put into effect last week, you could have a nursing facility and an assisted living facility on the same campus. The nursing facility was testing twice a week. The assisted living component wasn't under any requirement to test. The operator may be doing that already just to make it easier, but this created one standard. Hopefully that does encourage more facilities to test and identify those folks that are asymptomatic but potentially infected. And then finally, I think the hope is that by doing more testing, we can move forward through the pandemic and keep working on isolating people that are sick. And cohorting and isolation is the main step to keep, if you're in a long-term care facility, from it spreading. But as we're also testing more people, that might open some other opportunities where it'd be easier to let visitors in because we could test them if the capacity exists to keep testing going. Have confidence in the staff that they're not spreading COVID around, moving from building to building or when they start work. Really just provide more of that confidence that I think we need to keep moving forward, doing all the things that are still required, hand washing, sanitation, mask wearing, all those kinds of things. But this is just another tool to help control the spread and better manage it. So hopefully those are the impacts that we'll see. We'll keep evaluating that as we move forward through the next several weeks. Madam Chair, that's my prepared comments. Happy to answer questions now, or I can stay on the Zoom and answer them at the appropriate time.
I think that we'll go ahead. We appreciate you being able to stick with us today because that will be very helpful as we, I think, progress. But I would like to go ahead and I know I've got some questions and see if any other members have some questions that might help clarify as we move forward some of the questions and issues that might come up.
Sure.
All right. Committee questions, Senator Hildebrand and then Representative Carpenter.
Thank you, Madam Chair. And Scott, thank you for the slideshow. Sorry, not slideshow. But my question is on labs that we're using in Kansas, there's not a whole lot of talk about cycle thresholds, giving false positives if they're over a certain level. Are all 7 regions using the same cycle threshold? You know?
Senator, I am not. I think I said it flippantly last week, and I'm saying it very seriously now. I'm not the expert on the testing epidemiology. I'm happy to take that question back to KDHE and ask the our lab experts about that. I know there's some in the RFP process, they tried to standardize it as much as possible, but again, from my observation, uninformed largely, each lab is doing some slightly different variations on testing. So I can ask about cycle threshold and see if there's data about that we can tell from these 7 labs. But I just apologize, that's not my field of expertise.
I think you did that for us. I think that'd be important information to have. And I just have one other follow-up question. Are the labs open on the weekends?
I know they're processing tests on the weekends. I assume they're also taking samples in over the weekends as well. But I can ask that question and verify for sure.
Thank you.
Representative Carpenter.
Thank you, Madam Chair. Hey, Scott, thanks for being here. On this testing mandate, are we absolutely sure that all the nursing homes have the supplies they need and to test on what's required in this mandate?
We did a survey of long-term care facilities, everybody that KDAD's licenses, before we rolled out the lab, the 7 regional labs. Based on the results of that survey, the vast majority of facilities were already testing, had some capacity to test. And so we felt pretty confident then that the executive order would help fill in the gap or maybe give that nudge to some facilities that weren't testing. And then with the labs being available and having the responsibility to serve those communities, that we could fill in those gaps. Now, is it the same day or do we still have some work to do to build that up? I think we do, but at least there's a resource there. We weren't putting a requirement on facilities that couldn't be met with some Spark funded capability. So I think we're close. My other concern or other answer to your question is what HHS and CMS was sending out to facilities, the Binex cards and the ability to buy additional supplies for their testing instruments. The initial distributions of those were based on the resident census inside the facility and assuming a normal level of testing. It was not testing twice a week, everybody all staff in the facility twice a week and do that for more than a month, or probably more like 6 weeks, which has been the experience many nursing facilities have had in the state, given the level of community spread. So am I confident? No. For the CMS facilities and under the executive order, there's a standard of twice a week if you're over that 10% positivity rate. There's also a mention in both that says you make your best effort. So if there's not enough supplies available, you can't get them, you can't afford them, you can document that and there won't be a penalty associated to it. So I think there's a little bit of an out, but I think what was not anticipated was the level of community spread and the amount of testing that would generate in Kansas.
Okay, so I guess the same corrective measures are available for this as before, where they could attest to the fact that they couldn't get supplies, weren't able to, then, so the mandate is, allows for that.
Yes.
Okay, do you have any idea what the percentage of vastly is?
I missed the last word, Representative, I'm sorry.
You said, I'm vastly sure, and I'm thinking, well, is that 95%?
Oh.
Is that, just give me a percentage on vastly, I'm kind of vague on what vastly.
So out of the 700 long-term adult care homes that we've got in Kansas, when we did the survey, and we published a status report of those facilities that have the ability to test their staff. Out of that report, we only identified it right at 100 that said they were not testing at all. There was another bunch of about 120, 130 that we didn't get a response from or couldn't identify. So if you just take the ones that said no, when we asked them if they're testing, it's 100 out of the 700 facilities. And that was that was asked of them before the executive order. So we're hoping that we close the gap on those that are just saying we're not testing if the answer is because they don't have resources or because there wasn't a mandate. I guess we can close that gap. But so I'm confident that's 10% or so, maybe a little over 10% based on that 100 out of 700 that said they just weren't testing.
Okay, thank you.
Any further questions? How about on Zoom? All right, Scott. I think one of the things that would be very helpful, because it gets confusing talking about licensing through CMS versus KDHE on, and I don't know if when we say long-term care facilities, if that includes everything, nursing homes, the assisted livings, the home plus, I mean, everything. So if we could get that defined, as we go through, as part of the education process for legislators, so that they understand and they get a call from a constituent, it's like, well, how do I know if my home's been testing or that my home is testing and that they're licensed, under the state or they're licensed with CMS, and, how does this all work? Because I can tell you that one of the questions that I'm getting since the ERO is, where was this 9 months ago for these facilities?
Mm-hmm. In terms of the requirement to test?
Yes.
So CMS's requirement to test nursing facilities didn't start until, and the weeks blend together a little bit, but until September or October. I'll get the exact date when I'm not trying to remember it. But so that didn't start until in the fall, and only applied to nursing facilities. Our concern at the time, because that did come up because of the exact reason that you said, why does it apply to nursing facilities but not the assisted living that's on the same campus or something that's of a similar size? It was a reasonable question. Our concern at KDADS at the time was that we couldn't guarantee access to the testing supplies, the labs that could run the tests in a timely way, the reporting back to KDHE, all of those steps that are needed to close the loop of from when I've got somebody who I want to test to getting a result in. We weren't confident in that supply chain and the resources that were available. When the Office of Recovery and the Spark Committee identified the Spark money, the $52 million or so that said, let's significantly ramp up the capacity to test, we felt a lot better about that, asking or putting a mandate on facilities that they could actually meet. So that's part of the reason that it didn't make sense with CMS and HHS sending out testing instruments and Binax cards to nursing facilities. They were confident that they could make that a requirement from CMS. At the time, we didn't have the same confidence. That seemed like an unfunded mandate on facilities that we didn't have a way of helping close. So I think the resources from the Spark Committee changed that scenario quite a bit, made the capacity and access to testing significantly better, or at least that was, that's what the goal was. So I think that changed the conditions, but I understand the question, and it would have been much better to have a lot more access to testing earlier in the pandemic than now. Totally agree. On your other question about which facilities this applies to, so we tried to, the executive order broadly applies to facilities that KDADS licenses. So, and then it leaves out ones that are CMS required, or CMS licensed. So it's every type of facility that we license that's a residential facility. So the status report that that the consultants have helped us put together identifies all those facilities and the types, and that would be a good thing to pass to your staff to share with you so you can see that. I think that gives us the whole list of, by county, all the facilities that we know are testing or reported that they're testing, and those that aren't.
Okay, and were you able to, and maybe if you didn't, that's fine, you can go out and have KDHE, but the question I asked you last week is the accuracy of the rapid test.
There are concerns about it, and but I can check with KDHE again if there's more they would like to say, particularly and in response to Senator Hildebrands' question about cycle threshold. Those would be good for them to ask together. I apologize for not having that today.
Oh, that's fine. I just thought I'd go ahead and check because I said the information I had is a 50-50 chance. And I know that in your comments last week, you said that if a person tests positive with one of those, then they're automatically sent to either do the saliva or the nasal, which is in more detail. The concern I have is the negatives that make it positive. You know, and I'm not being a betting person, 50-50 is just not, I just couldn't go, I couldn't bet on 50-50.
Sure.
I'm just really concerned, well, you know, if a lot of our facilities are only dealing with that rapid test because they don't have the machine, so they don't have the other testing, you know, what kind of position are we putting them in for their test?
Sure. And it's a great question. One of the things that we have talked to facilities about in response to similar kinds of questions is, so where do these 7 regional labs fit in? We've already got our instrument. We had a lab contract before. Where do these labs fit in? And what I've said is, well, it's capacity. It's paid for by the Spark funding. So if you wanted to use that to complement your rapid point of care testing, so you're using your CMS provided machine for one of your tests during the week. The other test during the week, you're using the Spark funded lab to do the nasal swab. And the Spark funded labs are only doing, they're required to do the PCR viral testing. So you're going to get that more definitive result anyway. So if you wanted to use that as a way to complement your testing, or if you're in a county where you're testing twice a week anyway, use your point of care test one of those tests during the week, use the Spark funded lab, the other test of the week. And, you know, if it's wrong 50% of the time, you might catch it in that second test when you're looking for the viral elements, or 5 more days would have passed. So we've tried to say this is a way to, because we don't want to, other than to suggest we think people ought to be testing, that can look very different in facilities depending on what they're capable of doing, what the staff's got time to do. Lots of concerns that you'll probably hear about from other conferees. So we're trying to figure out, put more resource in the bucket, and hopefully that helps meet those needs. But I agree, if it's not a one and done process. So hopefully we've complemented or supplemented, maybe is the better way to put it, the capacity that facilities have.
Okay, and then going back to the labs, has all of the money been sent to the labs that was agreed upon in their contract with the state?
They're paid based on the number of tests they conduct. So I don't think it was and there was some advance that was done. My understanding in kind of we meet every morning to talk about the contracts and how they're rolling out. So some labs did need some startup money to get the capacity rolling, but then they're paid per test from there. So I can ask my colleagues at KDHE kind of where we are on the spending, but it's well short of the 52 million at this point, just because there haven't been the projection was to conduct something on the order of like double the testing capacity, so like 10,000 a week, and we're not quite there yet. But I might get the metrics wrong. I'll follow up with KDHE and get you an update on the spending.
Okay, I appreciate that. And then if you could also provide us on the page 22, you listed the 9 labs that we contracted with. And I think it would be good for us to understand the amounts for each one of those.
Okay. Again, I think the contracts were awarded based on tests conducted, so there may not be a bulk, but I'll check.
I think there's some that are out there that there was supposed to be some other payments too. And then, oh, I know what it was. It was on page 19. When you refer to sampling, is that the same as the term you used last week on pooling? Or is this actually sampling X number of people out of 100?
That sampling is actually who's going to draw the sample from the resident, either do the nasal swab or do the nasal pharyngeal swab or gather the saliva. It's actually gathering the sample that's going to be tested. So for some facilities that don't have the clinical staff or trained people to do a nasal pharyngeal, deep nasal cavity swab, the labs are providing either through a mobile site, or they're going into the facility and collecting the samples for the facility. It's that sampling is the actual collection of the sample to be tested for the presence of the virus.
Okay, I just wanted to make sure I was getting my terminology straight, because that pooling has still got me kind of wondering.
Yes. So that, again, right at the fringe of anything that I'm comfortable talking about, but that pooling is you take samples. So you take the saliva samples, for example, from 5 people, put them together, test it for evidence of the virus. And if you get a negative, then you assume all 5 don't have the virus. If one comes up positive, then you've got to figure out which one of the 5 has, or how many of the 5 actually have the virus through a follow-up test on the remainder of the saliva that you've got. Or that really is at the fringe of what I know of how this works. But so you break the sample back up and figure out how many of the 5 have the virus.
Okay. And I don't know that this is really something so much that you can answer, but it's a question that's out there at some point. Someone I think is going to have to answer is, so we knew back during the special session that there was not capacity for tests. Would you agree?
I wasn't following it closely, but I would say that's true. Yes.
All right. So what my concern is, I think this is the piece that's probably not on in your pay grade for this here, but then during the special session, we knew that that there would not be the testing capacity to do what was needed for these long-term care facilities, whether they were CMS or they were state. But yet at the same time, we provided no COVID liability for any of those facilities. And the reason I'm concerned about this is the question I asked last week about how many do we have in receivership, which we knew was 2, but we will be 1 at the end of this year.
Right.
But also Deputy Secretary DeBoer mentioned that KDAS has had to go out to some of our facilities that may be potentially into financial issues. And we also know that there's already lawsuits being geared up out there against some of our facilities that are COVID related. And if we don't have the beds, where does mom and grandma go?
Mm-hmm.
So you don't have to comment.
I appreciate that. I did get a note from my survey commissioner that the CMS requirement for testing was effective on August the 25th. So that I'm pretty sure that was after you'd adjourned. So for nursing facilities, they weren't required to test until late in August. But the need to test people for COVID-19 wasn't unknown before that point.
Right. All right. Thank you.
Yep. You're welcome.
Questions or comments or anyone on Zoom? All right, seeing none. Scott, thank you very much. I think, when we originally set up this committee, we didn't realize the in depth that you were going to come in last week. So we appreciate you repeating some of it, and
my pleasure.
Some of the questions that we had. So we appreciate that very much. Thank you.
Marginally less work for me, so I appreciate the opportunity to do the same thing twice. That doesn't always happen. But I'll stay on if there's a question that comes up that you'd like me to respond to. I'm happy to do that.
Yeah, you'll probably get to do it a few more times during the session, so it's just
okay. Thanks.
All right, next I have Rachel Monger, Vice President of Government Affairs with Leading Age Kansas.
Good afternoon, Madam Chair. Hopefully you can see and hear me okay.
We can hear you, yes.
Okay. Oh, hello. There's my face. Thank you so much for allowing us to be here today. Give us so much of your time. to hear from providers about the many issues that they have dealing with COVID-19 in long-term care. I'm not going to take a lot of time talking because you'll be hearing from care providers that can speak a lot better on their issues than I can. I do want to thank Teresa McComb and Joe Ewert for being here today to help us keep putting a face on and giving a voice to the many very real, very tired, very brave people who are working in long-term care, caring for our seniors during this crisis. I just want to touch on two important things that concern all of our long-term care providers across the state, and those things are liability protections and staffing shortages. So number one, liability protections. As I'm sure you guys know, in the special session, long-term care providers are the only healthcare providers excluded from full COVID-19 liability protections during the state of emergency in Kansas. The liability protections given to every other healthcare provider in the state are narrowed to only those healthcare activities related to the COVID-19 emergency and do not apply to acts, omissions, or decisions that result in gross negligence or willful and reckless conduct. These liability protections preserve the ability to go after actual bad actors while allowing all the other providers to continue doing their best without the constant threat of litigation that drains precious resources away from resident care. We in long-term care are not asking for special treatment. We're only asking for the same treatment and protection granted to every other healthcare provider in the state. Singling out long-term care for personal injury and class action lawsuits during this pandemic does threaten the very existence of our senior care system in Kansas. It's a system that was already many times on the verge of crisis before this pandemic ever happened. It has already sparked a crisis in our liability insurance markets and may ultimately affect the stability of our healthcare stabilization fund. Last but not least, for us, and what I hear over and over from our providers is that it represents a demoralizing punishment for the tens of thousands of long-term care workers in the state who are loving, dedicated, tired, stressed, traumatized, and doing really heroes work caring for seniors during one of the worst public health care crises we have had in history. Next, I want to touch on staffing, and you will hear a lot of detail on this issue in the testimony coming after me. But I just want to bring up two specific requests we have had, which is around temporary nurse aides and use of the National Guard. So temporary nurse aides have basically saved our bacon across the state when it comes to emergency staffing and long-term care. Under an executive order from Governor Kelly, we are allowed to use temporary nurse aides who have taken a free 4-hour training course, and then they prove that they can meet a list of competencies before they're put to work, helping with our residents. And this has been essential for our homes, especially in rural areas, to continue caring for residents. And it does go away with the emergency declaration. So we really cannot stress enough how important it is to keep the temporary nurse aid program going as long as we have COVID and we're fighting it. And due to our workforce shortages, we also think it's very important to establish a pathway for those temporary aides to become full certified nurse aides when this emergency is over. And then last, deployment of the National Guard to help with severe staff shortages in our nursing home settings. There are a number of states that are supplying National Guard staff to help nursing homes with assistance, help them with record keeping and reporting tasks, which are many and vast under the mandates we've had since COVID, door monitoring and temp taking and all the record keeping that comes with that, cleaning and other types of non-clinical tasks that can free up our clinical staff to do actual resident care that we need to badly doing. And a lot of, and you'll hear that from the providers too, a lot of our clinical staff are tied up doing these non-resident care and non-clinical. Really cannot afford to be doing that. So I'm going to end there, and obviously I'll be sticking around the whole time as well to answer any questions.
Thank you, Rachel. Questions for Rachel at this time in committee or on Zoom? All right, seeing none, we're on to Teresa McComb, Administrator with Logan Manor Community Health Services.
Hello, can you guys hear me?
Yes, we can.
Okay, all right. Well, thank you, Madam Chair, for having me here today. I just wanted to kind of talk about our small town and our facilities experience with COVID and how it has affected all of us. We're a small town in northwestern Kansas. There are about 550 people in the town and 5,000 in the entire county. And back in July, we were just kind of hanging out over here. We had not had any cases to speak of. There had been 2 in our counties, but just in general, Western Kansas had been pretty free and clear of COVID. We did not have any testing supplies or capabilities at that time. And all of our staff was doing what we were supposed to do. We were wearing our masks in the facility. We were screening on the way in and partially through shifts, screening before we left. And we had locked down the doors. We weren't allowing visitors. And we were seeing a big increase in depression as our residents were not able to see their families. They couldn't leave to go to church on Sunday. It was just a whole different facility feeling. And we worked so hard for years to make this place a home where the residents can come and go freely and be happy here. And we were taking that away from them by not allowing visitors. And our staff worked very hard to keep attitudes positive and to do what we could for the morale of our residents that we care for. We had the kids come to the windows still, where they'd usually come into the building and interact with the residents. They were able to come and do window activities and different things just to keep entertained and to keep that relationship going and moving forward. But it was, you could just see the sadness on their faces. They felt like they were stuck in a building. They couldn't get out. They weren't even able to go out for appointments like they used to as we transitioned to Zoom. So they couldn't see what was going on in the small town that they were used to seeing every day. And then at the end of June, our county had experienced 2 cases of COVID up to that point, and they were both travel related, people who had left the county and come back and contracted the illness. The attitude in our area was that COVID is a big city problem. It's not going to happen here. We don't need to wear our masks. We're farmers. We're going to do what we do and not be troubled by anything. And a lot of the healthcare facilities kind of had the same attitudes. And others, knew that it was going to come to us eventually, but it would slowly work this way out and get to our counties. And then on one Sunday morning, June 28th, I got a phone call at home, and I was told that we had 8 residents who just had varying signs and symptoms. A couple of them had high fevers, a couple just had diarrhea, and a couple of them were just not acting like themselves and had a little bit of an altered LOC. So the director of nursing and I came in, and we got all those residents relocated to one hall of our building, where just the old style nursing home, you walk in the front door, one hall to the north, one hall to the south, 36 bed capacity. And we were at 35 residents at that point with 24 rooms. So we didn't have a lot of space to work with, but we evacuated one end of a hall and put all the residents down that hall that were having signs and symptoms, put them in isolation, and tried to get orders to get them tested for COVID since we had no in-house capabilities. We work with 2 different hospitals. One is in Norton, which is 30 miles one direction. The other is in Phillipsburg, which is about 20 miles a different direction. We talked to the doctors at each facility, and they were on call. Doctors, since it was the weekend, were not able to get a hold of their actual providers. One of the hospitals agreed and wanted the COVID tests done when we could possibly get them done. The other thought it had to be food poisoning or something else that was going around, that it could not possibly be COVID. So we ended up working with the health department as well and got orders from our medical director to test these residents that were showing signs and symptoms. And they could not get out until Monday to actually do the swabs and get those kits sent off to KDHE. So Monday morning, we got those swabs done and sent them off, and we awaited the results, continuing to keep those residents isolated from everybody else. And then Wednesday morning, that same week, July 1st, we had the KDAD state surveyors came into the building to do our infection control survey. And so they were in the building, and we had gotten our first results back that we did indeed have positive residents. And all of them came back positive. So we switched everybody in the building from the regular surgical masks to N95 masks. We were in very short supply of PPE. We had been trying to get what we could since the beginning of the pandemic, but it's in short supply. It's very expensive. We don't know what kind of quality we're going to be getting. We're lucky in our county that we have a very good emergency operations coalition, and they were able to bring us out a lot of PPE supplies and the N95 masks, the gowns, the gloves. They worked very closely with us. They were out here that same day. And we also, that very same day, July 1st, we had the health department come back over. They swabbed all of our staff, all of our residents. We had people coming and going on the sidewalks to get tested. We were trying to get KDAD satisfied with their survey so that they could exit the building. It was the worst day probably of my career here, just because we were trying to get so much done, trying to reassure the residents that were confused about why they were getting swabbed. We had to call family members and explain to them that their loved one was being tested for COVID or that their loved one had COVID. And there was a lot of fear and anxiety that day as we moved forward and got everybody swabbed and kind of situated. We felt with that survey that there was zero understanding about what we were going through, and that we were trying to care for our residents that day and do what was best for them versus getting the paperwork that the surveyors needed to get out of the building. And that was very frustrating on top of everything else we were dealing with. That Friday, we got all the staff and resident test results back, and we had 8 staff members and 11 residents who tested positive for COVID. The residents, some of them had signs and symptoms, some of them were asymptomatic. Our staff had already been working so hard to help keep the building staffed, and then all of a sudden we were down 8 staff members, and we had to all just step up and do what we could. There was office staff working in the kitchen, cooking meals. There was the director of nursing and our MDS coordinator were working on the floor. Our SSD and activities director were working as aides full-time. And we had some people that, looking back, worked more than 80 hours in a week just to make sure that the residents were cared for. We did have several staff members walk out the minute that they heard COVID. They did not want to risk their health or safety or their family's health and safety. And we found ourselves also in a position where we needed more staff than we usually even have on a shift at a time, because we had 2 different halls. One was a COVID hall and one was a non-COVID hall. So we had to have 2 nurses at all times in the building, where we usually just had one charge nurse at a time. The aides had to fluctuate and go back and forth depending on what the workload was on each hall at any given time. We had to focus and try to make sure that we were not forgetting about everybody's just social and psychological well-being as well. You can't lock people in a room and not interact with them and expect them to be okay mentally. So I spent a lot of my time that I could spare just going in and out of rooms, visiting with people, playing Scrabble with someone in their room when they were just sad and lonely, just visiting with them a little bit. And we tried to get staffing agencies to come in and help us. But like I said, our local staffing agencies, they had not seen COVID cases either, and they were scared. They didn't want to come in and help. They didn't think that they had staff who would be willing to be exposed. And the agencies that were further away or out of state, they said they could find us a nurse or a CNA, but it would be 3 to 4 weeks before they could have somebody in our building helping out. And we had no idea what it was going to look like in 3 to 4 weeks. We were living in the day, just doing the best we could. We had several local nurses and CNAs who worked at other facilities that called me and wanted to help, but their primary employer wouldn't allow them to come and help us out at all because they were afraid that then we'd send it back to their primary employer in the staff. We continued to test all of our staff and residents every week. And the first 2 weeks of testing went well. We worked with the KDHE lab, but after those first 2 weeks, during our active outbreak, they would not do any more tests for us. They said that we had to find another lab. So we worked with the health department and found a lab out of Wichita that promised that they would have 48-hour lead time. And the first week they did. The second week, it took over 10 days to get the test results back to us. And we had one resident who tested positive and 2 staff members. So by the time we had those results back, they were going to be out of their quarantine in 3 days anyways. So it was very frustrating. And there was a lot of worry, just not knowing how far they could have spread COVID through the building, just with us not knowing for so long. In the meantime, we had reached out to Roger Marshall, and he helped us find another lab out of Kansas City that had a better lead time. And we started working with them, and they did have better lead times, and we were happy with that. And we tested for it was about 7 weeks total until we got our 2 rounds of negatives in a row. We had 21 residents tested positive and 17 staff members. And every person was different. A majority of our staff had no signs and symptoms. And they, it was just maybe no taste for a day or diarrhea for a day. But we did have 2 very severe cases. One was a young mom. She was 29 and she had been working 70, 80 hours a week, helping us out, making sure that the residents that she loved were cared for. And she ended up coming down with signs and symptoms, and we sent her home. And she ended up going to the hospital 2 days in a row. And the first day they sent her home, gave her some IVs, and then she ended up going to the local hospital. They sent her on to Hayes, where she was on ICU for a few days before she was able to recover.
Teresa, can you hear me?
Yes, sorry.
No, that's fine. And I appreciate all this testimony. I've got quite a few people to get through today because we have to wrap up today with our report. Can you kind of summarize the rest of what you had to share with us? And we do have this in our file.
Okay.
All right. Thank you.
All right. So and I just wanted to thank you again and to say that we do need the vaccines in our facilities. Our staff and residents are out of their 3-month window now, so they are no longer immune to any COVID. They're able to contract it again. And we just want to be able to take care of these residents and open our facilities back up for testing and to be able to go back to our normal way of life where these people who we've been entrusted with to care for, we're able to let them thrive.
Thank you, Teresa. I appreciate you being here today. Are there questions from the committee or anyone on Zoom? All right, Teresa, where are you at today as far as your PPE supplies?
At this point in time, the last couple of months, we've been able to order more PPE and we do have some on hand. The cost is very high still, but we are able to order when we need it.
Are you still reusing N95 masks?
Not every day, just if we would have a suspected resident with COVID, we would then put them in isolation and use them.
Do you have all of the testing kits that you need?
Yes, we were one of the later people to receive one. We got our Quidel machine on August 28th. And there was a couple weeks there where we could not get any of the kits for it, but we're able to order those now through our normal suppliers. And we've been getting the Abbott cards on about a weekly basis from HHS.
Is that the rapid test cards?
Yes.
All right. Thank you. Anyone else with questions? All right, seeing none, thank you very much, Teresa. And we appreciate all the work that you're doing out there. So, let your staff and everyone there know we do appreciate that and not to give up. We're all going to get through this.
All right, thank you.
Next I have, is it Joe Ewert with Brewster Place?
That is correct. That is correct. Do you have me, have I unmuted appropriately?
We can hear you, Joe.
Okay. Well, thank you, Madam Chair and committee members for the opportunity to share just a sampling of our experiences. Listening to Teresa, it's evident that our experience is not unique. I think what we've heard and what I'll say is probably able to be repeated time and time again across the state. So Brewster Place, I have the privilege of being the CEO of Brewster Place. We're a retirement community in Topeka. We're home to roughly 400 individuals, and we provide a variety of services from independent living, assisted living, skilled nursing, home health care. And we do that through about 320 of the most committed, caring, competent, and trustworthy people that you could find in this region. We are a standalone not-for-profit organization, so we do not have a corporate sponsor. We're actually sponsored by a local church, the Congregational Church. However, we don't receive any additional resources through them. We do serve a number of our residents through Medicaid benefits, especially in our healthcare section, our nursing home. But 85% of all of our revenues are generated directly from residents who pay for their housing and services from their personal retirement savings. COVID-19, I remember the day, March 11th. Nothing has been the same since. We have altered every single aspect of our operation, and our residents, unfortunately, have lived in a way that is completely different than what they have known their entire life. We've created numerous new systems, and we've adjusted them countless times in response to changing public policy and directives. Many of my team members worked and continue to work 7 days a week. I think the first break that we saw was sometime in July, but many of us were here 7 days a week. When PPE was scarce, we handmade face coverings for staff and residents. We bought rolls of plastic and heat guns and made our own isolation gowns. We learned to import the KN95 masks directly from China. We implemented every piece of rapidly changing guidance that came from a myriad of authorities from the local, state, federal authorities, and multiple entities on each level. We closed our campus to visitors, and we self-performed all the functions that we would normally use contractors or families or other vendors to help with, simply in an effort to reduce the number of people that could potentially bring the virus to our campus. Our teams dug deep and they gave themselves over and over. They continue to do so. In the early spring, I want to just mention this. In the early spring, while we were all watching television and we were seeing these images of healthcare workers on the coasts and across the oceans in this space age looking PPE, with ventilators and all of it, we were sitting there in our homemade masks, and we were first subjected to the directive that was published on KDHE's website that we would be required and mandated to take COVID positive residents to make sure there was space in hospitals. We were standing there in our without PPE. We had our handkerchiefs and our homemade masks, and we had our first suspected case, and our nurses and nurse aides stepped forward and volunteered to care for these residents in our makeshift isolation unit. I remember there was a nurse aide. She was probably 23, 24 at the time. And before she went into the separated isolation unit that we had made, I asked her if she understood that she could get this virus and what that meant. And she said she absolutely did. And then she looked at me and said, but if I don't care for this poor man, who would? And she was right. Unfortunately, heroes aren't grown on trees. Nurses and nurse aides have always moved in and out of the workforce with changes in school schedules, career advancement, family caregiving needs. However, when the pandemic hit in the spring, applications for caregivers for Brewster Place went from 30 a month to 3. So at the same time that we've been asked to do exponentially more, we've seen our workforce absolutely dwindle. We are committed to providing approximately 2,600 hours of direct caregiver time to our residents in our nursing home each week. We continue to need to provide that level of service, if not more. Our residents don't need less right now. However, we have consistently run with more than 500 vacant hours a week in nurse aide positions only. We actively screen our employees and symptoms for exposure. We send them home to quarantine based on exposure and symptoms, like all nursing homes and assisted living facilities are doing right now. Since March, we have lost 2,800 labor days due to screening people out for potential exposure or for testing and so on and so forth. Much like Teresa mentioned, our entire team has been committed to filling in the gaps. We've scrutinized the duties that we have our clinical teams provide, and we put those out to administrative staff and all the other staff that we have who volunteer to work weekends. My COO routinely answers call lights, passes waters, and fills every gap possible. My CFO delivers meals. I've become pretty good at cleaning resident bathrooms. The point, though, is really just that our teams are absolutely stretched to their fullest capacity to provide the care that our greatest generation deserves, certainly that we believe they deserve. In August, as it was mentioned, we had the mandate to begin the surveillance testing of all of our staff, and in some circumstances, our residents as well. I think we started August 26th, so the day after it was announced and made mandatory. We do it twice a week now as mandated. I can't properly describe the level of effort that it requires to complete this task. However, one distinct cost of the initiative has been that we have had to close our 18-bed post-acute rehab center. So that's a wing that we have used for a number of years to provide care to people who, have Medicare typically, or over 65, have an accident, injury, some type of illness that requires hospitalization, and they are not safe to be at home. And so they come to us typically for a 2 to 3 week period. We have closed that. We simply don't have the personnel to staff it, largely due to the mandate. And I say that because the mandate was the last major item to come and force us to move our caregivers from the bedside essentially to administrative and reporting tasks, collecting the samples and so on and so forth. Unfortunately, we're not alone in the decision to have to cease admissions. Nursing homes in our community and across the state have been forced to stop taking new admissions. And this is not something that any nursing home operator would do willingly. Just for reference, the state and federal government, the authorities, the regulatory authorities use a variety of enforcement remedies to gain compliance. A ban on admissions is the most frightening penalty out there by far. Our ability to take new admissions is literally how we stay in operation from year to year. Unfortunately, though, the decision to cease admissions does more harm than just create financial burdens for our teams, but it also creates dysfunction in the healthcare system. So our inability to take admissions simply pushes back into the hospitals that are full or struggling. Certainly in our community, they are struggling to free up bed space for people that they do not believe have an acute need anymore, but can't go home because they're unsafe. We actually personally went through this just last week as my wife's grandmother had an operation, and she went in very confused. The recovery period is long, and she absolutely needs rehab care, but no one is available for her. We ended up taking her home with wound vac and some significant skilled need, and of course a lot of attendant care needs, and fought hard to find placement for her in a post-acute rehab among the very small number of places that were available at the time. So this staffing situation in your nursing homes has significant downstream effects that impacts far more than just those who are in the direct vicinity of our nursing home and assisted living facilities. I listed out a few suggestions in my testimony, things that as I've looked over the past several months and applied what I would do differently if I could pull the levers of government, so to speak, and I'll let you read through those. But the three things that I would specifically just like to comment on: staffing is a very, very significant and difficult hurdle for providers of nursing care right now. It always has been, but I think we are very much into the zone where it has become a crisis for us. We need help with that. We are doing everything possible to recruit and retain staff, but I just don't think that they're out there. Certainly not in this time. I know that there's been some allusions to National Guard. We've seen other states that have done that. The question, of course, when getting help for us is what could we put them to work doing, knowing that we don't have a great number of additional hours that we can spend training and so forth to get people ready to work. The testing alone could be something that would be very simple, I think, for another entity of the state to help us with the National Guard, so to speak. I need to commend Mr. Bruner for his work to get the regional labs up and running, and specifically including the sampling collection in that. We've not been able to utilize that ourselves. I would have liked to, but to be quite honest, having 4 to 6 weeks worth of a service like that will cost us probably several days in administrative time and again nursing time to get the system up and running, to get the contracts, the relationships established, to get all of our staff, all of our residents' demographic information, everything that goes along with making a switch like that. It unfortunately hasn't been something we've been able to make good use of with the short amount of time that's available. Funding, there's no way around it. The funding to the nursing homes needs to be continued in any way that you possibly can. The CARES Act and the Spark Fund have literally been godsends to us. If I had my druthers, I would ask that policymakers make the strings to these funds as short as possible, and certainly make the rules as clear and understandable as possible. We're constantly in situations where the funds come out and we think we have help, but the guidelines for how to use those are slow to get to us, and it makes it very, very difficult for us to apply any real strategic use to those funds. It just makes it very, very difficult. And then lastly, the mandates, we saw the mandate for the assisted living testing come out, of course. I would just ask that all mandates be looked at for efficacy. There are always resource uses that policymakers can't see when they make decisions with great intent to try to get their handle, especially around something like this pandemic. But those resource uses in a situation that we are right now, where we simply don't have any extra to give, we do not have any extra to give. Those mandates need to be effective. I would ask that the legislature demand some analysis of whether or not these measures are useful or effective at their end goal. With that, I would love to answer any questions that you might have and allow you to move forward if you need to.
Thank you, Joe. Are there any questions for Joe on Zoom? Senator Petty.
Thank you, Madam Chair. And Mr. Ewart, thank you so much for sharing the information about Brewster Place. I've actually been there. I had a relative that lived there for a while. But there is a statement that you have in your, and I think all the comments that you've expressed have to be those of probably every nursing home in the state of Kansas or in the country, as to the demands and the lack of staff and how it continues, and the concern you have for your residents, particularly since you have a population where 45% of our deaths have come from. You made a statement, you said whether it's the guard or others, the weekly COVID-19 testing could be administered within our communities, freeing up substantial human resources to deploy to the bedside. So I'm taking that you're suggesting that and you said to us that 85% of your residents are self-pay. So you're suggesting that government or communities, other sources come in and do the testing. Is this correct?
It is. I just want to clarify. So about half of our residents in our nursing home are here with Medicaid benefits. It's just 85% of the total revenues that we collect are from privately paying residents. Yeah, the testing, and this is something that has certainly been discussed amongst our peer circles, is getting help, what it looks like. And the National Guard is just one example of something that I have read about and I have heard about from peers in other states, where they have essentially mobilized them to do different things. For Brewster Place, the thing that they could do the quickest and probably the simplest and most straightforward way would be the testing, just collecting the samples and doing the reporting.
Further comments or questions? Joe, I just wanted to clarify with you on your first page of your testimony in the second paragraph, down towards the bottom, you said, with no help in sight, with the directive published through KDHE stating nursing homes must admit. Wasn't that a letter that made it come from KDAD?
I think we first saw it on the KDHE website. Okay. I believe they walked it back, but I haven't followed the politics of it.
All right. Any further questions? All right, seeing none, thank you very much for being here with us today. We appreciate it. And let your staff know we appreciate what they're doing.
I will. Thank you.
All right, next I have Linda Mowbray, President and CEO of Kansas Healthcare Association for Assisted Living. Are you there, Linda?
Hello, I am here. Can you hear me?
We can hear you.
All right. Well,
We lost you. Did you mute it, Linda?
Am I back? Sorry, I had a little flip up there.
I see you.
The information that I'd like to go over today is a step beyond what you're hearing from the providers themselves. I'm not a provider. Used to be in a former life, but have been with the association for a while now. You'll see in my testimony that I've outlined some areas that we really are having the worst problems with. I've used some pretty strong language in there that's not directed towards the Kansas legislature. It's not directed towards the administration. It is simply directed towards the overall systems that we have in place, we didn't have in place, and we failed people. All of us failed people, whether it was policies where we chose to go out in public and gather in masses and whatnot and not pay heed, whether it was just taking stock in what supply lines looked like, what staffing was looking like. You know, we just needed to have more of a comprehensive, cohesive action at the very beginning of this. And our hearts do go out to the family members, to the residents, to the staff members, and to everyone who has been touched by this pandemic. And all of us have been touched in one way or another. But we are at a point now where there's light at the end of the tunnel. There's a vaccine coming. Priority healthcare workers and long-term care residents, which does include nursing home and assisted living. We applaud that. We hope we remain a priority and that we will be able to get those shots administered, those vaccines to our workers and to our staff just as soon as possible. We're still in the crisis though, and we will still be in the crisis for months to come. The money's run out in 2 weeks. You know, the labs are set up now, and we so appreciate the work that KDADS has done to get those labs set up and ready to go. But can the homes afford to continue that level of testing if they have to pay for it themselves come the first of the year? Census is dropping. As Joe Ewert mentioned, Medicare, those units where people come in for the short-term rehabilitation stay and then go back to their place in the community, they are really the bread and butter of our long-term care industry. Medicaid has year after year fallen short of what actual costs are. And the way that providers have been able to stay solvent is to provide that short-term rehab care through Medicare. It's not just the staffing. When the pandemic was really starting to roll and we stopped doing elective surgeries, people chose not to have surgeries, people stayed away from the doctors. It was definitely a snowball effect. The knee replacement that you might have had done or the hip replacement that you might have had done, you put it off. And so you didn't need the rehab stay. So the revenue stream for our homes was dramatically cut. I want to talk about 3 major issues that you've heard a little bit about, but I want to take a little bit different stance on them. The workforce instability, the skyrocketing insurance rates, and the risk of insolvency and closure. I'll start with the workforce, which is probably one of the hardest to deal with. Not everyone wants to work in long-term care. Not everyone is of the temperament that they should work in long-term care. Because of funding, the wages that are paid to whether it's a cook or a certified nurse aide, whether it's a housekeeper, someone that does laundry. Those wages have not kept up with the times. And they haven't kept up because the homes can't afford to compete with the big box store and to some of the fast food residents that bumped everybody up to $15 an hour. Hopefully that this pandemic will shed a light on the need for pay equity, but in order to pay, there has to be stable funding. Now, some good news that I will tell you is that early in the pandemic, there was an executive order that was backed up by the Finance Committee that allowed for the temporary nurse aides. Rachel spoke to that in her testimony, Rachel Munger. That program is 8 hours of online testing and learning. It's then 2 additional hours in the facility and then supervision by the staff within the facility. We found out this morning that our numbers in Kansas have gone to 800. 800 individuals have taken advantage of the temporary aid. That's huge. Now, are all of them going to want to stay in long-term care? We hope so. Some of them are probably the business office manager or someone else that was already in long-term care. We hope that they will want to continue with the hands-on personal care. We are working with KDADS and with Health Occupations Credentialing part of KDADS, not to bridge or shorten the training time for an individual to become a certified nurse aide. There are federal requirements with that, and Kansas has always had more training requirements than the federal government when it comes to certified nurse aide. What we're dealing with is the training centers and locations that want to train CNAs, because of the pandemic, can't put their students in a nursing home right now. Makes sense. If you're not allowing visitors in, you're probably not going to allow students in. What we're working with HOC and KDADS on is a program where the students can take their training online, the full amount required by the state of Kansas and by the federal requirements, and then do their clinicals right where they're at. Not have to go to another facility, not have to go to a training site, but to do their training right where they're at. The barrier is this. Many of our homes have had a ban on training or providing CNA classes because of survey history. There are means for the state to provide waivers so that the homes can do the supervision for clinicals. What I'd ask this committee to consider is to really look into allowing that training to take place where the person is at, so that we can have more certified nurse aides. We can add more individuals that are available for workforce for the full range of items that certified nurse aides can do, and that we do it well, that we have them complete the entire class, no shortcuts, not a bridge, but actually just a pathway to get that training done so that we have more certified nurse aides in the workforce. How do we fund this? How do we fund getting extra people and extra money and whatnot? I would remind the legislature about a program back in the late 90s. It was a wage pass-through program where monies were allocated from the state that went to nursing homes. It was passed through the Medicaid rate, and it had to be used entirely on increases in staff wages. It was a good program when it started. And then with funding, you don't put the money into the program, the money doesn't come out of the program. And it fell the way of many good programs that it was not a priority and was not funded. I would suggest that we take a look at that program again and see if there is an appetite for funding these frontline care workers and giving them more money for a decent living wage. The liability issue, the surge in rate increases, we did an informal poll with our members back in probably first part of October. Some had already experienced a rate increase. Some were anticipating a rate increase that their carrier had already said, yeah, they're going to go up at the first of the year, but we don't have numbers yet. I will be interested and probably devastated to know what those numbers look like, but we will look into that. Part of it is because of liability protection. As Rachel Monger had said, we're not asking for anything special. We are asking for the same type of liability, immunity to liability, as every other healthcare professional in the state of Kansas. Nursing homes and assisted livings are under that definition and umbrella. We simply are asking for them to be included and not excluded. Risk of insolvency and closure. On my testimony, my written testimony, on the back side, you will see numbers. We provide these numbers for you every year. These are the nursing home, basically financial impact numbers from the cost reports that nursing homes have to file. This data is from the 2019 provider cost reports. 331 nursing homes in the state. Not everyone provided a cost report, mainly because of change of ownership and things along that line. But based on that information that we did have, you can see that long-term care makes a huge impact on Kansas economy. From workers and jobs to the indirect workforce, wages in long-term care, over $1 billion. The economic impact as far as the communities, we're still the second largest employer in a lot of small towns, a lot of communities. We're a healthcare provider to those communities and a resource. Tax revenue, state and local, 59 million, federal, 189.9 million. Those are not small numbers. We are an important part of the economy in Kansas. We provide an invaluable service to elders, disabled, short-term care people that come in for rehab. The profession is needed and it needs to be supported. I will say again that my heart goes out to the families, the residents, the staff, and all the losses. I don't think we can underestimate or understate the power of this pandemic. I hope that once we do get on the other side, once we do have the vaccine and it's widespread and available, that we'll be able to look at long-term care and really see where our priorities are. What's the value? How do we make sure that if another pandemic comes along, that we are more prepared, that we are willing to work together and across agencies and across breaking down some of these silos between agencies so that we can provide the best possible care for our residents and the best possible quality of life and living for Kansans. I will stand for questions when the time is appropriate.
All right, thank you. Committee, are there questions or comments for Linda? How about on Zoom? All right, seeing none, thank you, Linda, very much. We appreciate you being here with us today. Next, I have Tony Johnson with KanCare. Tony?
Good afternoon, Madam Chairman and committee. Thank you for hearing my testimony today. I submitted an outline of my testimony, but I don't do well with scripts, so I'm going to kind of speak from the heart. I have the privilege of being the Chief Operating Officer for Recovered Care Healthcare, and I also hold the position of Vice President of Government Affairs with KHCA. We operate 18 skilled nursing facilities, 2 assisted livings, 1 independent living, and 1 hospital in the state of Kansas. We spend approximately $65 million a year on payroll, and we spend $850,000 in property taxes. We employ 2,100 employees and approximately 250 contractors on any given day. I realize that there was no playbook for this pandemic when it started just under a year ago. So some of my remarks may be sharp and pointed, but it is really a constructive criticisms. What we've done along the way too is self-evaluate, adapt, pivot, and do the right thing for our customers. Speaking of customers, we operate 1,400 licensed beds. We have currently about an 82% occupancy, and 70% of our customer base are Medicaid recipients. Early on, again, there's no playbook. We had to improvise, use infection control best practices, the best to our ability to keep the virus out of our buildings. We closed down our buildings before it was mandated, and we're proud to say we pitched a shutout until mid-July with keeping COVID out of our facilities. Since July forward, it's been a much different story for us. One of the things that we've noticed in our portfolio along the way is the inconsistent message from public health authorities. We've had instances, and it still happens today, where we may have a question, we get tossed around like a hot potato. The county tells us to go to KDH&E, KDH&E sends us to KDADS, and we're left making the decision. We have no problem making the decision, but with no liability immunity, we're kind of on an island, and always in the back of our head, we're wondering what's next, what's coming in the media, what kind of regulatory ramifications for our decisions that we make. Another thing that we're experiencing at this very moment in Saline County, we've gone over 3 weeks without a single resident that had a positive COVID result. We're being told by Saline County to continue to not admit patients. And as my colleague Joe mentioned earlier, admissions are our lifeblood. And if we don't have a bona fide reason to stop admitting people, we'll be the first to stop admitting people if we feel it's necessary. But to have a public health authority tell us, no, you can't, for what seems to me is not a scientific basis, but rather a feeling, that is very damaging for our business. And as I'm speaking to you, this is not resolved yet. We get contradictory testing information or guidance. We had a building with 2 cases, and this is in Shawnee County. We had 2 cases of positive COVID patients. We were instructed to do a facility-wide sweep of those. And thank God we didn't have any more cases than that. Our other facility that was in Shawnee County had a dozen cases, and we're told not to sweep. And as you can imagine, subsequently, we had a pretty widespread outbreak. And by the time our testing capabilities could catch up to the spread, it was too late. We had that same guidance hinder us in Emporia, Kansas, where we were too late to get people tested at the same, in a timely manner. I want to talk a bit about the surveys. And again, I realize I'm armchair quarterbacking this a little bit, but for the first month in March, when this was all unfolding, we continued to get surveyed, and we got surveyed by the fire marshal. Our organization has had, through November 30th, 37 infection control surveys. And I think they're well intended, because that's what surveyors do. They inspect, they validate, they issue a deficiency if possible, if found. But of those 37 infection control surveys, and 5 of them were done by federal CMS surveyors, we've only had 2 deficiencies. I'm very proud of that. But that said, is that really a good use of resources during these unprecedented times? Multiple surveys, week in and week out, inspecting us. Is that really helpful right now? And even to this day, I am dismayed that when we are banning loved ones from visiting our residents, surveyors still enter our buildings. We had an annual survey last week. And as far as I'm concerned, they're not even being tested before entering our buildings. And I think it's on good authority. They're going to multiple facilities where there are outbreaks, yet they're not even following the protocols that we have to follow every week as providers for our employees and residents. And I think that is something that needs to be addressed. I want to talk for a minute about PPE. It was kind of like the Wild West at the beginning, and some weeks it still is. Our organization is still having a difficult time procuring N95 masks. We have enough KN95 masks to last us for a long time. However, N95s are still expensive. They're still hard to find. And my workers' comp carrier tells me OSHA, if they come in and survey us, they are going to issue us fines for not having enough N95s on site. We do use them, but we don't have a trove of them sitting somewhere in case things get worse. Speaking of PPE, one of the things that I'm proud of as our organization is early on, we established a logistics system. Because PPE is so hard to get, we established a warehouse in the basement of one of our skilled nursing facilities in Topeka, and we courier all the PPE to our 19 plus buildings across the state. That is the most efficient way that we can manage these precious resources and making sure they get to the right people when the time comes. We spent over 600 grand, more than we did last year on PPE, and we appreciate the Spark monies and the CARES Act monies to help us fund that. The one thing I want to talk about, though, is I think my colleagues share these thoughts, and I know my accountants do. There's a big and healthy fear that there could be clawbacks if we don't spend the money appropriately. There's a lot of encumbrances, like we can't use it for hazard pay for employees. And we are very nervous on how to allocate and use these monies in a way that we don't have to give them back either to the federal government or what have you. We've had some help from Ford Motor Company. They gave us 10,000 masks, Duracell batteries, giving us thousands of batteries. Johnson County's been great. They've been leading the pack in helping us with PPE and so on. Other counties are lagging, and I don't really know why that is, but we had a county, I'll just talk about it, Franklin County, in August, when CDC and CMS issued new guidelines for visitation. We subsequently had a Zoom call, and the county asked me and other providers what our plan was to open up the facilities. And this is right on the heels of CMS and CDC and doubling down on limiting visitation. So in my testimony and some of my remarks today, I like to come with recommendations. If there's a way that we could have central command, so there isn't passing the buck, or there's a consistent message to the various providers across the state, I think that would be very helpful in having consistent messaging. If it's not possible, I'd like to see a clear line of appeal or asking for guidance if there cannot be a central message. I'm a big proponent in regulatory reform. We need to get away from paper compliance and get back to the person. Our regulations in our industry are very encumbering. I've heard this for the last 20 years. We're second most regulated next to nuclear power. And I think what COVID has shown is when we're so encumbered by regulatory constraints, it stifles innovation, and it makes it hard for us to adapt. So a lot of us are out there working with 30, 40-year-old buildings with limited funds, and it is hard to evolve. The next minute I want to talk about is staffing a little bit. Again, Linda discussed the wage pass-through or having encumbered dollars to strengthen our workforce. We needed this before the pandemic. There's a stigma in long-term care before this. And now when we're asking the people who touch our patients the most, who make $12 to $15 an hour, to come in and provide that essential care where they could get the same job with less risk down at Home Depot, that's a very tall order. And I'm very worried about that moving forward. The public's going to remember the bad news stories about skilled nursing and how risky it is. I think we're just seeing the beginning of the staffing crisis that my colleagues are speaking about. Now's a perfect opportunity to strengthen that. And lastly, when we talk about staffing and the testing, I'll be the first to say the testing is vital for us to know what we're dealing with. And I think that's something that we need to keep in mind too. Early on, we didn't have the testing capacity. I think many of us were dealing with COVID and we didn't even know it. Now we have better data. And I want to share with you an important statistic in our company. Each week, we spend 640 hours on testing alone. What that equates to is 16 FTEs. And that alone is a strain on our resources and our workforce. The other the other area in staffing that has been very difficult, and my colleague spoke about it earlier, is the nursing agencies. They've hijacked our staff. And what they do is we raise our wage scales. They learn about it. They say, okay, Recover Care is paying nurses $30 an hour. Well, we're going to offer them 40. And you know what we're going to do? We're going to mark up our invoice and pass it along to them. And then, since 70% of Medicaid is our funder, the state of Kansas pays for these markups. And they are out of control. They hijack staff. They go to the highest bidder. They hold out until there's a COVID outbreak in a building. Then they mark it up more for a premium, and they send those staff to those facilities. I won't even get into the ethical or the right thing, but our staff is very thin to begin with, and what staff is out there or in the market, they have a stronghold on them, and it's very hard to access them. So in summary, I'm asking for encumbered money or a wage pass-through that Linda spoke about. I would like to collaborate on shaping the future of long-term care. I see this as a tremendous opportunity for us to make it better. I think where we're at today was 30 years in the making. And I don't want this opportunity to slip by and be forgot about when hopefully in the future we get through this and move on post-COVID. But we must remain vigilant and take this opportunity to reshape the long-term care future. Thanks. And I'll stand by for questions.
All right, thank you very much. Many questions? Anyone on Zoom with questions? All right, Tony, thank you very much for.
Madam Chairman,
Yes.
this is Susan Concanon. I was trying to do the raise hand thing, but.
Okay, go ahead, Representative Concanon.
Thank you. I've got a couple questions on the surveys. And I understand the issue with being short employees and then having to stop everything for a survey. But when you had those surveys, did they come from a complaint against your facility?
The infection control surveys, I'm going to give you a rough number. I would say a third of them were attached to a complaint, but the vast majority of them were routine infection control visits. When they find out we have a positive case or an outbreak, that prompts the surveyors to come in and look at us.
Okay. Okay, thanks for that. And then on the workforce and having your staff hijacked, I'm sure if I asked you, you would say that that's not just a COVID issue. That's all the time. This has been something I've been looking into for several years. Do you know if any other states do anything to maybe control what, I hate to say that because that goes against everything I believe in, but anything that they do to control the wages that they can pay your employees?
Yes, I'm with you. I'm a red-blooded capitalist. I cringe at what I'm even talking about. But that being said, yes, I moved here from Minnesota 13 years ago, and they put in legislation in the early 2000s to do that very thing.
And what did they do? They
put a cap on what they could charge providers. And I'm, it's been a long time. I haven't kept up on what they do. I'd assume they update it with cost of living, et cetera.
Okay, thank you. Thank you, Madam Chair.
You're welcome. Any further questions or comments? All right, Tony, thank you very much for being here, and please thank your staff for what they do. We appreciate that you're out there doing it.
Thank you. It's an honor.
Next, I have Della Rivordi. Is that correct? AmeriCare Systems?
You are very close.
Mer- AmeriClub?
It's AmeriCare?
Yeah, AmeriCare. Okay, that's what I thought I said.
Okay, great. Madam Chair, thank you for the opportunity, and the committee, thank you for the opportunity to discuss AmeriCare and the 13 communities that I support across our state, and a little bit about the experiences that we've had thus far. First, for a sound check, can you all hear me okay?
Yes.
Okay, wonderful, thank you. So you can see from my testimony that we do have a significant impact in the state regarding the 787 employees that we have and the $23 million in wages that we pay for these amazing people who, you know, I don't know how we find these great people. You know, we've been historically really blessed with a very, very low turnover rate. The state has about, we ran about 22%. We've been as low as 15% in some of our most recent years. But with a system that was already struggling, COVID has brought on some challenges that I've never realized in my career, and I've been doing this for a really long time. I started in long-term care back in the late 1980s. In 2018 and 2019, I had an average turnover for directors of nursing, these are registered nurses, of 8%. When I initially wrote my testimony, we'd had a turnover of 8 directors of nursing. Today, that number is 10. 77% of our directors of nursing have left the industry. They're no longer working in long-term care. And I ask them why. And they say, Della, you know, the job was already hard. This pandemic has just made it untenable. I can't take it. I cannot do it anymore. I'm suffering from high blood pressure. I've had people who have had to wear Holter monitors. I've had phone calls at midnight with people having panic attacks. And I know it's been scary, and it's something that those of us alive today have never experienced in our lives. Even H1N1, none of this can compare, not even close. Part of what's caused some of this concern is this shortage of staff that you've heard so many people talk about today. And I agree with you, Tony. We're competing with Home Depot, with Walmart. And at the end of the day, when we match those wages, why do people want to come to work in this very tough industry? Well, generally I'll say it's because they have a servant heart, and that's why they're here. Some have spoke a little bit about the regulatory climate in our state. I would like to address that as well. Early on in the pandemic, we got a lot of really good guidance. We got something called what I would call a critical element pathway. It was preparatory for what you should have in place to do a good job of protecting your residents from a COVID-19 outbreak. And our survey teams were there to assure that we were doing a good job with that. They kind of gave us a report card. And in in most instances, it was really helpful because you could say, wow, someone independent from my organization came and reviewed what I was doing. They looked at my policies. Let me fast forward to today. So here's a real world example. I have a community that this week is their 4th visit for a COVID focused survey, and not due to complaints. It's because of having positive people. We are in that community, we are in the dark days, the darkest days of when you have an outbreak. That's when you have multiple staff members who have contracted the virus. You have multiple residents who have the virus. Many, many times, these are key players in the organization. It's the leaders. Sometimes the director of nursing, sometimes the administrator, sometimes both. And this survey team would like to see for the 4th time my infection prevention and surveillance policy. For the 4th time, my emergency preparedness policy and my emergency staffing policy. And for the 4th time, my COVID-19 facility assessment. And please know that these are not small documents. These are large documents that they've seen and have approved. And then it's more of the detailed work. This outbreak occurred on 11/25. On my limited staff, who are doing everything that they can to care for these residents, on a skeleton crew, I need to now produce my COVID-19 education to the residents since June 15th. My infection control log since June 15th. All testing, and I've been testing twice a week since June 15th. And then to verify that indeed I have submitted what I need to submit to KDHE. And I hope that no one in the room is thinking that that's a small ask. Because I'm telling you, when you are in this situation and you have rapidly changing conditions and staff who become sick during their shift, residents who are having changes of condition, you're monitoring them every 2 hours, it's a heavy lift. And for us to then have to turn and divert all of our attentions to satisfy a survey process, it's really disturbing. And it really is kind of what is breaking the back of a lot of my really fine caregivers. They're just saying, why aren't we trusted? Why is this happening the way that it is? I want to talk a little bit about some of the other experiences that we've had. I am so happy to have met some of the fine people in our state. During one of the very first rounds of testing that we did, it was in the hot summer months. And I was right out there along with all of the staff, and we were doing a drive-through testing site that our emergency management and our local health department nurse helped us with. They made sure that, back then there was a lot of media buzz if you were going to do whole house testing. They secured a site for us. And when we were so exhausted and barely able to do one more thing that day, the sheriff of that town said, "Let me drive those samples to Topeka for you. It's the least we can do." I'll be forever grateful for that small town, for that small county, because right then, that's exactly what we needed. We needed an agency to extend a hand to help us out, to make sure that we knew where we stood and that we could proceed with caring for our residents and, if need be, taking steps to further isolate those residents to keep all persons safe. The most recent spark monies that we've seen mobilized through the use of Source 309. Wow, what a great job. That one was really knocked out of the park. It was so awesome to be able to really get your hands on some PPE that was much needed. One of the things that we're really struggling with, believe it or not, are things as simple as disinfecting wipes. Our large national supplier has been affected by being a large hospital supplier, and we just couldn't get our normal supplies. So that was really just in time, and we appreciate that. You know, the navigation through this whole thing has been really difficult. Having 105 counties in our state operate in 105 potentially different ways, it's been a challenge because CMS will say something, CDC will say something, but then for us out here operating, I'm operating in 12 counties. And believe it or not, folks, there's 12 different interpretations out there on how we should isolate, how long we should isolate, how many rounds of testing is required, and it goes on and on. The other and last issue that I want to address is that of funding. We have to have probably one of the best ideas that I've ever seen about funding. It's regulated, it's consistent. You have to report on where those dollars go and how it affects our wages. I really recommend that we find that so that we can stabilize our caregiving staff. I am very sad to say that for the first time since 1981, my company is likely going to have to reduce our skilled nursing footprint in the state of Kansas. And it is tragic because I know what building it is. And I know how important to that little town that building is. And their moms and their dads are cared for in such a way that they know that it's a neighbor taking care of a neighbor. But the harsh reality of where we are is that it's time, and we are going to have to make this change because we cannot financially, we cannot operate any longer. I once had to talk to an official at CMS and explain that this might have to happen when I was in another state. And they asked me how big the building was, and I said it was a 60-bed building. And that person said, well, that's really insignificant. And it might be insignificant in that person's world, but in the world of rural America, if that was my mom or dad, it would be devastating for me to have to drive 50 miles to go and see my loved one. So I just want to say thank you to everyone. Thank you for KDHE, for KDADS, for our local health departments, and all of the emergency managers that have been out there helping us and partnering with us through this really, really tragic time. I do hope that we can see more stabilized funding, and I do hope that we get to see vaccines happening very soon. And I thank you.
Thank you very much. Committee members, are there questions in the room? Seeing none, are there any questions or comments on Zoom? All right, seeing none, thank you very much, Della, for being here with us today. And please thank your staff for all the hard work that they've been doing. They will continue. So thank you.
Absolutely, thank you.
All right, committee, I might mention, it's really important we try to keep a quorum, and I'm hoping that the three individuals that we have out there on Zoom, which is, I got it here somewhere. We have Representative King, Senator Berger, and Representative Murnan. Are you all three still on?
Concannon's here.
What about Representative Burnett and Senator Berger? Anyways, my point is, I know that there was a couple in this room that was needing to leave, and we need 6 people for a quorum, because we will be making our final committee recommendations. So, and what we have left now are our MCOs giving their presentations. So the first one up I have is, if there's MCOs out there, if you can, and we've got Audrey and David and Michael, if you can keep them simple and brief and make sure you're highlighting the things that are new or that you want to really make sure that we get our attention on, we would appreciate it. It's not your first rodeo and testifying before us. Senator Petty?
I just want to, thank you, Madam Chair. I just want to comment. I know we had 2 pieces here that were written only.
Oh,
yes. And I just wanted to comment on Mitzi's, because she does bring up a good point about the fact that today we've heard from lots of providers, but we hadn't heard from any clients. And that's pretty much the point of her.
All right, thank you.
So I think it's important to remember.
That was kind of, this was called on such a short notice that we just didn't reach out to that far on it. So. And then some of those clients, yeah, it was just hard with the short notice. So Audrey Masner, I guess you're stepping in for Kevin. With here.
Can you hear me?
I can. Welcome.
Perfect. Thank you. Thank you, Madam Chair, and thank you, committee. I'm going to share my screen here. Can everybody see that? Got it? All right. So real quick, and I will try to keep it relatively simple, update from the past 2 Bethels has been focused on really what UHC has been doing in regard to COVID response. And so that holds true this update as well. That has been really where we've had our concerted effort and concentrated the resources within our plan to really keep those members, the member needs at top of mind, and then working with KDHE and KDADS to everything in sync, and also with the MCO Association as well. So team effort as we continue to work through COVID challenges. This is just a little bit of an oversight of UHC as we've seen the impact in total. I'll let you guys take a look at that. We are continuing telehealth. We are continuing all member services and really concentrating on a couple key things that we're trying to get our members, which I'll touch on here in a minute. One of the things we've noticed real quickly in the last couple of weeks, as we saw the surge come into the state, we wanted to get extra resources to our members, which include the LTSS members and approximately 275 of the skilled nursing facilities that we have members placed in. So we will be mailing in the next 30 days COVID kits. And those kits include, you can see a picture there on the side. They include everything from hand sanitizer to the face shield and an oximeter, which is pretty handy for both the members and for the nursing facilities. So we will be deploying those kits here very, very shortly, getting those all put together and out to the field. So seeing the need and wanting to get folks any resources that we could, we got these put together. Another initiative that our SDOH team is running is called STOP, Safety Testing and Overall Partnership. This is also going to be deploying additional resources for health and safety, specifically in Seward and Wyandotte County. And we will also be deploying approximately 6,000 food boxes to members that are in need, with 5 to 6 strategic partners between the 2 counties to get those out to members that will be needing those support services. I think we touched on this previously. We have a surgical mask initiative. We sent out at the onset of COVID, we sent out masks out to members and to providers. We are further partnering with the FQHC partners to deploy another 10,000 masks, surgical masks this time. And you can see right there some of the entities that will be receiving those masks. And then finally, just to really wrap up, UHC has dispersed a little over $1 million to 3,795 Kansas providers. This was for the CARES funds. One thing I would note, our plan specifically, UHC of Kansas partnered very closely with the other two MCOs and with KDADs to disperse the Sparks funds here in the last month and a half, I guess. And that was for UHC, we dispersed a little shy of $2 million to providers for the Spark funding. That went out to about 169 providers that got those funds. So adding that to this, about $3 million has gone out to the Kansas providers through CARES and Sparks funding. And with that, that's really the crux of what we wanted to talk through. If the committee has any questions, you can open it up for questions. Great, thank you guys.
Questions, comments? Audrey, thank you very much for being here with us today. I know that we asked you to come back to give your presentation that you were all going to do last week, and we appreciate the flexibility that you provided us today. So thank you.
Anytime, thank you.
All right, next I have David Livingston with Aetna.
Good afternoon, Madam Chair, members of the committee. I will be extremely brief as I can be. Want to just open up with a quick member story. As we've been working through this pandemic, I think it's really important that we focus on our members, and that's who we are, and that's why we're here. That's why all of us are here. The providers are working very hard, and really our role is to help facilitate that care. So just a brief story. We had a member that prior to COVID-19 was living independently and did receive some residential support. However, once COVID-19 struck, she became very hesitant to allow others to come in and help her, and refused to seek care because of fear, basically. During this period, she fell, broke her ankle, and initially refused surgery because she was afraid to go to the provider. Really frightened by the whole pandemic. She did go to the hospital. We worked with her to get to the hospital. However, she refused to get the therapy, and her physician deemed her unfit to make decisions. So that kind of moved her down the guardianship route. She was initially discharged to a rehab facility that when she didn't get engaged in the therapy, she was discharged from there. And our care coordinator stepped in to help her find a right location for her. And we did this through telemedicine. And that's just been one of the great things that's come out of this, is the ability to use telemedicine to help our members get care. If it weren't for telemedicine, this member really would have continued to suffer. But through working with this member telephonically, connecting her with her providers telephonically, we got her with a guardian that she liked and is comfortable with. And I'm happy to say now that she is living independently now, has a roommate in an apartment. She does have residential support, and she's now actively engaged in her own healthcare and improvement. So there are good things that are coming out of this as we are being able to leverage some of this technology. I'll jump ahead to kind of talk about the services that we've been providing, just to, I know that there's been interest on, especially the transition to telemedicine. Since the beginning of the pandemic, we have facilitated or delivered, paid for approximately 183,000 units of telehealth service. And some areas where we've seen some really exciting new uses for this include brain injury waiver therapies, through the use of the telemedicine that's allowed through the state has waived some of the requirements on that. We've actually been able to serve members, not just the ones here where they have the providers, but also expand services. And so members who have not been able to get the services because they have lived in more rural areas and have not had access to the care, we've actually enabled some of those services through telemedicine. We've also seen tremendous increased utilization in remote patient monitoring. The benefit of this is fewer hospitalizations, fewer ER visits, because we're able to facilitate 24-hour nursing or access to a nurse 24 hours a day if they need them, and also do remote, various routine checking of vitals. From a volume perspective, as of the middle of November, we've delivered or helped deliver over 11,000 COVID tests, and we've had about over 17,000 units of care related to COVID. And then also our care coordinators have been actively involved in reaching out to over 5,000 of our members, either preventively, proactively, who we believe might be at risk of COVID or who have expressed concern. So, we are continuing to focus on our members, making sure that we deliver the care that they deserve, and collaborating with our providers and all the agencies and the MCOs. And again, as I did last time, I want to thank the front line, the providers of care. We are working very much as an association of MCOs to make sure that we can reduce any friction that doesn't need to exist or shouldn't exist, because we want to make sure that there's nothing that's getting in the way of the care of our members. So there's sort of my abbreviated version, and I will stand for questions.
Thank you very much, David. I appreciate it. Are there questions or comments for David? David, one of the things, and I should have also mentioned this to Audrey, and I think between the agency and yourselves, is wanting to keep an eye on what the increased expenses are on the HCBS waivers for the schools. I understand why we're doing it, and I'm not arguing with that, but I think it's something that we need to monitor what that increase has been for us, because I think at some point during our budget process, we're going to have to figure out, is there any way we can go back, because I think there's some more matching things when you're into quote special ed, which is where this would normally go through in the formula. And if we can't convince the feds to maybe come in and help pick up part of that tab. So we appreciate that. Any other questions? All right, seeing none. Thank you very much, David. Appreciate it.
Thank you.
All right, last but not least, Michael Stevens.
Thank you, Madam Chairperson. It's my privilege to be here, and knowing that I'm the final speaker to stand between you and the loss of a quorum, I'll also be very brief. It's been our privilege to work with the Kansas Legislature and the department and all of the providers during this unusual time of the pandemic to make sure that we get great outcomes for our members. And so I'll just be very brief. My slides were shared earlier last week. I would like to start with a mission moment. We start all of our employee meetings by reviewing examples that have occurred recently where one of our employees was able to truly live out the mission and make a difference in the life of a member. I included this in your packet, but we received a call from the ombudsman here recently when a member who had just joined Sunflower was discharged from a nursing facility without adequate planning. And unfortunately, the member had been with us for only a week. Our provider representative reached out to the facility and learned that member had been with them for over a year in healing from a fall that resulted from multiple broken bones, and that the facility secured a motel and told him to go there. Well, we worked on trying to find a better and more stable housing option for this member. And the member felt that he really didn't have any choice in the action taken by the facility, and that he was looking for affordable housing. So we brought in our LifeShare team, and a referral was made by the case manager, and LifeShare is now assisting him with finding an affordable place to live. The ombudsman responded to us and said this: as he's no longer a long-term care resident, we will not be able to assist with the new issues he may run into. And we're appreciative of knowing he was provided the opportunity to make his next choices. Sunflower's expedience response is much appreciated, a bright spot in an otherwise dark event. And I think it just accentuates what really makes this work fulfilling for us. And as David and Audrey have also pointed out, that it has truly been an opportunity for us to break down barriers and collaborate with the other MCOs and with our partners at the state to find creative ways to take care of the needs of those that we serve. You can see in my packet some information about what we have done to assist vulnerable members along with providers with getting PPE and other assistance. And then finally, to respond to the specific question from the committee about Appendix K and HCBS services for children in school, I put a little paragraph in there, and as a follow-up to last week's Bethell committee, was able to find that on average, we have just over 1,000 school-age kids that we are serving through this expanded benefit right now. So it is definitely an additional cost to the KanCare program as we're providing the services in terms of attendant care during school hours because of this situation. About 1,000 kids that we have that we're providing additional assistance to at an additional cost that fluctuates between $200,000 and $300,000 per month. So that's the Sunflower experience in helping to meet this need. And the rest of my slides are there before you, and I'll be happy to stand for any questions.
Thank you, Michael. I appreciate that. Comments or questions of Sunflower?
Madam Chair.
Yes, Representative KanCare.
Thank you. Thanks for your presentation, Michael. Unfortunately, you're going last, so it gave me time to think of the question that I was thinking of the other day. So this should be a question for everyone. So I'm thinking about the vaccines and wondering what kind of billing guidance that you are providing to the healthcare providers that are out there. Yeah, I'll just let you respond to that.
Sure. So it probably won't surprise you, Representative Concanon, that that Jello is not quite set in the mold, that we're still learning about that and working with the state to collaborate on both a way of receiving and distributing the vaccines and the financial circumstances. So we don't have complete guidance on that yet with which to be able to share with providers, but we expect that over the upcoming weeks, we'll be able to figure that out together.
Okay, thank you. Thank you, Madam Chair.
Right. Further questions or comments? All right, thank you very much, Michael. We appreciate you being here with us today. And as I said earlier, the others for adjusting your schedules to move from last week into this week. So thank you.
My pleasure.
All right, committee, that includes all of the people that we had appearing before us today. So what I'd like to get down to, because I know some of you need to get to other events and meetings, is the discussion of recommendations for our joint committee report. I believe staff has something to hand out. All right, committee, have y'all got a copy in front of you? And has a copy been sent to, all right, so Representative Concanon, do you have it?
Yes, I'm reading it now.
The first half were the recommendations that we've already approved at our meeting last week isn't that correct, staff? Okay. So nothing would have changed with any of those. And then suggested recommendations that we need to look at today. And this doesn't mean it's the complete list. It's what staff was able to help me compile with the questions and things that were brought up. And then the last two there, I added those today, is recommend the legislature review how other states estimate caseloads. So what I'll do is I'll just ask for a yes or no on each one of these items.
Yeah.
Do we need to vote on them? We don't, do we?
Madam Chair,
Yes.
I'm wondering if we couldn't amend that to, I think it's appropriate the way it is, but would like, I'm sorry, would like to look at the possibility of reinserting the PACE program in those caseloads.
All right, this one.
Thank you, Madam Chair. I think that might be a separate issue.
Okay, we can make it in addition to a representative once we approve this one.
Okay, all right, thank you.
All right. Okay, all right.
And I can give background on it.
All right. All those in favor? Okay, I'm just going to call them. I see what is number 1, 2, 3, 4, 5, 6, 7. And if Representative Cannon, if you'll let us get through the ones that we have printed, then we'll come back to the additions. Okay.
Sure.
All right. So on item 1, all those in favor signify by saying aye.
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 Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. On item 2, recommend the K-Trax prescription drug monitoring program be funded through state general funds. Any objection? Oh, we need a motion, don't we? We're voting. Okay. All those in favor signify by saying aye.
Aye.
Opposed? Ayes appear to have it. Ayes do have it. Motion carries. Number 3, recommend nursing facilities be given the same immunity from civil liability provided to healthcare providers in 2020 HB 2016. The one question I had on that, and this is probably for Eileen, when we use the term nursing facilities, are we covering all of our facilities, the assisted livings, the home pluses, and Scott Bruner, are you still with us? Is there language that we can? Yeah, as defined by statute.
But some of them aren't licensed by state license.
Well, we're just recommending that we look at that to be given. We're not saying it will be done. So then you guys can all sort that out through in the, yeah. You got that by definition, so we'll move out nursing facilities. Questions, comments? All in favor, signify by saying aye.
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 Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Item 4, recommend the legislature address the direct care workforce concerns. Senator Petty.
So, should we be specific here, direct care, nursing home, workforce concerns? Right here,
Representative Carpenter.
No, Senator Petty, it's system-wide workforce problems. We see it. We've seen it from everything from substance abuse to behavioral health, mental health issues, with lack of psychiatrists, and also you just heard from the nursing homes, lack of even CNAs and that. But it's system-wide. It's kind of why it needs to be broad.
Yeah, one thing that's kind of interesting is that, we think of, rural Kansas,
sometimes having the shortage and the disadvantage. But I can tell you that when we did, was the first year we had the mental health pilot program, we were not able to staff at the level we asked in Topeka, Kansas. And that just, you know, so it's a shortage in the whole healthcare industry, and I think that's what he's trying to say. Does that help? Yeah. Representative Bethell.
Thank you, Madam Chair. I had a similar question because of just that last testimony. It's amazing she got through it that way. I heard at any moment she was going to. But could we mention, if recommended legislature address system-wide, I mean, if we could put in system-wide so that includes anything without saying, for example, because then we'll leave out somebody and then they'll be really annoyed because we didn't cover them. But if we could say system-wide, then that's, I think they would see themselves in that.
It is.
In healthcare.
Yeah.
Yes, healthcare.
So, Madam Chair.
Representative KanCare, go ahead.
So does, do foster care issues, are those social workers, would those be included in healthcare?
I think the socials workers would, I'm not so much sure about, well, not so much with the families, if you're thinking about that, but the social workers would be covered under this because you've got all different levels of social workers that are clinically licensed, et cetera, et cetera.
Okay, thank you.
But it seems that maybe we do need, I'm afraid we're leaving out something. First of all, the word concerns, I don't think we need concerns because what is concerns? You know, I mean, just the fact that it's in the workforce, but whether it was nursing, what she said is foster care, whether it is anyway, but I'm just trying to think.
Maybe issues.
Issues is better than concerns.
Because you're looking at the shortage, you're looking at the possibility of licensing, pay, you know, there's a whole bunch of pieces out there. Because we know the pay's been an issue for a long, long time. And I know we've already talked to the BSRB on some of the social worker stuff. So, yes, Eileen?
Madam Chair, for clarification purposes,
Or Eileen, just a moment. Sorry.
No, I just want to make sure that we read it back because I wasn't sure how it was worded. I'm sorry.
Madam Chair, just for clarification purposes, then it might be better to use issues such as, and then kind of spell them out because people who read the report who aren't as familiar with the concerns or the issues as the committee is, would be able to kind of follow along and be cognizant of what's going on.
And then that way you can put in nursing homes, what are the other concerns, foster care?
Then we leave somebody out and we're in trouble. That's what my problem is.
That's why she said like it's going to be training, pay. Just the issues would be training, pay.
Licensing.
Yeah, such as
Sir, reminded to turn your microphones on when you are talking.
Mine's on.
For everybody else.
You gotta eat it. Oh, everybody else, not Barbara. Barbara's just she's not eating it. You're not eating it.
Get off me.
No, you're not eating it.
No, I don't plan to.
You are here on her report.
Because you're not close enough to the mic.
Well, she's the one who was speaking in the mic, so I don't know why she's talking.
Representative Ballard, we can't hear you or Senator Petty so far. And I don't want to miss a word.
All right, children, stop. Okay, so you ladies have some more.
So we have recommend the legislature address the system-wide workforce issues such as, and then we can add examples like pay concerns or pay, licensing, safety,
shortages.
This is what I'm worried we end up, because there's so many little
That's
pieces.
why I said, so we might leave them out. Are we taking out direct care workforce? Are we taking that out? Because I didn't hear her say direct care.
No, direct care comes out.
I was replacing direct care with system-wide, but we can include
Yes.
it. And the such as is not I mean, it's not a limiting term, it's just providing examples, so.
Well, we might verify it's an example.
Yeah.
I'll know that there's, okay, that works.
For example,
Right.
Everyone clear? As mud? All right, all in favor signify by saying aye on number 4.
Aye.
Ayes appear to have it, ayes do have it, motion carries. Item number 5, include a statement that the legislature should look at the charges nursing facilities incur when temporary staff must be used to meet workforce needs. Questions, comments? All right, seeing none, I shall call for a vote. All those in favor of line item 5, signify by saying yes.
Yes.
Opposed, no. Ayes appear to have it, ayes do have it, motion carries. Item number 6, recommend the legislature work on integrated care, coordinating general and behavioral health, which includes mental health, substance abuse, and primary care. And that should have my name by it. She was typing it up for me during the meeting. Questions or comments? Senator Petty.
I'm just wondering, could we use as an example the project that's in Northeast Kansas? You want to say the right place?
The one here?
Is that one care? Representative Renee?
The facility is Community Health Center of Southeast Kansas. The contract they're working under is under the MCO's One Care. The specific example they gave was attached to United.
Yeah, so I think this kind of covers what it is that we're talking about here, to highlight the integrated care that carries forward from the mental health side, because we also heard from some examples from Washington.
I was just
they offered up
recommending that we include mentioning the project that has federal funds here in Kansas, and that would be the One Care.
Is that Representative Merman? Is that One Care with the 4-county CCBHC that they got out there?
No, I believe that's a different situation. Just a quick reminder, One Care is a pretty small thing. When we passed that a few years ago as a proviso, we didn't have much money attached to it. And that's the one that defines special populations. So we talked specifically about behavioral health and asthma. And so back in the day when we had health homes, this is like a mini version of health homes back in the day. So health homes are a vehicle to get to integrated care in theory.
I would have to agree with that. And I think that's two separate issues.
Oh my God, somebody write that down.
I think I can count on one hand, Representative Merman.
You're gonna miss me, you know it.
We're increasing those numbers. Because that's a different issue than the CCBHC issue. Marissa.
For clarification, yeah, the 4-county mental health center, there was that SAMHSA grant for the CCBHC.
So we're not talking about the same thing. That wasn't integrated care.
Can I offer that integrated care, what we heard about from what's happening at Tri-County 4-County and Indy, is a integrated care with a lowercase I and C, just like we're talking about, but their funding source was through a different funding source. So I think if we, with the recommendation, the bigger picture is really how do we align the system and support the system to ensure that an individual person can have access to integrated care as defined by healthcare and behavioral health care. Right? That's what you're getting at, Representative Landwehr?
Yes, because it's, because I pulled the language, and I believe if I go back through my notes, I think that came from SAMHSA on their sheet was, making certain we come in and clarify that
It's coordinating general and behavioral health, which includes mental health, substance abuse, and primary care.
Madam Chair, I have in my notes that the Community Health Center Southeast Kansas also included dental and pharmacy.
Correct.
Do we wouldn't consider that primary care. Do we want to include that?
We could say healthcare. And dental and pharmacy fall under that. But I think too, the primary, sorry, I'm just talking now. Primary care is oftentimes the vehicle to get it done, right? Somebody comes in for a sore throat and you find out that they're depressed, right? So.
Or they need dental services and that's why they're not feeling well.
Yeah, exactly.
You're in trouble. Yeah, I think we just leave it like it is here right now because, you know, we can always dive into the weeds. The thing is, when we get into that committee process, then that's when the whole bag gets opened up on the table and we do dive into the weeds. Are we good with the language now? Okay. All right, vote on everyone in favor of item 6? Aye.
Aye.
Opposed, no. Ayes appear to have it, ayes do have it, motion carries. Item number 7, recommend the legislature monitor the financial stability of long-term care facilities in Kansas. And I brought that one up because I have a great concern. I think that we also heard that today, is that we may see us losing some of our facilities over the lack of funding, the lack of several things, several reasons with the COVID stuff. And we want to stay on top of it so that hopefully we don't end up in receivership of several homes again. Questions, comments? All right, vote on item 7. Recommend item 7. All those in favor signify by saying aye.
Aye. Aye.
Ayes appear to have it, ayes do have it, motion carries. And then the last one I've got, which is not before you, and this was, you heard me kind of mention this to, I believe it was either David or Michael, one of them from our MCOs, is for us to monitor and report the increased expenses of HCBS service waivers provided for school-age children because of school being remote.
What, Representative Landwehr, sorry, what was that one? Is that on the paper?
No.
We have an increase in the usage of, and it's an expense on our HCBS waivers because of the children that when they're in school, they're receiving services.
Great. And so what was your recommendation? I'm sorry, I missed that.
That we monitor that particular expense because I think it's Appendix K, so it shouldn't be hard to take and monitor. And then see if at some point we can't go back to the feds because I believe there's some federal matching with the special education money in the formula. Now, the way the formula works, if the services are not being provided at the school, they're probably not getting any funding, so that's not the issue. But there may have been some federal match in there that we could maybe go back and recoup later with the federal government. We just have to try.
Madam Chair, I believe that, didn't Ashley, who was it that spoke the day before last time we met on this? Didn't she say they withdrew the Section K amendment?
Yeah, they didn't withdraw it.
What did she report? That was when she was cutting out and I missed it. I thought that she said they withdrew. Was it the waiver on Section K?
No. No, they were already doing it, and then they just came in and told us about it. Actually, it came in by accident because I think it was a KDAD's decision, and the information came in through KDHE, I think. Yeah, when they did their report. It's not like it's not that we're saying it's bad or that it's wrong. We got great clarification last week on this issue, so. You know, just something for us to kind of monitor. There's going to be a lot of issues facing us next year that, you know, we think that it's been unusual this year. What do you see the issues that happen this next year?
I guess I misheard her the other day because I thought they were saying that that is no longer, they are not doing that unless an individual child, after Bert's recommendation, an individual child it may be appropriate for. So you're asking for those individual situations to be added up in totality to be monitored?
Well, I believe that, let's see, I believe it was Sunflower that had that in their testimony. He said that they had about 1,000 children. And we didn't ask that number from the other MCOs. Yes, if you look on page 6 of the testimony from Michael Stevens with Sunflower, AC services for children in school. You know, in schools, it's not that they're in school, they're out of school. So what they would have been receiving in school while they're being taught remotely is now being provided in their home. Under the Appendix K on our federal waiver.
But it was specific to attendant care, correct?
Not all of it.
Yes, he did say it was attendant care. Yes, he did.
But not all, I don't believe that all of it
He
is
said
attendant
1,000
care.
children, attendant care. He said specifically attendant care, yes.
But I don't believe that that's what the secretary said last week.
Well, this is what you're asking about Sunflower. This is specifically what he said, attendant care.
All right, what I was sharing with Representative Murnan was the fact that no, Appendix K has not been deleted. And so I was just confirming with that. I'm not arguing about what Sunflower did or Sunflower didn't do, but it's my understanding that we're providing HCBS services outside of just attendant care.
But that's not what he said. He said attendant care. He said specifically attendant care.
Well, that's on Sunflower. We didn't talk to Aetna, and we didn't talk to the United Healthcare. And I know in my discussions with Department of Education, I think it goes beyond that. So we want to monitor it so that we can check into it when we get back up here for the sessions, what it's about. And, you know, I'm kind of one of those anal people when it comes to number and it comes to facts. And the facts may come in January and we say, oh, nope, we really didn't need that. Okay, so then we move on. It's not about being opposed to it, Senator. We just want to keep it at the top of our mind so that we look into that as we're looking into our budgets next year.
I guess I'm having a little bit of issue about the budget issue of it all, because one thing you're saying it's there that Sunflower brought up this information for us today. We had a very extensive presentation on the 9th from the Department of Education, and so there's a difference between how the services and this, they were specific to attendant care, and it was attendant care.
You also have the issue, see, this is what wasn't clear, Senator, is the issue of IEPs. And that was brought up in the discussion with the secretary.
I don't know that we want to debate it, but I don't know that we really ever talk specific. I mean, IEPs is a totally different thing. Now you're really getting to educational elements, and we're talking about healthcare and the services that are being provided. And I think one of the things we've heard is what could be provided when they're in school and whose responsibility it is when they're not in school.
All right, yeah, just a moment. I believe it was the first time that KDHE made mention of Appendix K in their testimony, and the discussion that day was, and I believe this came from Secretary Howard, was an issue with some of the IEPs. I can tell you that everyone was a little bit confusion because the very next day I sat down with the Department of Education and they were like, we're not sure what's going on with that. Let's go find out. Now that doesn't mean the people down here didn't know, but the top didn't. And they had to go back and research that. So there's some confusion, and we're seeing that confusion right here, right now. Is it all attendant care? Is it IEP services? Is it the para? Is it the para that's dealing with the second language for a student? We don't know what it is. And we're going to need to sort those things out.
detailed on that way. I'm sorry.
I can understand you being in detail, but you're talking about some recommendations that you're also talking about conversations and information that you've gleaned or worked on outside of this committee. So I have a hard time having it be a recommendation from this committee when it's outside of the presentations within the committee.
I can tell you that with the testimony that I received in this committee, forget about my outside conversations, that there is a little bit of confusion. It was an appendix. It was never brought to us as, oh, here's what we're doing. It inadvertently ended up in the KDHD testimony. It was never in the DCF testimony or KDAT's testimony until we brought it to their attention, which the secretary was more than willing to do. Working with Secretary Howard is a positive thing for me. I enjoy working with her, and I feel like she comes to us and she lays things out straightforward. So I just felt that I have some confusion on it. I've had discussions with, Representative Carpenter, and I think he was kind of along the same boat. I chair health, he chairs the social services budget, so we want to take a look at it in this next session. If you don't want to look at it, you don't have to look at it.
I'm sorry, I haven't felt in my 8 years being in the legislature that I necessarily had that control of making those decisions of what I did or did not as a committee, what I look at. It was usually a consensus or made by the chairman.
I am the chairman.
Yo, can I get in?
No, you may not. Representative Ballard.
Even though I've been going back and forth listening to it, I still don't know what the issue really is. I mean, I don't see where I guess I can't see where it's a either or. And the more you guys talk about it, the more confused I am, because I'm looking at it, recommend the legislature monitor the financial stability. No, you're adding one.
It's not even.
Give me the wording again of how it was worded, because I'm not able to really look at it to know what really the issue is.
Yes, I did not. Oh, I know. Monitor and report the increase, I should put in there Appendix K, the increase in the HCBS waivers under Appendix K for services provided for school-aged children because of school being taught remotely. It's just something that I want to, as a legislator that is involved on appropriations, is involved on the Health and Human Services side, and then we have the chair of the Social Services Budget Committee. We have the ranking here as well. And I'd have to see who the other members were, that we just want to see it and look at it. We're not saying that we're going to do anything with it. It doesn't say we're going to change it. It's just something we want. It was a brand new thing that popped up. It's not something that the legislature did at all, or the legislature even talked about during the session. It was something that was unilaterally decided by the administration. And it may be fine.
So
there may not be an issue. We're just going to look at the dollars on it.
So we're going to monitor the financial.
That's it. Who did it serve? Were there IEPs involved? There hasn't been 100% clarity within this committee. You have it? What's it say, Dave? No, go ahead. We get one. Was it last week? Okay, in this here, in and I don't know if that's Scott Bruner or the secretary. Yes, they talked about the waiver participants because, the thing that wasn't clear when this first came up, and yes, you can call me a person that kind of wonders what's going on when the first time you hear about something, they can't explain to you the decision that they made that's worth millions of dollars. And they could not do that day when the Appendix K was brought up in the KDHE testimony. And then they came back and they said, oh, no, it has nothing to do with the IEPs. And the first time they talked about IEPs. Well, you're right, that's a different story than someone that's on the waiver. So it's clarification on what's being spent on this, how is this working, does it have anything to do with IEPs? Is it only the normal waivers that are triggered like at Christmas time, vacation time, Thanksgiving vacation time, probably spring break, those type of things for these students? And there's a cost to that. There's an SGF cost to that. And there's nothing, you know, and I do not know detail enough of the K-12 finance formula because it is so complicated. If there's any, you know, federal piece in there or whatever that we could, you know, maybe go back to the feds at some point and recoup some funding on that. Those are special, you know, those are special education because those services are provided by the school, not by us during the school day. They're not under, even though they're HCBS waivers, those are not used from less than 8 to 3 for school. It's only when the kids are out. And then some of them, it has to do with the services they receive while they're in school. And that's where the issue about the IEP. So I am confused about IEPs versus it being the regular waivers. And I just want further details on it. I don't know why it's an issue just to want information. I'm not recommending that we take action on anything outside of, let's gather this information and look at it. And it may be we look at it and we say, okay, it's a non-starter. But it's not in our normal budgeting, period. It's just not in there. Senator Payne, excuse me.
Thank you. I guess I would just disagree. I thought we had clarification from Department Ed last week.
Well, then I'm just not understanding.
Second.
Well, we're not doing the first and seconds. And we don't have to all agree with that decision. It's just up to the vote and then that's the way it goes. But we're just looking at it. I'm not triggering anything. I'm not making anything. This is the one thing about Brenda Landwehr. What you see is what you get. What I say is what I mean. I don't have the patience, the tolerance, nor the desire to play stupid little games to say, hey, read between the lines. There is no between the lines with me. Would you agree with that, Rosie, about it? All right. So there's no game, there's no mystery in it. It's not a trick for anybody. I take very serious the job that I have to do up here, and that's dealing with numbers. Because when I get into the K-12 budget, if I'm still on that committee, then I've got to know what's going on. I got to know when I'm sitting on appropriations what's going on. Is that good? It's still not good. You still don't like it?
That's correct.
All right. Everybody doesn't have to like it, and I get that. I understand. Well, maybe I don't understand. I better not say that.
Representative Landwehr?
Yes, Representative Marianne.
Thank you. So I feel like we did get this clarified. My only concern is we've been talking all day about supporting integration. And what the waiver would have done is support integration by allowing some codes. And then we could do, once you got the codes, then you could do the fiscal impact on it, right? And so the fact that they didn't submit the waiver, I felt like that it was clarified this week that we were talking about a very small group of children who, based on Burt Moore's interpretation, their families chose not to have the kids come to the least restrictive environment. So what I thought I heard was it's just a small group of kids, it's a possibility, and that in theory, the MCO care coordinators would work with the school district to determine the usage of that. My concern is that this is going to require a lot of new type of tracking for them that they don't currently do. And I just think it might be an increased burden on a system that is essentially pretty small, and totally get that we want to make sure there's not something bubbling up that creates a great big financial oh no, but it just seems that it would be really, really hard to track down which kids are receiving virtual services and then also getting an HCPS service. I mean, that would take like literally going through individual plans. So that's my concern. And that's why, with respect, I don't think I can support this one.
All right, and I understand that, but you do understand, Representative Merman, that Appendix K was submitted.
No, I'm sorry, I didn't. That was when Amy's, she was cutting out. And I'm sorry, I don't really know that, but you're saying the waiver for the ability to bill HCBS services during typical school hours was submitted.
Yes, when the child is not in the school building.
Okay, and so sorry, that was when we couldn't hear her on Zoom.
Oh, okay.
And so this was Amy Penrod, correct?
Yes, and then
okay, yeah.
Clarification from Amy, Secretary Howard was giving me the nods and a thumbs up that I had finally figured it out. And my still question, the IEP piece, because there was some confusion with it. And as we heard Michael Stevens with the Sunflower, he said that those kids are tracked separate in their system. He knew it was 1,000 kids. And he referred to it as an enhanced benefit to the current package, because it would be. It's an add-on to our Medicaid plan.
Attendant care? Or what is an add-on for the 1,000 kids? That's what I'm sorry, I missed that part.
He used, I believe, the word attendant care, which Senator Petty pointed out. But there's confusion from last week, well, from the very first time it got brought to us to last week and others. And maybe everybody else in the room understands it, and perhaps it's just Representative Lammer that doesn't understand it. But I'm just asking for it to be tracked so that Representative Carpenter and I make sure that we keep it on our radar and we take a look at it this next legislative session, because we use this KanCare report when we're working budgets and stuff. It's just to look at it. It's not to be, I guess I don't understand why everybody's upset wanting to just take a look at something.
I wouldn't call myself upset. I would just say I have concerns about the level of work that we're putting on some folks at the school level and at the HCBS level right now. That's all.
No, I think it'll come from the MCOs.
I would say they are not going to be able to know that without an IEP, seeing an IEP and what services are provided. So that, I mean, and maybe that's just because I've lived in this world and I've gotten these calls before. So again, all due respect. Thanks for letting me talk.
That's fine. Shall we vote? All right, all those in favor signify on the new item, which is what, 8? All those in favor signify by saying aye.
Aye.
All those opposed, no?
No.
Okay, 2 noes. Ayes appear to have it. Ayes do have it. Motion carries. Is there any other additions that anybody's got? Did you have one? Senator Petty. No, I'll go to you first. He says ladies first.
Well, I think it is relevant that we have something in the recommendation concerning continued use of the enhanced or the CNA pathways that are available now through virtual.
Well, I don't think it was just the CR or the CNAs. Tell me that there might, I don't know that we heard about this maybe on some LPNs. I think it's probably.
It was CNA pathways was specifically mentioned by KHCA.
Okay, do we want to put it with just the CNAs because of the testimony we got on that, or do we want to put to take a look at the expansion that was done within House Bill 2016, which allowed APRNs, it allowed CNAs, it allowed AAs, it allowed nurses, and I don't remember at what level, you know, if they were coming out of school, that they could go ahead and go right into work, you know, if they were monitored and those types. There was a lot of releasing some of the regulatory things that we have out there. that prohibits some of these actions in House Bill 2016. And then that would cover all of those services, because I think they're all going to get looked at. You know, just like telemedicine is going to get looked at in more detail this next year than it probably would have if we had not expanded it like we did during this time and released some of the regulations and things on it. That's why I said earlier is we've already talked to the BSRB, and you know that the Board of Healing Arts is looking at some things, and then we have the nursing board looking at some things on what was put in 2016 that we would maybe want to make permanent with all these healthcare providers.
So I kind of lost you along the way there about what you're saying in place of what I mentioned.
Well, expand it beyond just the CNAs.
So the healthcare field, I mean,
Well, we could say that the expansion of, and I don't know, the expansion of I don't know, it has to do with releasing the statutory and the regulations and the licensing and everything else in 2016.
well, so it was mentioned about they're working on a program with KDA to do training online and do a site training where they are at. That was specifically mentioned about the virtual training for CNAs and that.
Or nursing homes. It'd be only for nursing homes.
Right, correct. Well, that's what we listen to often in nursing homes. And so that's what so I'm talking about specifically with nursing homes. And that they are being allowed to do their, it's an exception right now, but they're being allowed to do their training where they are at instead of having to go someplace else for hours. And so
I think it's something we could say we could look at, because I can tell you that, you know, I was a little bit nervous with the idea that it was being done virtually, and I guess maybe once I saw it, you know, I would have a more comfort zone, because there's a reason that we had in our healthcare that they do hands-on as part of their, you know, I don't know in all the fields that they call them practicums, but that's what I call them. There's a reason that they do that. So I don't know how well the virtual training, you know, is. It may be sufficient, and that may be something that they decide to move with on but we can make mention to look. I don't know that I would recommend that we do that. I wouldn't be comfortable recommending.
Chair, Madam Chair.
Yes, Representative Kincannon.
Wouldn't this fall under workforce issues?
Oh, that's a good point. I think Senator Petty would want to kind of highlight it, right? Or you find
I don't disagree with her recommendation, but I just think that the education stuff is absolutely something that would be addressed when we talk about workforce.
I would agree it goes, it would fall under workforce issues.
That was in number 5? Yeah. 4. Okay. I don't have a problem adding it. I just don't want anyone to feel like they're, you know, people come in and say, well, what about the NPRNs? And what about the CNAs? And what about the AAs? Like I said, I don't know if LPNs were included in some of that stuff.
Well, and we had done such as under, I think, number, which one did we do such as? Under 4 as well. Is that correct? You could amend that and add virtual clinics for CNA courses. As we're talking about workforce concerns. Or not. Oh, wait a minute. Okay, wait. Now let's look at number 5.
Look at the charges, nursing facility, no, that was the charges that didn't have anything to do with it. But it must be used when temporary staff, that was a different issue, I'm sorry. It's 4, yeah.
Right here. Number 4, where we had recommend the legislature address the system-wide workforce issues. And then we had, for example, safety, shortages, pay, just add education. Or education and training.
Yeah, education, training, what, licensing. That's fine, okay. Well, if you want something different, then I'm not telling you no.
I think part of the issue was that that we heard today was the virtual, that they were able to use this, do virtual training for CNAs and how it's working well. Not just that, I mean, it was also mentioned about being able to work in-house, but the virtual training. So,
and there might be, they may be doing that in some of the other areas besides just the nursing facilities. I don't know. That's why I want to cover them all. And we can talk about, somewhere in there, or Ida mentioned that, there's been some virtual training with, we can talk about the education training. An example of virtual training of CNAs for nursing facilities. Does that help, Senator? We need to go back and revisit 4 and make that addition to the vote. Staff, no, that motion would be to. All right, Reese, have you got it written down what we're going to put in there? Or you still figuring it out?
What I have is recommend the legislature address the system-wide workforce issues, for example, safety, shortages, pay, education, training, and licensure. As an example, virtual training or CNAs by nursing facilities. System-wide healthcare work.
So do we have to delete that one and then come back to the new language, or we just go in and make a modified? Okay, so we're going to do the modified language on this. All in favor signify by saying aye.
Aye.
Opposed, no. Ayes appear to have it. Ayes do have it. Motion carries. Are there any other recommendations or additions to the report? Did you have something? Oh, I'm sorry, Representative Carpenter's report.
Thank you, Madam Chair. I would recommend that we support participation opportunities to expand the certified community behavioral health clinics, CCBHC model in Kansas. CCBH model provides an innovative, sustainable finance model of care delivery. The model is designed to provide a comprehensive range of mental health, substance abuse disorder services to vulnerable individuals. In return, the CCBHCs receive an enhanced Medicaid reimbursement rate, providing vital resources needed for the workforce recruitment and retention. There's currently one in Kansas. We urge the state to support movement of the CCBH prospective payment system expansion of the CCBH model when the opportunity presents itself. And that's kind of what we heard this morning. CCBH model.
You want all that wording in there, or would you like to have it short? Because I bet if you were to pull the mental health modernization report, see, that's why I didn't think about it being added, but that's where that language is at. Okay, that's what we had in there, I guess.
So anyway, we could just use this.
So just use that thing. Recommend the CBHCs. CC, I always forget the other C.
We call it the Texas model when we talk
Right, we felt Texas.
Washington budget. Certified community behavioral health clinic.
Texas model.
Yeah.
Well, because we didn't get underneath that mental health enhancement here several years ago, whatever that act was called, then there's one other state that's done something similar. And then we've got the pilot that's out in Fort County. So we're saying that we amend our 1115 in order to do it. And then we should get somewhat of an enhanced rate. This is for mental health.
And I think probably the big question is whether we can prove budget neutrality on it. And if we can, we can be enrolled in that program. But anytime you submit anything like that, it has to not cost more than the program we're doing now.
And this is what he just read with you, Reverend Ballard, is the recommendation that was also made by the mental health modernization that we had last year.
I've heard it before, but I couldn't figure out why it was here. And I just, we did that, but we didn't do that here. We did that in.
Right, because when he started saying, I'm like, no, we've already got it. And then I looked through the list, it's like, oh, it's not there. And I'm like, no, mental health, because we're both on the, yeah, it was the mental health.
Sorry, I'm trying to feel.
Well, it never hurts to have it in two places. Yeah. Make sure we get the point. Discussion, comments on the what Carpenters want to add, Representative Carpenter? Hearing none, all those in favor signify by saying aye. Opposed?
Aye.
Ayes appear to have it, ayes do have it. Representative Buchanan, I think you had an addition to.
Yeah, I mean, this isn't something that I had prepared. It's just when the topic of caseloads came up, I was referring back to Sean Sullivan testimony where he was asking to have PACE reinserted in the caseload numbers.
To look at adding the PACE back into the caseloads estimates. That's what that's what your motion is, and I think staff's working on wording.
Sure, thank you.
This is how we do it on the fly, and we look at staff, and it's like, you understand, right? And they look at it and they say yes, and then they type and they come back with the verbiage for us. Hey, don't be laughing. You do that too. Have you got something to read back to us, Marissa?
Recommend the legislature consider adding PACE program to the consensus caseload estimate process.
Yes.
Perfect.
All right. Questions, discussion? All those in favor signify by saying aye. Opposed? Oh, ayes appear to have it. Ayes do have it. Are there any other additions or recommendations into our final report?
Madam Chair.
Yeah.
Also, something I don't have prepared, but you mentioned telemedicine, telehealth. Were we going to make a recommendation for telehealth or just let that one go?
No, you're right. Yes, that's the problem that I'm struggling with. I think we've done something and we haven't because of the mental health. We could take the language that was a recommendation in the telehealth if everybody's in the mental health modernization committee. That was a recommendation on the expansion of telehealth, if everyone's good with that, and add that to one of our recommendations. A good catch, Representative Buchanan. Discussion, comments. Seeing, Representative Senator Hildebrand, I'm sorry.
I'm sure this is Representative Hildebrand, and I just was not on the mental health task force, so would somebody be able to explain what the telehealth portion was?
Just go with it. Staff, can you pull that report up? Or
Yeah, so the report is online. We can forward it up to you so you have it. This is not the most updated version because we did make some amendments on Friday to this report, but it will be updated. But the telehealth section, there's about 4 or 5 recommendations in this, asking to develop standards to ensure high quality telehealth service are provided. So that includes establishing more consistent guidelines for telehealth, ensuring patient privacy, educating patients on privacy issues, allowing services to be provided flexibly when broadband access is limited. We had a recommendation concerning reimbursement codes. So maintain reimbursement codes added during the public health emergency for telebehavioral health services. We had a recommendation for telehealth for crisis services. And then some more strategic ones about originating the distance sites and the child welfare system. So I guess the question for the committee would be, which exactly of those are we adopting for the Bethel report? Let's maybe clarifying that. So we had 4 or 5 telehealth recommendations from the Special Committee on Mental Health. I guess, which do you want all of those included? Do you want?
I think
There's one general one that we had.
I think, Representative Concanon, if you're all right with that, I think that we just take that from that committee. Then that way we're covering all of telehealth because it's still going to involve our MCOs.
I'm okay with that.
I have a question.
Add all of those.
Representative Vernon?
So what I think, did you just say there was a recommendation, or did you read what the recommendation was?
So these were recommendations that currently were adopted by the Special Committee on Mental Health Modernization and Reform last week on Thursday. And the report is something that I can get to the committee, but those were adopted in the committee last week in that special committee.
But what was the recommendation itself? I'm sorry if you said it and I missed it.
So there are 5 of them, and I can read all of them, but
I'd like to know what we're recommending, because if we're saying we don't want to recommend telehealth, I don't want to vote for that.
No. No. It is all 100% supporting. It was to the point, Representative Mergan, in the modernization committee, that we had to form a 4th working group just to address telehealth because all 3 of the working groups were discussing it. And we felt like we would end up in a bind if we didn't bring it under one committee and talk just telehealth. So what happened was there were 2 members from the 3 working groups, so 6 members, and then some legislators were on that to come back with a recommendation on telehealth. And what she's telling you, there's like 4 or 5 different recommendations because we wanted to clarify exactly what we were looking at out there on telehealth. So it's 100% recommendation to do telehealth. We just have to fine tune it. We can't just do what we've been doing under an EO. Was that EO or 2016? Whichever one it was.
It's a combination of multiple things, I think. But
no.
I'm with Senator Hildenbrand. I would just, because telehealth is super important to me, and it's anything we can do to improve that payment structure, the licensing structure, all of that. I'm for it, but I just kind of want to know what I'm voting on is all.
Right.
Can I look it up online somewhere?
Yeah, she was telling you can go in there and look up. It was last Friday. Now she said that we made some minor modifications onto the wording of that report, so the final one's not up.
But the recommendation language didn't change.
Okay, the recommendation language didn't change. So if you would pull up the
where you're going, or if somebody can throw it in the chat or something.
Okay, she's going to throw you a link, right, Marissa?
If you put it in chat, that would be great.
Representative Marianne, Representative Ballard, while you're waiting for that, I would tell you that I also served on the telemedicine, and we, in our working relationships, we developed anything around increasing pay to from location. If you were in Kansas, but your client went.
Okay, I've got him now. I'll read them. Okay. So about your location, where your feet are, if you get paid, that kind of thing.
All of that. So rather than choose between the 5 recommendations, we decided here that we're just gonna recommend all 5. So that even though you can cross-reference in mental health, but you also can do it with telemedicine through our committee as well.
Because there's a lot of things that need to be studied and fine-tuned in that, because there was issues brought up. There were some groups that wanted to come in with parity pay, and you know what happens with that issue. There was also a big discussion on what a facility fee means.
So are we talking Appendix A of KHI's report?
So I put in the chat the Roman numeral pages of the summary of those recommendations. It starts recommendation 10.1 are the telehealth.
Thank you.
I try not to touch it. Are you okay now, Representative Moran, or you, or Moran, Murray? Monica Moran.
I guess so. I can't find it, but I guess so. Yeah. I'm looking, but it's a big old report. So
Well, and you know,
it's okay as long as it's positive.
oh, it's one, there was no negatives in that whatsoever. And I think that we covered, you know, pretty much every detail. If we didn't, I can guarantee you that all the legislators that were involved with it, Elizabeth, Representative Bishop was one of them that was also on there. I don't remember who was all on it. It was a big committee. Yeah, Dr. Lawrence was on there. Yeah.
Yeah, move on without me.
Okay. All right. Marissa.
I mean, if you want me to, I can read them. They're not terribly long, but I just didn't want to.
Well, that'd be lovely.
All we do is for Representative Vernon.
And Senator Hildenbrand.
No, just for you, Monica.
So for
First.
5 recommendations under telehealth, recommendation 10.1, quality assurance. Develop standards to ensure high quality telehealth services are provided. This includes establishing consistent guidelines and measures for telehealth in collaboration with licensing and regulatory agencies. Require standard provider education and training, ensuring patient privacy, educating patients on privacy related issues, allowing telehealth supervision hours to be consistently counted toward licensure requirements, allowing services to be provided flexibly when broadband access is limited. Recommendation 10.2, reimbursement codes. Maintain reimbursement codes added during the public health emergency for telebehavioral health services and consider options to prevent loss of facility fees so that providers are not losing revenue by delivering telehealth services. Recommendation 10.3, telehealth for crisis services. Establish coverage of telehealth for crisis services to allow for the use of telehealth with law enforcement and mobile crisis services. Explore virtual co-responder models for law enforcement to aid police departments and other law enforcement agencies as they respond to mental health crisis in rural and frontier communities. Recommendation 10.4, originating in distant sites. The following items should be addressed to ensure that individuals receive and providers offer telehealth in the most appropriate locations. Adopt a broad definition of originating site consistent with the Kansas Telemedicine Act. Allow staff to provide services from homes or other non-clinical sites if patient privacy and safety standards can be met. Examine issues related to providers practicing and patients receiving services across state lines, such as exploring participation in interstate licensure compacts. Recommendation 10.5, child welfare system and telehealth. Utilize telehealth to maintain service and provider continuity as children, particularly foster children, move around the state. Consider how the unique needs of parents of children in the child welfare system can be met via telehealth.
Thank you so, so much. I wholeheartedly support all of those.
Say, I told you so. All right, is there further comment or discussion on the addition of the telehealth language? Seeing none, all those in favor signify by saying aye.
Aye.
Okay.
Opposed, no. Ayes appear to have it, ayes do have it, motion carries. Is there any other recommendations or additions to the report?
Madam Chair.
Really? Yes.
Yeah.
Representative? Go ahead.
Can we make a recommendation to KDADs? Okay, this is what I'd like to say, that KDADs recommend KDADs adjust rates annually for PACE as currently occurs with the 3 MCOs.
I would recommend, I think that'd be better for us to recommend that be looked at as a possibility. I want to be real careful about us recommending something that's going to cost us, that probably has a fiscal note on it, Representative. Because we can definitely look into it. I don't disagree with you. But I don't want to say we recommend that they do this. We recommend that this be looked at as
yeah. Okay, I'm good with that.
All right. You good, Marissa? All right. Any more discussion, recommendations on, or questions on what we just heard from Representative Concanon? Seeing none, all those in favor signify by saying aye. Opposed, no. Ayes appear to have it, ayes do have it, motion carries. Any other recommendations, suggestions, ideas to the KanCare Oversight Report? Speak now or forever hold your peace till next year, when Senator Hildebrand will be the chair. All right, I want to thank staff and I want to thank all of our members that stuck through this, those that zoomed in and those that came into the meetings for all the hard work on this. I appreciate the opportunity to be your chair on this, and we are adjourned.
Thank you, Madam Chair.
You're welcome.